नहीं नहीं पहली स्लाइड हुआ पहली स्लाइड We will move on. It's 10:30 a.m. I am Dr. Lalit Verma, and I happen to be the Secretary General of South Asian Academy. And on behalf of SAO, I welcome you all to this one-day program. The theme of the program, which I have kept, is primarily tips in practice. Tips in practice. Obviously, you can't cover the entire ophthalmology, but we chose 3 hot topics which I think a lot of ophthalmologists use drugs for this according to their own choice, sometimes non-scientifically, sometimes indiscriminately also. Like in OSD, lubricants or anti-glaucoma, a lot of people do not understand and they may, irrationally prescribe some medications. And you do come across prescriptions even by the top authorities, one-page prescription written down for common diseases. Nowadays, conjunctivitis session is on, and you have so much prescriptions. Anti-glaucoma also. Same is true for anti-VEGF. So these 3 subjects I thought are burning topics, and today in the 5 sessions which we have planned, we will listen to the luminaries, discuss, debate, and try to learn about these things maybe in a more rational way. So, thanks to our sponsors, which are listed below, who have helped us in arranging this program. So, this is the session number 1, which will be on OSD, and we have Dr. Ritu, Rishi, and Aditi, and Rajesh with us, and we will talk about these topics. Session 2 will be primarily on glaucoma medications and surgery, which hopefully Harsh will be there along with Vishnu. Bhalla is already here. Then we have anti-VEGF agents. So I broadly divided conventional anti-VEGF agents, which all of us have been using for decades. Then newer anti-VEGF agents have come up, which promise a lot of efficacy as well as safety, but there are issues all of us know and understand. So this is one newer anti-VEGF and this is another newer anti-VEGF agent. So we will try to, this is one platform, all the anti-VEGFs we will try to cover up, so that we know what to use when and why, where and how. So with this small introduction, I will now request the chairperson Ritu and Rishi to take over and start this session. Thank you so much.
Thanks, Lalit, and good morning, everyone. I think very aptly named, this is a tips and practice session. So the first tip I'd like to give all the speakers is to cut their talk down to 4 minutes instead of 8. And the other trick that we're going to play is to try and finish this session before time, which is only possible if everyone puts his talk at 4 minutes. So I'd request the people who are putting the timer on this system to put in 6 minutes. Let's give them 2 minutes grace. ठीक है ना? So we'll cut straight to the chase.
Yeah.
Rather than giving us the pathophysiology of allergies.
That's anyways not there.
Great, excellent. So the first speaker, of course, is Rajat. Needs no introduction. Let's start.
Yeah, good morning, everybody, and thanks, Dr. Lalit, for reminding me here. Can I have my slides, please? So the topic for today and the theme for today is tips in practice. I'll be talking about chronic ocular allergy, and in the whole presentation, please make a note of, how does this work? I don't know if it's coming. So in all of the presentation, you have to look for these stars. And wherever these stars come, these are the tips which you can take home in your clinics. So many thanks to my teacher, mentor, guide, Dr. Sangwan, who has been always there with me for my as my teacher. And a lot of the photographs which are there in this presentation were taken when I was doing my fellowship, and they are still relevant, and you will know why they are relevant. So what we'll highlight today is why what I'm talking today is important. We'll talk about the non-routine clinical features of VKC, the management pearls in VKC management. In case of steroid responders, how do you manage them? The routine complications and the specific management of those complications. What is very important, and this is tip number 1, please do a optic disc examination on the first visit, because you usually tend to miss them when the patients come to you in follow-up. And because these patients are supposed to be on immunosuppressives and immunomodulants, the optic disc examination is very important, especially steroids. So why is this important? Because we are living in an area where there is socioeconomically, geographically we are in the area tropical region where this disease is rampant, both in the world and in the Indian context. Clinical features we all know. I'll not discuss the routine features. I'll discuss a few things in specifics. So this giant papillae, they are like very common in patients of VKC. Before the giant papillae, you see this stingy thread-like discharge. This is very, very classical of vernal keratoconjunctivitis. You invert the upper lid, you see a lot of giant cobblestone-like papillae. They could be pleomorphic. They could go as increased. The size could be as high as 8 mm. They have a thick tenacious discharge, and they could be so massive that they could lead to a ptosis. This is my second tip for the day. You should always stain the ocular surface and also look for the staining of the upper lid if you feel they are active. And if they take up stain, that means that these are active and you should treat them appropriately. So staining the papillae, especially the upper surface, is very important. Tip number 2. Tip number 3. In chronic VKC cases, the upper tarsal undergoes fibrosis, and you might not see proper cobblestone formation. So even if there is not a cobblestone formation, but the patient has a lot of allergy, please look at these kind of signs, and if there's fibrosis there, cobblestones would not form, but this still is an active VKC. Tip number 3 here. Tip number 4. This is a chronic VKC. You see the limbus, that's fine. There are elevated excredences, there are horner-trantra spots. Limbal thickening can be seen very well. What is important to note here is this kind of a subconjunctival pigmentation, not subconjunctival pigmentation, and this is very classical of VKC. Now when you treat this patient, the limbal inflammation will go down very easily, but this conjunctival pigments will take a lot of time to go. So if a patient comes to you of VKC who is in remission, does not have allergy at that point in time, but if you see these kind of conjunctival pigments, you can make out that this patient has had a chronic symptoms and chronic problems, and treat them accordingly. Again, various forms of limbal inflammation. These things are very common in our areas. If we are living in the belt of VKC, please make a note of this. Tip number 5 is VKC can happen in 3 areas. We have 3 areas of conjunctiva: the bulbar, palpebral, and limbal. Limbal VKC is supposed to be the most severe form because it has long-term ramifications. Chronic limbal stem cell deficiency can happen because of limbal stem cell inflammation. This is an article published in Asian Pacific Ophthalmology journal, which told us years back that chronic limbal stem cell deficiency is a very common thing in VKC, and it's very hard to treat. Management principles, will not go in this. I'll go to tip number 6 straight away. You should always remember, ocular allergy is not only an ocular phenomenon, it's a systemic disease. Please don't hesitate to give oral steroids. I'll tell you why in the subsequent slides. And always treat the patients with prednisolone 1%. In my experience, dexamethasone, the prednisolone has better results as compared to dexamethasone. So next is, because we are dealing with chronic cases, we are giving patients steroids for long term, you always end up having steroid responders. A study done in SNEC told us that out of 145 patients, 28.3% have had a response, and of those 5.5% progressed. So what, obviously, if it's a chronic disease, you will have a longer duration of corticosteroid use, you will have a topical which had a high risk. In their study, dexamethasone use was increased with a high risk of having a steroid response with the odds ratio of 2.25, and it was found less with other steroids. What was also found was in a mixed type of VKC, chronic VKC, and in those with corneal involvement, the chances of steroid response were high. So what it tells you intuitively is patients who had more severe disease had more chance of steroid response. That's obvious. Therein came the role of tacrolimus. There were multiple studies of tacrolimus which were published. So tacrolimus gives very good results when used one time in long-term cases. My tip here is Tacrolimus comes in two kinds of preparations. One is paraffin wax based, one is a gel based. When initially the tacrolimus came, it used to come in paraffin wax based ointments. It used to cause a lot of stinginess and burning because it was a skin ointment. Nowadays we have a lot of tacrolimus which comes in gel based preparations, and they cause much less stinging, they have less concentration, and they are more apt for the ocular usage. So you should be using this. Tip number 7. Now we go to complications. So there are palpable form of VKC which can lead to GPC and shield ulcers. Limbal form, as I told you, can lead to limbal stem cell deficiency and acute high drops. We'll discuss them one by one. Tip number 8, as I told, thick GPCs with mucoid discharge in between. These are active papillary conjunctivitis, giant papillae, and they should be treated very, very aggressively. How do you treat them? Topical steroids obviously are the mainstay, but obviously always give them systemic prednisolone. It works wonders in patients with GPC. The indications of surgical intervention, by surgical I mean insertion of the triamcinolone drug in the UTC, are presence of corneal erosions, lost follow-up if you think that the patient will not come to you, and the presence of shield ulcer. The options are, ma'am, I'll take 30 seconds more. So this is the area where you inject. No need to explain this to this audience. What you need to know about shield ulcer is they are usually present in the superior half of the cornea, and tip number 10, they are primarily non-infective. What we see in all the prescriptions coming to us is that patients of shield ulcer are bombarded with a lot of antibiotics. I don't think all those things are necessary. You need to treat the primary cause, and then this thing takes care of itself. The probable mechanisms of shield ulcer are the rubbing effect and the chemical problems. Chemical problems are because of the active VKC. Grading, I don't think we should discuss here. There are different treatments available for the grading. High dose steroids should be given in all cases. My last topic for today, acute eye drops. So acute eye drops, why does it depend? Because of why does it happen? Because of frequent eye rubbing. There are breaks in the endothelium. What I need to remember today, what I need you to remember today is this, tip number 11. Whether you inject C3F8 or you don't inject C3F8, multiple studies have shown that the time of resolution might be different, but the ultimate visual acuity is the same. And this has been published very illustratively in this journal, in this article, if somebody wants to read it. Second is, article published by Dr. Namita Sharma's group told us that you should inject only when you can see where you are injecting. Otherwise, the air can go inside the stroma and then can cause further problems. I'll end up with 2 cases. Can I have 30 seconds more, sir? 2 cases finally, please. So there was a 13-year-old boy came to me from Uttarakhand. This was around 10 years back. He was a known case of VKC, was being treated there for about 5 to 6 years in his hometown. This is his picture at presentation, right and left eye. Right eye had a Kmax of 59.3, vision of 636, but was improving with RGB to 6/6. Left eye had an acute eye drops picture. So what we did was, we did nothing. We waited, we treated the allergy, didn't do any surgical intervention, and 3 months later there's the same picture without doing any intervention, and then we again gave the patient RGP and the patient's vision was 6/6. So what I am telling you here is, you might not be lucky always, but if the scar is paracentral and the central area is spared, you can just get away by not doing anything. Final case, limbal stem cell deficiency is a chronic problem which can happen in a lot of patients. I'll skip and I'll go to one case. This patient presented to us when I was doing my fellowship in 2002. He was an 8-year-old boy, had a history of VKC for 5 years. This was his presentation on ocular surface images. He underwent allogenic slet, and then after this course, in the next 5 to 7 years, he underwent 13 limbal stem cell transplant procedures. What I am highlighting here is the main aim of doing so many transplants and so many allogenic transplants was because he was in those age group, he was in the embryogenic age group. So what we needed to do was prevent his amblyopia, and then when it recurred multiple times, ultimately the patient ended up having a Boston K-Pro and maintained his vision at least till I heard about him last. That was in 2016. So all these things are required to be done in these cases. These are chronic cases. Finally, take home message, VKC is not a surface allergy, it's a systemic disease. Please don't hesitate to give oral steroids. Tacrolimus, I use it rampantly now for the past 3 or 4 years. The goal of management is earliest steroid-free remission and the prevention of complications. Shield ulcer is not an ulcer, please don't hesitate to give steroids. Limbal inflammation is an emergency, please treat it. Acute eye drops is not rare, it's fairly common, but treatment gives good results, and intracameral gas good results, but you should inject them only when you know where you're injecting them. It is not supposed to be used in all cases. Thank you.
So any question? So I just have one doubt. Do you consult an immunologist?
So if the patient has only a VKC and there are no other signs of allergy, I routinely didn't used to do it. But now we have a very good, I'm again no commercial interest here, Ritin's wife is a very good pediatric allergy specialist. She's studying in Gangnam or wherever. So now I send a lot of my patients to her, and a lot of my patients come and tell me that they are benefiting from the systemic immuno treatment. I didn't have a concept earlier 5 years back, कि ऐसा भी होता है, but now I do send them and it really helps.
Thank you.
Quick question.
Yeah.
Any role or experience with cyclosporin?
Okay. So this question of cyclosporin comes a lot because nowadays they have come up with a new compound also of cyclosporin. I'll tell you my experience in this. So my thought process is that thing which cyclosporin does, tacrolimus does the same thing in a much lesser cost and a much lesser dosing. So for me, tacrolimus works wonders, and now gel-based ointments have come which don't cause a lot of irritation. So all my VKC patients, even if they are not very high inflamed, I would still give them tacrolimus. I don't use cyclosporin probably because of two reasons. My two reasons are: one, it takes time to act. Tacrolimus acts a little bit faster, has less dosing, as in cheaper. So I use tacrolimus more. I don't use cyclomune, so I don't know how much it works.
How often have you seen dry eye with VKC?
Ma'am, these surfaces are allergic surfaces. Allergic surfaces will anyway always be dry. But if you control the allergy, then the dry eye tends to come down. Any allergic surface will be inflamed, and then the related tears would be less. So they would always be accompanied with dry eye. But if you treat the primary allergy, the dry eye comes down.
Thank you so much, Dr. Rajat. May I now call Dr. Rashad Shroff. He'll be speaking on dry eye after cataract surgery.
Okay, thank you, Lalit sir, for the invitation. I'm going to be talking about dry eye after cataract surgery and the role of prophylactic lubricants in treatments before that. Now, very often when we come across a dry eye patient post-surgery, they are unsatisfied, and the main reasons for the ocular surface being disturbed in these patients are the incisions we make, exposure to the microscope light, aggressive irrigation during the surgery, topical anesthetics, and of course our post-operative medications. These are a few papers from literature which show that the incidence of dry eye varies from 9% to about almost 100% in certain papers in the initial post-op period. Though it returns to normal in a fair number of patients, there are papers that claim even 30% of patients at 6 months post-operatively still suffer from dry eye disease. And most of the studies that we see show that the tear film deteriorates after cataract surgery. Now, what is the issue with dry eye and cataract? If you have a preoperative dry eye, there are a couple of problems that can come in. There are errors in topography or in your biometry. And post-operative problems like irritation, the patient's constantly complaining, a poor quality of vision which gets better when they blink, and of course our poor tear metrics like the low TBUT, lipid layer, and poor speed scores or surface scores. So what we are actually treating post-operatively is a very small problem. The real problem lies before the surgery. So management in dry eye disease, cataract in dry eye disease, this is a paper by Dr. Rashmi Deshmukh and all from LV Prasad that's talked about the pre-operative, intra-op and post-op management, and I'll be focusing more on the pre-operative care. So questionnaires play a very important role in these patients to understand their symptoms beforehand, and it's important to kind of understand whether there is a component of aqueous deficiency in these patients. If there is significant aqueous deficiency, then screening them, immune screening, consulting a rheumatologist, etc. is important. It's very important to pay attention to the lids. If there's any lid malposition or trichiatic eyelashes, etc., that should be taken care of preoperatively. If there is keratopathy, then use of topical or oral steroids may be important. It's important to again just defer the surgery, look at the biometry a little bit later, otherwise you could end up with a refractive surprise post-surgery. So this is a paper in JCRS that talks about an algorithm for preoperative diagnosis and treatment of ocular surface disorders. This is the ASCRS algorithm which you can see here. So at the preoperative visit, the first thing of course that they've mentioned is that 2 weeks prior to the visit, the patient should be, if on contact lenses, should be on a contact lens holiday. The surface should be virgin at that point in time. They've suggested certain non-invasive measurements like the OSDI screening questionnaire or the speed questionnaire, and looking at signs like osmolarity and inflammatory markers. If there's a negative screen, they've talked about how the ocular surface disease is unlikely, whereas when there is a positive screen, they've talked about optional measurements like TBUT, non-contact TBUT, mammography, etc. And of course, the clinical examination is equally important. It's very important to stain these patients and see if corneal staining is positive. So if you have OSDI, ocular surface disease, ruled out, no issues, but if you have it ruled in, then it's important to differentiate between neuropathic and neurotrophic pain, neurotrophic corneas, and whether there's visually significant or insignificant ocular surface disease. If it's insignificant, that means you don't have fluorescein staining on the surface, or the surface seems reasonably regular, and you can proceed with the surgery, go ahead with your biometry measurements. If there is significant ocular surface disease, treat that. So look at the lid margin abnormalities, look at your treatments with lubricants, look at your treatments with vectored thermal pulsation and other treatments like that, and only after the surface is optimized, then go ahead with the cataract surgery. Important to remember that the use of preservative-free lubricant, cautious use of viscoelastic agents, mucin secretagogues, etc., topical cyclosporin may help in improving the dry eye disease. The lubricant algorithm that I generally prefer is, if the patient has very mild symptoms, then you can start with a CMC 0.5% or an HPMC. Slightly more moderate, look at polyethylene glycol based preparations. If a little bit more, than sodium hyaluronate. And then of course we have the other agents like trehalose, which help in autophagy control. And if it's a very severe dry eye with MGD, then lipid based agents and paraffin based ointments can be used. A quick note on preservatives. So there are basically two types, the detergents and the oxidative type. Benzalkonium chloride gets a lot of flack because of course it's a very frequently used preservative which is toxic to the conjunctival corneal cells. The chronic use destabilizes the lacrimal film, it reduces goblet cell density and the mucin layer and causes epithelial desquamation. Oxidative preservatives like sodium perborate dissolve in water and release hydrogen peroxide, and therefore they are a little bit better for the surface as it forms a stabilized oxychloro compound. And the release of chlorine dioxide interferes with microbial protein synthesis. Specific situations to mention: in mild to moderate dry eye, like I said, I start with CMC. In severe aqueous deficiency, along with an immune workup, sodium hyaluronate and paraffin based ointments are helpful. You can use oral pilocarpine as well. In filamentary keratitis, I do use N-acetylcysteine and sodium hyaluronate. And in MGD, there's lipid-based ointments, formulations like Cysteine Complete, no financial interest there, but those can be used along with vectored thermal pulsation. We also did a study looking at the role of conventional and vectored thermal pulsation therapy before dry eye disease, and looking at the impact on dry eye symptoms and signs post-operatively. I won't go through the details of the inclusion and exclusion criteria, just through the results. What we saw was that in general, the objective and subjective tear film parameters showed significant deterioration when you did not treat these patients. So this is the group which had no treatment. I'll just take half a minute. Conventional treatment group, which was with a hot fomentation and lubricants, they showed a improvement in the TBUT and the FBUT post surgery, as did the vectored thermal pulsation group. And what we found was, if you treat these patients either with vectored thermal pulsations or with hot fomentation prior to surgery, they tend to do better post-operatively. To conclude, treatment of dry eye with lubricants before cataract surgery improves patient satisfaction after the surgery. Treatment with vectored thermal pulsations and traditional therapy helps in patients with moderate MGD, and of course we need more evidence to back our claims. Thank you.
Thank you so much, Rishad. So, ma'am.
No, I'm okay.
Very dry talk, so.
Yeah, so it's an interesting talk, and I think the tip really we need to learn from this presentation is that everybody who's coming in for cataract surgery must get looked at for a pre-existing OSD, because your outcomes, as well as the predictability of the results, as well as comfort, of course, and which is then patient satisfaction, is bound to get affected by the pre-operative assessment of the dry eye. And do not hesitate to defer surgery, I think, which is the point that you also highlighted. in patients who have a moderate disease, because you're going to make it worse. And I guess that applies to the next talk as well, which is refractive surgery, which is really the same thing. So once you're going to be insulting the ocular surface, you need to be very sure that you are dealing with or you're taking care of some of these things. The other thing that could probably be highlighted is the use of preservative-free medications in these patients, where that would be the other tip or trick in that sense. But yeah, wonderful. Any questions from yes, Lalit?
I'm not a OSD expert, but suddenly what has happened, and we were not doing all this thing before, and I do not know whether your results are compromised.
So, a couple of things is, one is screen usage has gone up recently, which probably was not there, and I don't think there's any study anywhere in the world that actually has looked at impact of our devices on our ocular surface in detail. Like, I mean, now we've all used them, so we're not going to have something that was never used, an ocular surface that has never seen a screen. That would probably be one of the reasons why this has become more and more important. I think Dr. Tityal had published a paper on that almost there's a 30% incidence of this in North India, which I don't think pre-screens was ever something that we looked at in detail.
No, I understand, but suddenly spurt has come in the management of dry eye for everything, pre-cataract, pre-refractive, pre-RD, everything. You keep treating and people forget about the main drops and people keep treating with these drops.
See, initially it was, I feel,
You see a lot of people will
people
come.
were basically getting operated and they were resting.
Yeah.
They wouldn't look at screen, they wouldn't go for work. Nowadays patients' expectations have gone up and they want to come back to work within next, say, week, 3-4 days. They undergo phaco and within 2 days they are back to work. And that's the time when your ocular surface really plays up. As long as you're not using screen, you will be fine.
Yeah,
Also
and earlier the biggest issue was we were struggling to attain 6/6 vision, and then 6/6, 9/6 vision. Then also came intermediate. Then when everything has come back, then people are definitely having more problems. Why? Because the vision is okay, but I mean, whenever you feel that the surgeon is happy when the patient reads all the lines,
But patient is not
but
happy.
patient is not happy because now he can read that, and he has understood because of all the media and everything that cataract surgery provides very good vision. So he's happy, but he finds that there is something wrong, some watering, some irritation, and that is why that has become more prominent than the complaints of less vision.
Correct. It's probably close to 80%.
Very common.
Only 20% people after modern cataract surgery, at least in my practice, are actually thinking they are not seeing well. Otherwise, they are very happy with the visual side of the outcome. So why are they following up? So they are only following up because या तो पानी आ रहा है या
चुभन हो रही है,
something
irritation
like
है
that.
आँख.
So it's obviously ocular surface which is creating this. I think our expectations have changed. We are now doing so many premium IOLs. Again, they are the ones who are more sensitive to, because they've spent more, they have more expectations again. And they are the ones who need the comfort.
So also, I think as clinicians, we are a lot more aware of evaporative dry eye. Now, we were probably not looking at that very seriously earlier. So it was probably only aqueous deficiency that we were looking at earlier. So we were probably underdiagnosing it as well.
So true.
Even the LASIK, he's going to give a talk, even the LASIK patient, you can keep telling them you'll have dry eye, but they go back to work in 3-4 days time and they still come back to 6 blurry hai. They may have 6/6, but they're very unhappy from the quality of vision.
Thank you, Dr. Tushar. May I now request Dr. Tushar to speak on dry eye after refractive surgery. Do we give lubricants in all cases?
So my gratitude to Lalit sir for having me here. I'll be talking about dry eye after refractive surgery. I'll try and not have too much of repetition of what Rushad said. He of course covered a lot of things about dry eye. So starting out with dry eye post refractive surgery, what causes it? So the most common mechanism that you see which causes dry eye after refractive surgery is the damage to nerves that happens. Damage to the subepithelial nerves and some of the anterior stromal nerves as well. The other mechanisms include damage to the goblet cells because of suction that is applied in LASIK, and the alteration that happens in the corneal curvature also produces tear film instability. So you can see how the corneal nerves get transected in both LASIK and SMILE, tends to be lower in calyx, any form of keratolenticulaar extraction surgery, but it's been found to be similar at about 6 months. So both the surgeries are altering corneal nerves, more so in LASIK. And this is typically the kind of staining that you get, the neurotrophic kind of staining that you get in patients that have undergone LASIK. So preoperative evaluation was covered thoroughly. I'll just repeat some of the important points. So extremely important to go in a systematic manner, go from the most non-invasive to the most invasive investigations. Extremely important to have a dry eye workup as a part of your refractive surgery workup. Doing a fluorescein stain, look for signs of ocular surface issues. Doing a Schirmer's to rule out aqueous deficiency is extremely important before surgery, because we know that refractive surgery by itself is inducing dry eye, so you're only going to make it worse in somebody who already has it. And following that with an MGD assessment, if you have these tools which look at the lipid layer or the lipid layer thickness, that's helpful, that's great, but it's not essential. You can also look at the meibomian glands, see the kind of dropouts there are. So these are all supplementary tools that we have now, that are available now, which can add value. So as Sir pointed out at the end of last talk, in somebody who's having mild to moderate dry eye, it's extremely important that you treat that before you proceed for refractive surgery. Somebody with severe dry eye, especially severe aqueous deficiency, it's important to look at the immunological cause, and it's important that you avoid refractive surgery in these individuals, because you're likely to have poor outcomes, and even regression has been reported in these cases. So like I said, treat dry eye, treat the MGD. You can also consider modalities like Rushad spoke about, LipiFlow. There are other modalities available as well which can be used to treat evaporative dry eye before refractive surgery. So moving on to lubricants, this is an excellent article by Professor Namrata ma'am and group which talks about treatment of dry eye and refractive surgery, and it talks about a step ladder approach. So lubricants do form a routine prescription for us post refractive surgery, because we are inducing dry eye. It forms the mainstay of treatment and is usually adequate in most cases. Then the next question comes out to be, which lubricant do you choose? Essentially, when somebody has mild dryness or you're using it as a routine, a low viscosity lubricant such as CMC 0.5% is usually good enough. When somebody has more severe dryness, you need to look for a high viscosity lubricant such as CMC 1% or sodium hyaluronate 0.18%. What is important to know is that these higher viscosity lubricants give you better symptomatic relief, but they're also associated with greater amount of transient blurring of vision on the installation of drops. So you can also combine a low viscosity lubricant during the day with a high viscosity lubricant used at bedtime. As was already discussed, it's extremely important that you consider preservative-free drops in these patients, and of course BAK drops should absolutely be avoided in these patients. Somebody with moderate dry eye or more severe dry eye, you can consider anti-inflammatory therapy as well, like topical cyclosporin, which needs to be given at least for 3 months after surgery. In somebody with pre-existing dry eye, you can start it a month before surgery, because these drops take time for them to take effect. Even lifitegrast is something that's available in India now, so that's also something that can be considered, though it's a little more costly than cyclosporin. And then of course, when you have severe dry eye, you need to look for other modalities like punctal plugs, scleral lenses, and autologous serum. So the treatment of meibomian gland dysfunction post-refractive surgery is extremely important as well. If you're considering LipiFlow post-refractive surgery, important that you don't do it too soon, because you don't want to disturb the flap. And the other modalities like conventional treatment of MGD should be given. So the other thing that, one thing we don't understand very often is what is neuropathic pain, or what we call as pain without stain, which is something where the individual has symptoms of dry eye, often very severe, but we don't see the signs of dry eye. And in these cases, it's been found that, drugs like oral gabapentin, oral tricyclic antidepressants do work. So it's something that we as ophthalmologists don't understand very well, and a consultation with a neurologist is helpful in these cases, and you can consider that. Then there is also the toxic component, which may be because of the drops that an individual is already using, or the drops that you've given after the surgery, in which case it's important to switch to preservative-free drops, and topical anti-inflammatory agents can be considered. So to summarize, dry eye is a very frequent cause of patient dissatisfaction, one of the most common complications, if you can say that, after refractive surgery. Dry eye evaluation is an extremely important component. So doing a refractive surgery workup should include a dry eye workup. Lubricants are an important part of the post-operative regimen, and I do recommend that we use it in all cases, but these may not be enough in every case. Somebody having moderate to severe dry eye might need other forms of treatment like topical anti-inflammatory therapy. Thank you.
Thank you so much, Dr. Tushar. We had a discussion regarding all this. Thanks a lot. And so may I now request Namrata ma'am to join us on the dais and Dr. Rajesh Sinha sir to speak on role of topical cyclosporin in dry eyes. Over to you, sir. Welcome, ma'am.
Thank you.
I'll be really cautious in labeling somebody having a neuropathic pain, because what happens is quite often it's something like when we are not able to solve the problem, we label the patient. So it's a very tricky situation. And are there any clear-cut guidelines to label somebody as having neuropathic pain? Because I have seen patients who have been referred to a psychiatrist when they actually had an organic cause for it. So
essentially what we refer to as neuropathic pain is something where you've done a thorough dry eye evaluation. There are no objective signs, but the patient symptomatically is troublesome. So it's not always a psychological or a psychiatric cause. It could be nerve related. So there are ganglia which are firing, and that is associated with neuropathic pain.
I absolutely agree. But are there any objective parameters for labeling a person as having neuropathic pain, or it depends upon my ability to diagnose or to detect using some investigative modality?
Yeah. So as of now, I think as far as from what I feel, we don't have any objective signs, because it is the absence of objective signs that makes us diagnose it.
Challenge test, and then you can put contact lens and see. So those are those tests which have been described to talk about peripheral and central neuropathic pain. So those have been described in literature, where you put Paracane, you put a contact lens, see if the patient improves with that, in which case it could be a peripheral neuropathic pain where your other symptoms, other signs are all negative. If it still does not improve, then they rule in the possibility of central neuropathic pain. So,
but won't Paracane take care of any local cause?
Basically, so you're going to talk about whether there is neuropathic component on that. Okay.
Shall I? Okay. Thank you very much. Thank you, Lilith sir, for inviting me in this meeting. Actually, I remember long back we were sitting in one of the hotel rooms wherein we in some conference, and there we were discussing that there should be some meeting wherein we should discuss about tips. So tips again is a word, but it's also an acronym. Tips means T stands for tip, I stands for in, and P stands for practice. So that's how he coined the term, and that's how we did a few meetings with tips, and that was really wonderful. So coming back to my topic, I'll be talking about role of cyclosporin in dry eye. A lot of dry eye and the polymers have been discussed, what can be used in various conditions. In a lot of studies, and most of these are international established studies, the Delphi panel, the DEWS definition and the DEWS 2 definition. In all these definitions, on all these studies, they have found out that ocular surface inflammation plays a key role in damaging the ocular surface, and that results in symptoms of dry eye. And that is why we have to use some anti-inflammatory agent, something like cyclosporin or steroid or doxycycline, etc. And cyclosporin as anti-inflammatory has a proven effect because it reduces expression of all the inflammatory markers like HLA-DR and CD11 and interleukins, etc. Studies have shown in Sjogren's as well as non-Sjogren's that the cyclosporin treated eyes have shown less T lymphocytes in conjunctival biopsies, and that is why it has a direct impact, because since the inflammation in the lacrimal gland is less, inflammation in the accessory lacrimal gland is less, so the Schirmer value increases. So there's an absolute increase in Schirmer value. So that's how the patient has less reliance on the lubricant. So you don't have to keep prescribing 8 times a day or 6 times a day. Once the cyclosporin takes its effect, you can reduce the frequency of topical lubricants. It also enhances the goblet cell density. It is a proven fact, and that's how it retains the tear film on the ocular surface, and that's the advantage of cyclosporin. So it is now an FDA approved therapy, and the only issue was whether it is safe or not. So it has been seen with even with 2% cyclosporin, long time back. I think Namrata ma'am will be remembering that, with Professor Vajpayee, myself, Dr. Namrata ma'am, we all had done a study with 2% cyclosporin. We found out that it is safe. As far as the blood concentration is concerned, it was found to be less than 165 nanogram per ml, which is the critical level beyond which you can cause some systemic toxicity. So it is reasonably safe. 0.05% is a very safe drug, and that is how it quantitatively and qualitatively improves the tear film, and also improves the goblet cell density, reduces apoptosis, reduces inflammation, and that is why it is very useful. It's a phase 2 study which compared various concentrations like 0.05, 0.1, 0.2%, and they found that there was no clear dose-response relationship. So that is also something which we have to understand. A couple of studies that have shown in post-refractive surgery, very nicely presented by Tushar, that cyclosporin is very useful in these cases wherein refractive surgery has been done. It not only improves the ocular surface, but it also improves the quality of vision by improving the ocular surface, and faster recovery of 6/6 vision, and that is something what we all want. The only concern is that it is most of these formulations are oil-based formulations, except for a couple of formulations that have come up now. And these oil-based formulations, the emulsions, they do have some surface irritation, and that is why the patient, when he puts these eye drops, complains of some stinging. And then of course these are present in unims, it is very costly, so these factors are there. As I said, oil-based emulsions, they have less bioavailability and has some stinging, and also causes some degree of necrosis and apoptosis on the surface. And if there is preservative in the drop, then of course we all know the side effects of preservatives. So this is something, I have no financial interest. It's a preservative-free aqueous-based cyclosporin that has been launched, I think, a year before, which was formulated with NPL technology. What is NPL? NPL is novel proprietary lipid technology. This is Cyclysis PF from Intas. Again, no financial interest, but it's a wonderful, very nice drug, wherein the pH of this formulation again is very good. It is 7, and that is why the patient does not have any stinging, does not have any irritation, and it is a aqueous-based preparation. And the NPL technology, what it does, normally cyclosporin is a lipophilic molecule. So NPL is the novel proprietary lipid which enhances its solubility in the aqueous base, and that is how it provides the actual cyclosporin onto the surface and allows it to remain there for a longer period. And it has a multi-dose vial, that is Novelia bottle. Novelia bottle has the advantage that once you press, one drop will come out, and whatever drop has come out, partial also, it will not go in. So the risk of contamination is not there. So cyclosporin, of course, is a disease modifying agent. Lubricants are definitely palliative, they are useful, but cyclosporin is a therapeutic drug, and it is just required a twice daily dosage and not much. Yes, it does require a long duration of treatment, has some degree of latency, which was mentioned earlier. The question is whether it is required in all the patients. I would say no, but yes, if the ocular surface shows some degree of inflammation, definitely it can be of great use. It can be very helpful. Thank you very much.
Thank you so much, sir. Ma'am, sir.
Well, there are other cyclosporin molecules which are also available and which do have a greater availability too. So how would you compare it, with other molecules which are available?
Yeah.
And then you have a cyclosporin which is 0.9% also. So
Yeah.
0.5
So-
vis-a-vis 0.9.
So there was one study earlier done. I mean, there's no current study which compares these two drugs, but there was one study which was of study compared with different concentrations. That was 0.05%, 0.1%, 0.2%. And they found that there was no difference as far as efficacy is concerned. They were comparable. That is one. Point number two is that another formulation which is there, which is very popular, is again based on which is an emulsion. Now that emulsion again causes some degree of irritation. This is aqueous based, so it has its advantage. It is preservative free. But yes, there is another formulation which is aqueous based, which has come up, as you said, 0.09%, and its bioavailability is also good. So I would say that I mean, either can be used because the studies have shown, till date there is no study which has shown that 0.09 or 0.1 has better effect. But there is one study which has shown that 0.05, 0.1 and 0.2, all three are comparable. So based on that we can say that yes, both can be used. Both these new formulations are aqueous based. So that's the advantage, that both are aqueous based, and both again, all three preparations, that even Restasis, all these have pH value which is close to 7. So that way all these three formulations are good, which can be used. The advantage of these two preparations, for the Sequa and the Cyclysis PF, is this, that these are aqueous based. So that is why there will be less of stinging.
One tip you have to give, which dry eye patient I should be giving topical cyclosporin?
Any patient which does have some degree of inflammation. If there's any subtle sign of conjunctival injection, if there's any subtle sign of inflammation, even if you don't have if you don't measure the marker, I mean, in large majority of patients, we don't measure the inflammatory markers. But if there's any subtle sign of inflammation on the ocular surface, then in that case, we should use cyclosporin. If a patient is on lubricant for some time, not responding to it, again, we should add cyclosporin.
So what is your ultimate aim? What do you tell them? That, you know, I'm putting you on cyclosporin,
Yeah.
and maybe you're on CMC or maybe hyaluronic acid maybe 4 times a day
Yeah.
and all. So what is the aim ultimately?
So the aim will be that right now you are putting CMC 4 times a day or hyaluronic acid 4 times a day. I'm putting you, and it's not working that well. Now I'm adding cyclosporin. It will help reduce the symptoms, and later on you may continue with 4 times a day drops only, twice hyaluronic acid and twice cyclosporin. So your number of the frequency of drops that you have to put will remain the same, and you will be symptom free.
Okay, thank you.
Nobody can exactly say that how long it should be used, but yes, it should be used for a long period, at least for 6 months to 1 year.
Do you use continuously for 6 months or
Yes,
after
ma'am.
3
It should
months you
be. It
like
should
to
be
give a
used.
break?
It should be used continuously for 6 months because obviously it has a latency. It does take some time to act. So it's better to use it continuously for at least 6 months to 1 year so that its effect is consistent.
Okay, thank you.
Aditi,
What you said was the dose-effect relationship is not that much in cyclosporin. So then what is the rationale of having both aqueous-based preparation, one is 0.05 and 0.09? If the effect is same, then what is the rationale of having 0.09%, number one? And number two, in dry eye, comparison of cyclosporin versus tacrolimus. What is your drug of choice in patients of dry eye having inflammation?
So let me first answer the second question first because it is easier to answer. If there's a dry eye, if there is a VKC or allergic eye disease, I would prefer tacrolimus. But if it's a dry eye, tacrolimus will itself cause a lot of stinging and symptoms. So I will not use tacrolimus, I would use cyclosporin. That is one. Now coming to why having aqueous based preparation with a pH of close to 7 with different concentrations. 0.05%, 0.1% and 0.2% were compared. But now the current, another drug that has come up now with 0.09%, that has another technology which is nanomicellar technology wherein they claim that the concentration of the molecule, the cyclosporine, will be more in a shorter period, and that's why the latency may reduce. That is the claim. But right now there is no study which can compare. So unless we have the product and unless we have the options, we will not become wiser. So once
penetration levels are there. With nanomicellar and your other thing, they have measured the aqueous level of cyclosporine.
Effect, ma'am. Actual effects.
So
studies have not, there's no study which has.
Use it,
So with the nanomolecular technology, the penetration is more, and that is what they claim. And that is what they claim based on their own studies only. But the effect, efficacy still has not been measured, whether the efficacy is better or is the same. And that perhaps we will be, will be knowing after some time when there is a comparison between these two drugs.
So if all the people on the dais had to give one tip with regards to cyclosporine use, Aditi, what would yours be?
So first I'll tell about the latency to the patient, because it is not a magic drug. Some of our patients, they are already so tired of using so many medications, so they feel that they'll start using it and they'll get the effect. So that is not going to happen. If there is inflammation, I do add soft steroids along with
it should be started with steroid only, because it does have a latency.
So that they do not get the additional stinging sensation. So that will be my tip.
Great. Ritu?
I like to use it mainly when there's a immune mediated element, especially the dry eye with all the rheumatological problems. This I always use with them, and otherwise expense comes into it, because it's expensive. Therefore I don't use it as the first one, but some of my post LASIK patients I've also put them on Restasis.
So I think topical cyclosporine does have a role to play, and I would like to use it with topical steroids. And when I use topical steroids, I don't use a low dose steroid, I use a full on steroid and a full on cyclosporine, and then only subsequently when the vicious cycle gets broken in between, then you would shift to topical cyclosporine and then taper off the steroids. So I think it is a role to play, because it keeps you off the steroids and yet gives symptomatic relief to the patient.
Yeah, I think the role of inflammation causing dry eye has always been very underplayed. But there are a lot of patients who do have surface inflammation, and they do require some degree of anti-inflammatory drugs. It can be steroid, it can be cyclosporins, it can be anything. So I think that is why the use of cyclosporin is increasing, because even after use of some lubricants, patients, they do keep coming with symptoms.
Yeah, and this is purely anecdotal, but when I start topical cyclosporin, I do start topical steroids also. I mean, I have no basis to say so, not done a study, but I would always combine them together, and then...
it should always be started along with steroid, because cyclosporin takes its own time to act. So by that time, steroid will take over, and steroid will start working immediately. So the surface inflammation will reduce, and you cannot use steroid for a long period, so you have to taper it off. So you'll just stop steroid after some time, continue the patient on cyclosporin, because by that time, cyclosporin has already taken over and it starts working.
Thank you so much, sir. May I now request Dr. Jaya Gupta to tell us about the devices to use in MGD.
So, morning. Thank you, Dr. Lalit Verma sir and Dr. Namrata ma'am, for giving me this opportunity. So it's not just about devices, though Rishi sir said that to keep the talk for just 4 minutes, I'll be skipping a few slides. So meibomian gland dysfunction is a chronic diffuse abnormality of the meibomian glands, commonly characterized by terminal duct obstruction and or quantitative changes in the glandular secretion. This may result in alteration of the tear film, symptoms of eye irritation, clinically apparent inflammation, and ocular surface disease. So, just a few words about the pathophysiology. Depending on various causative factors, which may be age or sex hormonal disturbances, environmental factors, changes of the meibum or aging process, contact lens use, there is hyperkeratinization of the meibomian ductal system. This hyperkeratinization causes obstruction to the orifices, which may result in low delivery, If there is low delivery, so there is deficiency of the tear film lipid layer causing evaporative dry eye. At the same time, the obstruction can cause stasis, and so there is increased pressure in the ductal system, which causes dilatation of the ductal system, which causes atrophy and thereafter gland dropouts. So, a few terminologies. Basically, blepharitis is a general condition describing inflammation of the lid as a whole. Anterior blepharitis is inflammation of the lid margin anterior to the gray line and concentrated around the lashes. The posterior blepharitis is inflammation of the posterior lid margin, which may include different causes including MGD, conjunctival inflammation, and other conditions like acne. So MGD is an underdiagnosed and undertreated disease, and asymptomatic MGD is more common than the symptomatic MGD. It is estimated that 70% of the Americans over the age of 60 have meibomian gland dysfunction. So meibomian gland disease or meibomian gland dysfunction could be low delivery or it could be high delivery. High delivery is the hypersecretory one, the cause being primary, we cannot say, secondary due to seborrheic dermatitis, acne, etc. The obstructive one can be both cicatricial and non-cicatricial. Several other causes like trachoma, oculopemphigoid in the cicatricial one, and in the non-cicatricial one, seborrheic dermatitis, acne rosacea, atopy, and psoriasis. And then the hyposecretory, which is meibomian sicca, that again can be due to medications. So diagnosis. The diagnosis of MGD is based on examining the altered anatomical features such as terminal duct obstruction, gland dropout, qualitative and quantitative changes in meibum, and pathological events leading to MGD. The International Workshop on Meibomian Gland Dysfunction recommended several diagnostic tests for MGD and proposed two approaches for diagnosing symptomatic MGD-related diseases. For asymptomatic adults, performing gland expression with digital pressure to the central lower lid followed by assessing the ocular surface damage is recommended. So how we do it, the clinical evaluation, we can look for the meibum quality as well as the meibum expressibility. The meibum quality is assessed in each of the 8 glands of the central third of the lower lid on a scale of 0 to 3 for each gland. 0 that is clear, 1 that is cloudy, 2 that is cloudy with debris, and 3 like we see in the picture, thick toothpaste thick like toothpaste. And then the meibum expressibility. For the meibum expressibility, which is assessed on a scale of 0 to 3 in the 5 glands in the lower or upper lid, according to the number of glands expressed. So if it is 0 when you can express it from all the glands, 1 when you can express it from 3 to 4 glands, and then 2, 1 to 2 glands, and 3 that is no glands at all. Then we notice eyelid margin morphology. With MGD, we'll notice the thickening of lid margins, rounding, notching, increased vascularity, and we look at the orifices. We can look at the number, pouting or the capping of orifices, changes in the position of orifices with respect to the mucocutaneous junction and the mucocutaneous junction examination as such. So diagnostics, we can look at the meibography, which is a very simple thing. That's basically because of the infrared light. We can look at the meibomian glands. In the first picture, we see the normal meibomian glands, and later on, we see in the second picture, there's MGD and gland dropout. And this can be classified a scale. This is the Reed-Pult scale, in which, depending on the meibomian gland dropout, it is graded. So at our center, we do not have LipiView, but we have OSA from My Healthscape, and OSA, there's OSA Plus, and IDRA. IDRA is the most sophisticated one. And now, as I've been told, that OSA and OSA Plus, they are not manufacturing it as of now, so it's only IDRA. So this machine gives us a lipid layer analysis using interferometry and aqueous layer measurement, the mucosal layer status, and meibography. Meibography is visualization of the glands through transillumination of the eyelid with infrared light. It images the morphology of the glands to diagnose any meibomian gland dropout, which would lead to tear dysfunction. That's the first interface. Here we'll be only talking about interferometry and meibography. Auto interferometry test that measures the lipid layer thickness with nanometer accuracy. So using the device, it is possible to do an interferometric analysis of the lipid layer in the tear film. The tear film plane must be focused while the image of the bright circle remains blurred. So this is how the lipid layer thickness is measured. It's compared to the prior templates, where we compare with the patient's exam. So anything less than 60 is severe dry eyes. Between 60 to 80 is again moderate dry eye, and if it is more than 80, that may be considered as normal. I'll skip this slide. Coming on to meibography. So meibography, I'll skip this as well because we've spoken about it. So there are several machines investigations which are available. For example, LipiView, a brief, I think Tushar and Rushad had covered that, and IDRA. I'll skip these slides. And then finally, we grade the MGD as per the expressibility and the secretion quality, and the clinical symptoms and clinical signs, and depending on the grade, the treatment is thus. In the stage 1, it's eyelid hygiene including warm compresses. In the stage 2, it is artificial lubricants, azithromycin, consider oral tetracycline derivatives. In stage 3, again, it's anti-inflammatory therapy for dry eye, which is also included. And stage 4, all the ones in stage 1, 2, 3 plus anti-inflammatory therapy. And in the plus disease, we have to do something extra. So I'll skip this. And first of all, coming to in the treatment, there are several masks which helps in MGD. In particular, I put this particular mask which is available on Amazon, and it's also got a music. So that's Dr. Santosh Tuman, one of my friends, who has put this mask and relaxing in between his cases. So these are the different MGD devices which I'll not be discussing in much details, but the details are here. So LipiFlow is basically a thermal pulsation system that applies heat and pressure to the eyelid tissue simultaneously to express the meibomian glands. What we have is this EI. EI is intense regulated pulse light. Here the mechanism is said to be neurological. It is the infrared nerve stimulation that induces a return to normal activity of the meibomian glands. So this is already discussed that the mechanism of action is neurological. I'll skip these slides and just come to this IRPL versus IPL. The IPL example is the image that is here, which that comes from Toshpro eyelight, and here the mask is put, and it's again like giving heat to the meibomian glands. And the last, that is the advantages and disadvantages of IPL and LipiFlow, summarized in this slide. So,
thank you so much, ma'am, for summarizing such a big topic. Any comments?
No, very well done.
Any question?
Any questions for Jaya in terms of devices? And any comparative choice? So the tip naturally would be, if you had to choose one device, what would you choose?
One device if I have to choose. So the first thing will be the mask.
Oh, you mean from the treatment perspective?
Yes.
And
yes.
for imaging?
For imaging, sir, from us, even this is good enough, like the IDRA.
The SBM IDRA?
Yes, sir. Okay. SBM IDRA. Because
even the OSA, the cheaper version of the IDRA would do fairly well, actually.
So OSA does not, I believe OSA does not give the real-time lipid layer thickness which is there in LipiView. IDRA has that lipid layer thickness, if we would like to study that way.
Right. Okay, that's a fair point. But there's a significant cost difference.
Yes,
so I guess
absolutely.
Everyone
so
can, better than not having any device.
Absolutely.
Okay. Wonderful. Can we, is Namrata next?
Yes, yes. No, Shikha. Shikha. Dr. Shikha.
May I now request Dr. Shikha Jain, ma'am, to speak on dry eye and systemic disease.
Good morning, everybody. I would like to thank for inviting me here. So the slides are not moving. Thank you. So I'll just skip these basic slides. As we are all aware, the definition of dry eye and it is a very common condition but is quite incapacitating, has a negative impact on quality of life, interferes with daily life activities, and in severe cases it can lead to anxiety and depression. So this is the lacrimal functional unit, which we are all aware, the tear film, lacrimal gland, conjunctiva, cornea. So if we look at the etiology of dry eye disease, it is basically classified into the aqueous deficiency and the evaporative losses and the further causes. But another way to look at dry eye disease and systemic disorders is to classify into immune causes, inflammatory causes, the neurosensory causes, and the iatrogenic causes. So when we talk about immune related causes, connective tissue disorders form the major chunk of these diseases, but we also have the Stevens-Johnson syndrome, ocular graft versus host disease, thyroid eye disease, OCP, etc. So the Sjogren's and the RA, these are the main things which constitute the connective tissue disorders and most commonly seen in clinical practice. Patients will usually present with history of dryness, redness, inability to open the eye, photophobia. On prodding, they may give you a history of dry mouth. We have poor Schirmer scores, low tear meniscus, and on clinical examination, you may see a picture like this with lots of SPKs and filaments in the eyes. In patients from young to middle age group, it is always prudent to order some investigations like autoantibodies, the SSA, SSB or ROLA antibodies, the RA factor, ANA, and a histopathology of salivary glands, which is conducted by the ENT people, always helps in the diagnosis. This is the diagnostic criteria for Sjogren's syndrome: a positive antibody, a positive biopsy, and an ocular staining score of more than 3. At least 2 of the above lead to diagnosis of Sjogren's syndrome. Sometimes with patients with long history of immunological disorders and in quiescent phase may suddenly come to you with sterile males. This was a 48-year-old female who presented with decrease of vision and redness around 2 years back. Left eye had an area of thinning temporally extending from 2 to 4 o'clock position with a central perforation of around 1 to 2 millimeter. There was no evidence of infiltration and she was a known case of seropositive RA already on treatment. She was taken up for glue plus BCL and a corneal scraping was done to rule out any evidence of infection. A rheumatology referral was repeated. Around 2 months she recovered a vision of 624, but subsequently she developed cataract and had to be operated for cataract. At present both eyes are quiet. Systemically she is on 2 immunosuppressants and doing well. So patients of Stevens-Johnson syndrome in the acute phases, these diseases may lead to erosion of ocular surfaces and destruction of meibomian glands. In chronic phases, there are chronic inflammation with poor ocular surface. So conjunctival ulceration in acute phases lead to fusion between the bulbar and phoenicial surfaces, leading to symblepharon, ankyloblepharon, and the tear film is disrupted. It affects all the 3 glands, the meibomian glands, atrophy of meibomian glands, the scarring and lacrimal gland ducts, and loss of conjunctival goblet cells, leading to severe dry eye. This is another condition. I do not have much experience, but this is a rare but significant condition which deals a triple whammy to the ocular surface. It causes lacrimal gland fibrosis, meibomian gland dysfunction, goblet cell loss, leading to punctate keratopathy, epithelial defects, and even sterile males. So the management of these patients depends on the inflammation that they have. It is very important to control the inflammation with topical steroids, and even oral steroids may be needed. Other supportive treatment in the form of lubricants had to be continued. So coming to the inflammatory causes, we could have ocular rosacea, sarcoidosis, lymphoma. Sarcoidosis and lymphoma mainly infiltrate the lacrimal gland and cause decrease in aqueous component of the dry eye. This is a 44-year-old male who developed some skin lesions around 7 years back and was diagnosed as rosacea by the dermatologist. 2 years ago, he developed ocular involvement in the form of dry eye and corneal neovascularization, which settled in the form of corneal scarring. So the management of these patients, because ocular rosacea mainly affects the meibomian glands, the management of these patients consists of lid hygiene, topical antimicrobials, and cyclosporin eye drops. So coming to the neurosensory causes, we have lesions of cranial nerve 5th or 7th. Just a recap of how the 5th nerve and the 7th nerve affect the tear film. So any lesions of the fifth or seventh nerve lead to decreased trophic support to epithelium from underlying nerves. The etiology could vary from a viral infection to diabetes or post-surgery damage to these nerves. So this was a young male who met with an RTA, road traffic accident, in 2021 and underwent a neurosurgical procedure. He presented with mild redness and decrease of vision in right eye, had inferior corneal thinning, which progressed rapidly on conservative management. He had severe dry eye with absent corneal sensations, and in COVID time, due to lack of corneal tissues, he was planned for a Tenon's patch graft, and he maintains a vision of 636 with quiet eye. So the management of neurotrophic causes includes non-preserved artificial tears. It is important to control underlying inflammation, if any, which is present, and BCL, tassoraphy and AMG are the other tools in our armamentarium. This is again a patient with seventh nerve palsy. The causes of dry eye in these patients are decreased aqueous production because the lacrimal gland innervation is affected and inadequate spreading of the tear film. So any kind of surface irritation leads to inflammation and tear film stability, causing a vicious cycle in the eye. So the general principles of management apply to replace moisture, preferably with preservative-free tears or gels or ointments, to treat MGD as already discussed. Modification of local environment in the form of humidifiers, screen time, dietary modifications may be helpful, but what is more important is to identify the etiology and give targeted therapy. Immunosuppressants may be needed for connective tissue disorders once identified. For inflammatory causes, steroids, both in topical and oral form, is a must. For systemic drugs or offending topical medications, we need to stop them and replace them. So the take-home message is, dry eye disease is a complex disease. Patient's history is crucial to identifying the underlying etiology, and not all dry eye disease are the same, and neither should be treated in the same way. Thank you.
Thank you so much, Shikha ma'am. Beautiful cases. Thanks a lot. Ma'am, any role of punctal occlusion as well in such cases?
Yeah. So punctal inclusion is one of the tools in the armamentarium, but it is important to know that the inflammation should be controlled in the eye.
Very important point.
Before we go in for punctal inclusion, otherwise the debris collects and worsens the dry eye.
Right. So which punctal plug, if you have to use, would you go for that?
So usually we start with the temporary plugs, and if the patient is comfortable, then we can think of doing the permanent.
Okay.
Cut.
Thank you.
May I now request Dr. Namrata ma'am to speak on nanomicellar topical cyclosporin. Over to you, ma'am. I request Ityal sir to join the chair.
एक अडेप्टर से लगाओ. So, thank you Aditi. I would be talking to you about nanomicellar topical cyclosporin, yet another molecule which has come in the armamentarium of anti-inflammatory drugs, that is cyclosporin. So, we do know that we give it as a step 2 when the lubricants alone don't do the magic. So, you do require topical non-steroidal immunomodulators in the form of topical cyclosporin, and there are various steroid, cyclosporin, anti-inflammatory therapies which are available, but there are challenges with all of them. And I think the challenge with the topical cyclosporin, lifitegrast, etc., the immunomodulator especially, is that most of the patients will discontinue the treatment because of burning and stinging sensation, and also because of the lag time between the initiation of treatment and symptomatic relief, and that is why I always believe that you should start them with topical steroids. This was just a study to show that dry eye disease symptoms, if lifitegrast is used, and now this is available with another company, is that the symptoms and the signs both do take about 4 weeks for it to act. The problem with the existing formulation, of course, is that they are the thermodynamically unstable, and the bioavailability is not as much as you would like it to be. The nanomicellar cyclosporin which is available, which comes by the trade name Sequa, does have a hydrophilic shell and subsequently also has a hydrophobic core, and then has cyclosporin molecule which is encapsulated in it. So when this comes in contact with the tear film, the cyclosporin bioavailability increases because the N-cell technology encapsulates the cyclosporin and allows it to penetrate the aqueous layer of the tear film. Now, these are few studies to show how it acts and what is the penetration. So, this was a rabbit study in which it was clearly shown that with this nanomicellar cyclosporin, that is Sequa, 3 times higher concentration of cyclosporin was there in conjunctiva, cornea, even aqueous humor as well as in sclera. There it has undergone phase 2b, 3 and phase 3 trials as well as the long-term safety and extension study trials. And if you look at the clinical efficacy, this was a phase 2b, phase 3 study in 400 plus patients where cyclosporin, where Sequa was compared with the cyclosporin 0.05% and vehicle also. And it was found that Sequa did show improved total corneal staining, which is in a short duration of time, and this duration was as short as 2 weeks. And the concentration is 0.09%, which is much more than the commercially available cyclosporins which are there. Now, just to see whether vehicle is doing the trick or the Sequa is doing the trick, a comparative study between these two was also done, and it was shown very clearly that there was reduction in total corneal staining at 1 month and subsequent visits, which was statistically significant. Also reduction in the symptom severity as far as the patient symptoms were concerned, and again this was found to be statistically significant. There was improvement in visual acuity also, which correlated with the reduced central corneal staining, again which was as early as day 56, and there was significant clearing as well as improvement of the tear production, which was seen in the patients when the Sequa was compared with the vehicle, and this is, I think, also something which is expected. This is an important study which was not done here, was done in US, but it gives you the real world treatment patterns in patients with dry eye disease who are either receiving Sequa or receiving some other cyclosporin or levetiracetam, which goes on to say that the patients who were on Sequa continued their drug longer as compared to levetiracetam and as compared to cyclosporin 0.05%, and this becomes an important study because the insurance is paying for the cost and the patients are not paying for the cost. So this gives you a true kind of a picture where the finances or the economics are not involved. More than 95% of the patients do experience either no or very mild irritation on installation of Sequa, and compares well with the other molecules of topical cyclosporin which are available. And in 6% patients there was also hyperemia, which was again very mild. Now, as far as the long-term safety evaluation is concerned of 0.09%, percentage of worse eyes with increase in Schirmer's score more than 10 at week 12 very clearly shows that Sequa scores over the vehicle. And again, this was the same for clearing of the central corneas. And adverse events again were seen, and there were hardly which was seen with the Sequa. Now, this was a study, animal model, which compared Sequa with restasis, and again Sequa scored over restasis as far as the tear production was concerned, or the goblet cell density population was concerned. Now, these can be safely given with the artificial tears, and this is a study which corroborates that. They can be given with topical steroids, and these are several of the studies which again corroborate that, because the improvement is there not only in the signs but also the symptoms, so they can be concomitantly given with steroids, and even they can be given for pre-operative biometry as well as higher order abrasions, especially in patients of dry eye who are undergoing cataract surgery, because it improves the biometry as well as the higher order abrasions both when these parameters were compared pre-operatively before the cataract surgery. So to conclude, from day one, I think there's no or mild installation at the site pain for more than 95% of the patients. After just 14 days, it begins to act as opposed to the commercially available drugs which act at about 6 weeks. There is reduction in the symptoms, improved visual acuity is there, and there is reduction in the signs as well. And after nearly a year, more patients still continue to use nanomicellar cyclosporin, that is CEQUA, as compared to the other immunomodulators. And I think the side effects which have been reported by other formulations are seen less with CEQUA. Now, having said this, I think there is a need to compare all the three drugs, CEQUA, Cyclysis PF, which are both 0.09%, which is 0.09 and 0.05%, Restasis, and I think even cycloimmune, because that is 0.09%. So I think which of the cyclosporins is actually good would be cleared in the picture when you do a study comparing that. But one thing is definitely sure, that CEQUA does act faster as compared to the other cyclosporins which are available. So thank you very much for your kind attention.
Thank you so much, ma'am. So any comment?
No, thank you very much, and I fully agree with what you said, that cyclosporin 0.09% with this nanomicellar thing, it has a very high, good penetration. So which I feel is almost equivalent to 2% cyclosporin, which we used to give for ocular surface inflammation cases. So it's a good drug to be used.
Yeah. And also it allows you to taper your steroids much faster, because
Right.
it takes over much earlier.
Sorry? Which one? 0.05?
We don't know yet.
It depends whether you've started the patient. I am now very liberal with the use of 0.09% cyclosporin. I mean, first straight away in ocular surface inflammation, because I've seen it working very fast. Within 2 weeks, the results start coming. And patients are very, very comfortable after that.
So I think also there could be a different set of indications for Cyclysis PF and for CEQUA both, because I feel CEQUA, maybe because we see a lot more, and ma'am also you see a lot more.
Practice.
It depends on your practice, because the more severe ones I think I would treat with CEQUA, and the less severe ones maybe with Cyclysis PF.
Yeah.
Did they do a comparison between the nanomicellar
and the
0.9 and
Cyclysis
the
PF.
non-minus, the normal 0. With the normal?
Yeah, that has been done.
Or only
Intraocular
because I saw
penetration
only-
has been done.
So they have done only 0.05% nanomicellar versus 0.09% nanomicellar.
And they did with vehicle as well.
And they did
didn't
with
do,
vehicle as well. Vehicle we
nanomicellar
understand.
without nanomicellar with the same concentration.
No, that has not been
So
done.
that is one of the.
So that's why I said cycloimmune also, because cycloimmune is again a product which is by Sun Pharma, and when they tell you, you start CEQUA, then you say, what do you do with cycloimmune? That is also your product. So when, and it's the same concentration. So they come up with this, that this acts faster.
No, it's 0.1%.
So
and this is
0.09 and
but this
0.1
is
will-
water soluble, and that is emulsion.
Emulsion.
So I have a feeling that it is the penetration which makes a difference. If some one you're just putting on the surface, another one goes into intraocular. With 0.09%, you have seen 1500 microgram in the aqueous. While with others, the intraocular penetration is not that good. So that's the reason there may be a difference.
No, but do you require intraocular penetration for dry eye? Again, that is something
yeah, that's
which,
what I'm
you know,
saying,
needs
the
to be
indication. Yeah,
debated.
I agree with you.
You don't,
That I-
you need to treat
that
the
I agree with you. That I agree with.
And with cycloimmune, there is a lot of stinging also, much more than what
Because
you
it's
get.
oil based.
Yeah, because it's emulsion in comparison to
So,
Cyclysis
yeah,
or
yeah.
CEQUA.
So that's what I'm saying. Sun Pharma makes both of them, cycloimmune and CEQUA. So you
There's
tell, what do you tell? And what do you tell the patients who are already on Restasis? Stop now and start CEQUA. Or what do you tell? Yeah.
No, if somebody is on restasis and lubricants and very well controlled, I will not change.
Then change nothing about it.
I will not do anything about it, you know.
There's another newer product with vitamin D in it.
Yeah.
So that also might be worth comparing.
Cyclosporin with vitamin D?
Correct.
Yeah, there's another one, cyclosporin
that
with vitamin D.
Might be interesting to
I
have
think
that
that is from Entod, if I'm
Entod,
not mistaken.
Entod
Yes,
has brought
Entod. So we have another company, sir, Entod, cyclosporin. So I think I will go to the next talk and...
Just one query, like if you look into this study-wise, they have compared, 0.05 and 0.09 in terms of patient's symptoms and disease stages. I think best would be, because this is the immunomodulated drug, so you have to look for a
biomarkers as well.
Pre-baseline biomarker, then see what happens after 1 month, 3 months, 6 months. That will actually give the,
So then in that case you need to have IL-3, IL-17 and then which kit to be used.
So that
all those things.
I think that should have been the major criteria for a success.
So that is what we were planning at the dais, that we would plan a multicentric study. And sir, you've given the cue to the same, that to know.
I think let's go on to next because we are close to 12 o'clock.
So again, I would be talking to you about something which everybody must be doing or would be wanting to do or would be contemplating whether to do or not, and that is role of intracameral moxifloxacin in prevention of post-cataract surgery endophthalmitis. There are no financial or proprietary interests. Of course, endophthalmitis is decreasing in the current times from 0.05 to 0.1 to now much less. And preoperatively, I've put this slide because the role of povidone iodine instillation in CONSAC for 5 minutes cannot be undermined whether moxiflox is there or not there. And of course, in post-operatively, you do have to give topical antibiotics. Globally, coagulase negative staph is probably the commonest. In India, I think there are other infections also, such as fungal infections, which play an important role. This is the ASCRS endophthalmitis prophylaxis survey from 2007 until 2021. And in 2021, 66% of the respondents said that they would be happy to use it. This is the latest survey, 2021, which very clearly says that increased adoption of intracameral prophylaxis, people would want it to as much as about 93%. We have various drugs, cefuroxime, moxiflox, vancomycin, cefazolin, but moxifloxacin, I think, overscores over the others because of the fact that it is commercially available, wide spectrum of action, and because of the concentration dependent killing. ESCRS study of prophylaxis for post-op endophthalmitis after cataract surgery was started but was aborted in between because of the starking results, and there was 5 times reduction in endophthalmitis, and so in between only this study was aborted. There are concerns with cefuroxime because it has to be compounded in pharmacy, and emergence of the resistant gram-negative isolates is always there. Vancomycin we've been giving from quite a period of time, much before cefuroxime or moxiflox, but this clearly study showed that there could be vancomycin associated hemorrhagic occlusive retinal vasculitis, and so this was not being given. Intracameral moxifloxacin is given in the dose of 500 micrograms per 0.1 ml, and we have studies from Arvind Eye Hospital, a retrospective study in more than 1 lakh patients where there was 4-fold decrease in the patients undergoing MSICS, analysis of 6 lakh surgeries again, which clearly shows that endophthalmitis does decrease 3.5 times, and the posterior capsular tear rate increases the endophthalmitis by 7 times, which is decreased by use of intracameral moxifloxacin to 0.2% from 0.48%. Then there are various other studies from various other parts of the world which have also clearly shown that there are no severe complications, TAS, etc. with moxifloxacin, and it is quite safe as far as the endothelial cell loss, the pachymetry, the intraocular pressure, anterior chamber reaction, etc. The parameters are concerned. If you see the cost-effective analysis again, vis-a-vis treatment of endophthalmitis, I think it is much more cost-effective. This was the first survey that we did from AIOS, which was wherein more than 4,000 members responded. So the response rate was 30%, and I think this is one of the largest surveys all over the world, which clearly showed and compared findings with 2014 ASCRS survey, because that was the one which was available at that time. There was similarity in decision for pre and post-operative antibiotics and intracameral antibiotic, but dissimilarity in the choice of intracameral antibiotic and decision for subconj antibiotic. So AIOS members were still giving subconj, and this was in 2017. In a more recent survey, we had different findings. 17 studies with more than 9 lakh eyes, again a meta-analysis favored the use of intracameral antibiotics, and this is the only randomized control trial. Again, the power of this is not great because the sample size is 3,000 only, but again it showed that intracameral moxifloxacin group had endophthalmitis rate of 0.05 vis-a-vis 0.38 in the control group. This is the second survey which was done from AIOS, And again, this survey concluded that intracameral antibiotic prophylaxis for cataract surgery has significantly increased in India from 40% in 2017 to 58% in 2022. And the younger ophthalmologists were giving it much more than the more experienced ophthalmologists who had more than 10 years of experience of practicing. And it was being given less in medical colleges as opposed to the private practitioners. We have completed our randomized controlled trial, a prospective evaluation of intracameral moxiflox for prevention of post-cataract surgery endophthalmitis. And now this was an interim analysis when we were doing for 16,000 patients, but we've now recruited close to 24,000 patients. And we did find that in cases where intracameral moxiflox was given, there was endophthalmitis was much less as compared to the control group, but the analysis and the sub-analysis is something which we are looking at, again in those cases where PCR also occurred. Now this moxifloxacin, which was initially being given by Novartis, is now marketed by JB Chemicals, and we've used this intracamerally with good results. And the second one which you can also use is the Moxisip, which comes from Cipla and which can also be used intracamerally. A word of caution by the Aegis advisory which was given by them, and this was the proper concentration and dose should be used. So there are two different concentrations which are more available. Not so here, but in US 0.5 and 0.1%, and there is increased TAS in those cases if you don't use the proper concentration or the proper volume of the drug, and so one has to be careful about this. So to conclude, intracameral moxifloxacin is safe and efficacious in prophylaxis of ENDOPH, and additional use of topical antibiotics of course would be needed after cataract surgery, and some surgeons even give it pre-operatively. So I think the study that we are doing at RP Center is going to be the largest in the world, which is going to clear the picture of intracameral moxiflox. Having said this, one must always realize that there could be resistance to even this moxiflox, and we don't know how long can we keep giving moxiflox to prevent endophthalmitis. Thank you very much for your kind attention.
Thank you so much, ma'am. May we have the last talk by Dr. Devang? Any questions?
Bilateral iris, this thing, depigmentation and transillumination. And bilateral iris transillumination, they say is a very serious side effect where they have atonic pupil, hazy cornea, and increased intraocular pressure. But I have not seen any other case reports being published, but that group clearly mentions that these are serious side effects to be taken into account.
So I think, like I said, the concentration and the volume is important. And
they use 0.5%.
So
0.5%.
So
1 cc or 0.5.
So that is important, and we don't know because that is only one article which says so. But there is AC, little amount of AC reaction and some amount of corneal element, which is not visually significant, has also been reported by others. So
I don't know the details, but they reported 4 cases. But this was subsequent to that.
I think
the way
Jitendra,
they take it up, take it up, taking into, when you are, loading it into an injection, by that also there can be some contamination, and that can give rise to some, low degree of TAS, or that can also result in these.
So I think one of the biggest issues is the GMPs. Whenever these products are being manufactured, see, we can only control our environment. So 2 things are there. One is an idiosyncrasy, wherein this patient may be sensitive to something. The other possibility is that the product itself has a problem in the manufacturing practices over which we have virtually no control. So we've all experienced TAS, and sometimes we pull our hair out because we cannot understand what is going on. And I feel sometimes it is a batch of one of the 10 products that we use inside the eye, which is the culprit. It could even be something as simple as the cannula, and the way they use the adhesive, the plastic they have used, how they have swatched the metal part to the plastic, every little thing. So, I mean, those are anecdotal experiences, and I don't think we should use that to determine our approach to use of prophylactic antibiotic.
It also depends on the setting. Now, Arvind gave study of 1 lakh plus and 6 lakh plus.
6 lakh cases,
But
no side effects.
One, it is retrospective. 2, they are in camp settings. So we really don't know. And 3, they are SICS. So I think all those things also have to be taken into consideration,
No, the
especially
6
the
lakh
1 lakh plus is a SICS, 6 lakh plus is a FACO study.
emulsification.
So I think those things have to be taken into consideration. Vis-a-vis, if we do a study and say, I'm not saying anything, but vis-a-vis where you do it in non-camp settings. So that is also going to make a difference.
I think why not use the pre-filled syringes where you don't have this another factor coming in, take the drops, putting in, then put in cannula. Cost is not, there's hardly any difference. Hardly any
GMP.
difference.
Even the person making the pre-filled syringes
Entod
has
and
to-
Oro makes it. Pre-filled syringes are available, and I've been using that for, I think, last 7-8 years.
Study has come where they said when no moxie was used, there was no difference in the, there was no difference in endophthalmitis, even if when no intracameral moxie was used. So, I personally don't use it.
Ma'am, the last statement what you said is that already we are using moxifloxacin for last 8 years. Are we looking at a newer molecule because 2-3 years down the line the incidence of resistance will increase? So any...
That's what I'm saying, there is no end to it. We use moxifloxacin, what next will you use? We were using vancomycin.
In that scenario, we have to prove that you don't require intracameral antibiotics. So you don't have to search for a new molecule which will go inside the eye. And looking into the incidence or rate of endophthalmitis, 1 in 10,000, 1 in 20,000, to require a huge sample size to prove or disprove things. So that is the major challenge we are facing.
So that is why we took this sample size, because the power of the study with this is 85%. And that is why people in the West are unable to do such voluminous studies, because it costs a lot. ESCR has started this study 10 years ago, 8 to 10 years ago when they finished the CIFAR exam, but they could not do it because nobody funded it.
Yeah, I think given the option, I would like to prove or disprove this.
They announced it also, sir, but nobody funded it.
So that is true, and we have been using, Vigamox, the bottle, for such a long time, and we never had a task type of thing here. Then, if you look for a single manufacturer, we are making the disposable.
Again, nothing against if you use Vigamox is different, but sometimes you have a moxifloxacin from other company, which says that moxifloxacin made in UK.
So
right? So when you go and look into it, it's made in Uttarakhand.
Normally
right?
made in India only, and the patches are...
So technically you are putting moxifloxacin, but one has seen reactions with others.
So that is what Rishi is saying. We are not sure which batch and how it is. So you have to have one particular brand with you and have an experience with it.
A very good afternoon to everyone. At the outset, I would like to thank Sao for giving me this opportunity. I would be speaking on dry eyes associated with anti-glaucoma medications. So if we come on to the disease per se, glaucoma is a age-related chronic progressive degenerative disease, and you look at dry eyes is a multifactorial disease of tears and ocular surface, and both are age-related. So they are going hand in hand here. And if you look at various prevalence studies of dry eye in glaucoma, we have seen a high prevalence in various parts of the world. And if you review the literature, we have seen that ocular surface disease is common in those using topical anti-glaucoma medications, and abnormal tear film breakup time is associated with an increasing number of eye drops, especially BAK containing eye drops. And the prevalence of ocular surface disease signs and symptoms was high in glaucoma patients who are taking chronic medical treatment. So glaucoma patients, why are these patients predisposed to dry eyes? Glaucoma is as discussed previously, that it is more prevalent with age. If you see that the prevalence at 40 years is nearly 0.3%, it increases to nearly 3.3% if the age is more than 70 years. These patients, they have a pre-existing ocular surface disease in old age. They are chronically on anti-glaucoma medications, and most of these are preserved BAK containing medications, and they are also on multiple medications, not on single medications. And most of these patients also might have gotten operated. They have a bleb, due to which the ocular surface or the tear film is not continuous, leading to all these symptoms. And the effect of aging has a toll on the lacrimal gland, on the ocular surface, and also in the systemic status of the person. So if you look on to anti-glaucoma per se, the effect of anti-glaucoma per se on ocular surface, if you look on to the class of alpha adrenergic agonist like brimonidine, they have a high incidence of ocular allergy compared to other topical AGMs. Prostaglandin analogs, it has been shown that they cause a obstructive meibomian gland dysfunction when used chronically. And beta blockers are well known to reduce basal tear turnover rate of the lacrimal gland, reduce basal and reflective tear secretions, and cause xerotic changes in conjunctival epithelium. And apart from all these medications have BAK, which is benzalkonium chloride, and they are multiple drops are being used over a long period. All these leads to disruption of the homeostasis of tear film and ocular surface, loss of goblet cell, meibomian gland, and accessory lacrimal glands, disruption of corneal epithelium and a reduction in corneal sensitivity, disruption of the tear film and thinning of the mucus, aqueous, and lipid layers. The effects of long-term anti-glaucoma drops on conjunctival structures, it has been shown that there was a significantly decreased goblet cell density, increased dendritic cell density, and increased subepithelial fibrosis. Another study from our center, wherein the ocular surface evaluation in eyes with chronic glaucoma on long-term chronic anti-glaucoma therapy, apart from poor tear film status, we also noted that the long-term topical anti-glaucoma therapy is associated with a decreased subnasal nerve fiber layer density. So if you look into the preservatives that are being used, the most common is BAK, and BAK sparing like polycotonium 1, SOC, sodium perborate. And the problem with BAK is that it has a detergent action which dissolves cell walls and cell membranes, vis-a-vis others which are not as destructive as BAK. So BAK is the most common preservative. It disrupts the ocular surface and alter the corneal sensitivity. It causes destabilization of goblet cells, and it induces squamous metaplasia. And if you look into studies, they have shown that BAK containing prostaglandin was associated with decreased tear secretion and associated with tear film instability. And ocular surface side effects should be considered with when prescribing BAK drugs. Also, increased incidence of adverse events with BAK have been demonstrated that the withdrawal of preservative reduces these side effects, and preservative-free treatments have clinically relevant benefits for patients. So if you look, how do we manage such patients? First is to minimize the effect of AGMs on the ocular surface, and second is to recognize and treat the ocular surface disease as early as possible and manage the course. So we first reduce the exposure to BAK. We shift them to alternative preservatives, preferably use a preservative-free medication, and choosing combination therapy if the patient is on multiple drugs. And if you look at efficacy, safety, and improved tolerability of travoprost BAK-free ophthalmic solutions, it was noted that switching from BAK preserved latanoprost and bimartoprost to Sofzia preserved travoprost, there was a increase or improvement of the OSDI score, decrease in the conjunctival hyperemia, and improve in visual acuity. And also a switch from preserved prostaglandin timolol fixed dose combination improved the tolerability and optimized the IP control, providing better adherence with greater chances of treatment success. And also preservative-free trafluprost treatment resulted in improved quality of life, increased patient satisfaction, and drop comfort. So it was noted that preservative-free formulations of glaucoma medications have become popular to avoid the ocular surface irritation, and studies comparing the effectiveness of these formulations have shown an improvement in ocular surface symptoms when patients are switched from BAK to preservative-free medications. And Jonan et al. Found that pain during drop instillation, foreign body sensation, burning, and dry eye sensation were significantly decreased in patients using topical preservative-free beta blockers. So, as has been discussed in previous lecture, that ocular surface management per se, preferably in these patients, we should use preservative-free lubricants. Early intervention is the way to go, and use of topical cyclosporin may help in these patients. So this was a 60-year-old patient with primary angle closure glaucoma, and she presented with foreign body sensation and increased grittiness after 3 or 4 months of use of medication. On doing the tear film breakup time, we could see that there was an immediate breakup in the right eye of the patient, and on the OSA, that is the ocular surface analyzer, we can see that there was a meibomian gland loss more in the advanced eye with respect to the fellow eye. And in the lipi view, we could see that there was a decreased lipid layer thickness in the advanced, where the patient was, the eye in which the patient was using multiple anti-glaucoma medications. So after proper management, at 3 weeks follow-up, everything was fine and the signs and symptoms resolved. And alternative treatment modality should be considered in patients who are intolerant to glaucoma medications or have very severe OSD. Glaucoma lasers or some form of surgery may be required if they are intolerant to these medications. And there are newer medications in the pipeline. Few ones are already released, the Novelia technology, preservative-free formulations, bimatoprost ocular insert, latanoprost punctal plugs, latanoprost eluting contact lenses, and bimatoprost and travoprost intraocular implants. And at the end, I would like to say that the coexistence of glaucoma and ocular surface disease is an important consideration for patients and ophthalmologists. Shifting to a BAK-free anti-glaucoma medication is recommended, preferably preservative-free, for improving the OSD and related quality of life. Use of combination medications if the patient is on more than one medication. Early identification and timely management is the key. And explain safe methods of topical anti-glaucoma delivery, like number of drops, installation in the lower fornix, only 1 drop to be instilled vis-a-vis patients who just put the drops, a couple of drops, wiping of the extra overflow drops, and punctal occlusion immediately after anti-glaucoma medication installation to the patient should be counseled for. Thank you for the patient listening.
Thank you so much. We apologize to the next session.
Just one question. You rightly pointed out we should use a preservative-free anti-glaucoma medications, but many patients do still require artificial tears, lubricant drops. So when should they put, before instilling the glaucoma medication or after glaucoma medication or together with the glaucoma medication?
So it is better to put after a certain interval, a gap of at least 5 to 10 minutes. So I think any of the thing can be put, but if
Dr. Asmar बैठे बताएंगे.
If many a times the patient says that the actual anti-glaucoma is stinging a lot, so in that case we can put the lubricant first and that later. But there has to be a gap of 10 minutes. So.
Certainly, there are many medications which don't sting. And then few of our patients.
Where they sting.
हाँ.
अगर बाद में डालेंगे sting तो हो गया already.
So what has happened with our patients that they put the lubricant पहले and they forget the AGM. तो हमारे लिए AGM is.
So that is very frequent. They keep putting lubricant.
इसलिए so for us AGM is the priority.
Thank you. Thank you.
Thank you so much for being a patient audience. We hand over to our next session and we'll have a quick photograph. So hand over to Namrata ma'am.
We are going to have inauguration now after this, and I would request Dr. Lalit Verma sir to please take over. Meanwhile, the speakers who are left can have a quick photograph.
We don't believe in inauguration, but since we have some time, so I'll request Chief RP Center Dr. Harsh Rajesh to please come and Namrata to join.
सम्प्रदाय शत्रुबुद्धिविनाशय दीपज्योति नमोऽस्तु ते। शुभं करोति कल्याणम् आरोग्यं धनसम्प्रदाय शत्रुबुद्धिविनाशय दीपज्योति नमोऽस्तु ते। शुभं करोति कल्याणम् आरोग्यं धनसम्प्रदाय शत्रुबुद्धिविनाशय दीपज्योति नमोऽस्तु ते। शुभं करोति कल्याणम् आरोग्यं धनसम्प्रदाय शत्रुबुद्धिविनाशय दीपज्योति नमोऽस्तु ते। शुभं करोति कल्याणम् आरोग्यं धनसम्प्रदाय शत्रुबुद्धिविनाशय दीपज्योति नमोऽस्तु ते। शुभं करोति कल्याणम् आरोग्यं धनसम्प्रदाय शत्रुबुद्धिविनाशय दीपज्योति नमोऽस्तु ते। शुभं करोति कल्याणम् आरोग्यं धनसम्प्रदाय शत्रुबुद्धिविनाशय दीपज्योति नमोऽस्तु।
I think without wasting time, we'll start the next session, and I request Dr. Harsh, Vishnu, and Dr. Bhalla, as well as Dr. Deventuli to please join on the stage and start.
Thank you, Dr. Lalit, for having us here, and I think we'll straight away launch, and we'll try and give small tips and stick to the time. Vishnu ji, आइए.
Give small, but give many.
आ जाओ भाई. Vishnu, come. Devin.
So we start our glaucoma session, and I'll request Dr. Harsh Kumar to start the first talk.
Okay, thank you, Dr. Bhalla, Dr. Vishnu, Dr. Devin, and Dr. Tanuj, Dr. Devang. So the first thing is, which glaucoma medications to start with in what kind of situations? So the first thing is, yes, we have to make sure, is it glaucoma? Number two, you have to know which type of patient I am treating. अब तुम उसको लिख दोगे एक बहुत महंगी सी दवाई और वो गरीब सा आदमी है तो वो डालेगा ही नहीं उसे. तो वी मस्ट नो कि whom I am treating. क्या हमारा टारगेट प्रेशर है भाई, विच मेडिसिन शुड आई स्टार्ट विद, पेशेंट कंट्रोल्ड है कि नहीं. पर सबसे बड़ी बात जो लॉट ऑफ यंगस्टर्स फॉरगेट इज़ दैट पेशेंट एक दवाई लिखवाने नहीं आया, ही हैज़ कम देयर टू बी हील्ड. सो यू हैव टू टेल देम कि भाई अगर मेरे पास रेगुलरली आओगे, हर 3 महीने में प्रेशर कराओगे, 6-9 महीने में फील्ड करा लोगे, आई एंश्योर दैट यू विल बी ऑल राइट. नहीं तो वो गूगल से पढ़ के आता है कि भाई ये ब्लाइंडनेस हो जाती है इसमें एंड ही इज़ कम्प्लीटली शैटर्ड. सो प्लीज़ बी वेरी वेरी केयरफुल अबाउट दैट. यू हैव टू कोरिलेट द डिस्क विद द फील्ड एंड योर फाइंडिंग्स टू मेक श्योर दैट येस वी आर डीलिंग विद ग्लोकोमा. हमें पता है कि भाई प्रेशर तो लो करना ही है, सारी स्टडीज़ बता चुकी हैं हमें. सवाल ये है कि सिर्फ प्रेशर लो नहीं करना, बट प्रेशर को हर समय लो रखना भी ज़रूरी है. So diurnal variation is a part of the game, and you have to ensure that as low the variation, the better are the fields protected. And normally लोग कहते हैं सर बड़ा मुश्किल है, हमें तो करना, हम नहीं कर सकते. But there are 2-3 situations, जैसे normal tension glaucoma है, ocular hypertension है, क्योंकि नॉर्मल टेंशन में हमें बहुत सारे और टेस्ट करने पड़ते हैं. तो एक बार तुमने डायरनल वेरिएशन किया, एक प्रेशर आ गया 24-26, तुम्हें पता है कि ये है ही नहीं नॉर्मल टेंशन भाई, Ocular hypertension में if everything is normal and yet the pressure is coming more than 26, 28, we have to treat that patient. तो इन लोगों में diurnal variation करना बहुत आवश्यक है. और सो दैट इज़ इम्पॉर्टेंट. कितना रखना है भाई टारगेट प्रेशर, ये सबसे ज़रूरी चीज़ है. तो अगर माइल्ड ग्लॉकोमा है तो पहले हम 20 से 21 से कम करते थे, पर हमने अपने धीरे धीरे तापमान और कम कर दिए हैं. तो हम कहते हैं भाई 18 से कम करो, लोग कहते हैं 16 से कम करो. और अगर मॉडरेट है तो 14-15 रखो. उससे भी अगर बहुत एडवांस्ड है तो भाई जितना लो रहे तो अच्छा है, 8 से 12 के बीच में रहे. वी आर वेरी गुड एंड हैप्पी विद दैट. बट दिस इज़ द इनिशियल थिंग. एक बार हमने ये कर लिया, उसके बाद आप फिर तो काफ़ी दिनों बाद करोगे तो एक डायरनल कंट्रोल करके देख लो भाई कि प्रेशर सारे टाइम पे कंट्रोल्ड है कि नहीं, कि जितना तुम चाहते हो है कि नहीं, हमें दवाई और ऐड करनी है कि नहीं. क्योंकि फील्ड तो हम कम से कम 3-4-5 महीने बाद ही करके देख पाएंगे. तो मेडिसिन स्टार्ट करने से पहले हमें ये देखना पड़ेगा भाई मैक्सिमम प्रेशर लोअरिंग होनी चाहिए. एक ही दवाई चले तो बहुत अच्छा है. कोल्ड चेन ना हो, क्योंकि हिंदुस्तान में कोल्ड चेन तो मुश्किल से ही मेंटेन होती है. डायरनल वेरिएशन को ब्लेंड कर रहा हो, मिनिमम साइड इफ़ेक्ट्स हो, आउटफ्लो इंक्रीज़ कर रहा हो तो बेहतर है. और न्यूली डायग्नोज पेशेंट है तो भाई अगर तुम्हें ये तो पता नहीं कितना प्रेशर था, क्या हिसाब किताब है, बट अगर फैमिली हिस्ट्री पॉजिटिव है, और कई लोग बोलेंगे कि फैमिली हिस्ट्री पॉजिटिव है, पर उसका देखो तो सही, उससे बोलो भाई रिकॉर्ड दिखा, तो पता लगता है कि उसके फादर को सिर्फ ऑकुलर हाइपरटेंशन था. देन यू आर नॉट सो वरीड. और एक और आदमी दिखाएगा कि भाई एकदम एडवांस डैमेज हो गया है, देन इट इज़ अ वेरी वेरी डिफरेंट थिंग एंड यू हैव टू बी वेरी एग्रेसिव. साथ में अगर स्यूडो एक्सफोलिएशन है, इनिशियल प्रेशर्स हाई हैं, पिगमेंट डिस्पर्शन वगैरह है, देन यू नो कॉर्निया इज़ थिन, देन यू आर वरीड एंड यू हैव टू बी अ लिटिल मोर एग्रेसिव. फर्स्ट लाइन थेरेपी में क्या होता है, कई लोग चल भाई चल सारी दवाई शुरू कर दो, पेशेंट आ गया है 30 पे तो तुम इतने घबरा जाते हैं जैसे पता नहीं क्या हो गया. सो इतना पैनिक करने की कोई ज़रूरत नहीं है. यू हैव टू स्टार्ट विद अ सिंगल ड्रग एंड द फर्स्ट लाइन इज़ ऑब्वियसली अगर पेशेंट अफोर्ड कर सकता है तो पीजी एनालॉग है, अगर नहीं अफोर्ड कर सकता तो बीटा ब्लॉकर है, बिल्कुल नहीं अफोर्ड कर सकता तो ट्रैप कर दो उसकी. तो ये सारी चीज़ें ध्यान में रख के चलना है. तो 20 to 30 अगर उसका है प्रेशर तो डेफिनेटली वी वुड लाइक द पीजी एनालॉग टू स्टार्ट विद. उसको स्टार्ट करने की, या बीटा ब्लॉकर तुमने स्टार्ट किया, 3 हफ्ते बाद उसका प्रेशर चेक करो, देखो अगर 15% से कम प्रेशर लोअर हुआ है, दैट मीन्स देन इट इज़ नॉट इफेक्टिव, देन यू हैव टू स्विच और यू हैव टू ऐड. अगर प्रेशर 30 से ज़्यादा है तो वी विल अलाउ दैट येस यू स्टार्ट विद मोर देन वन मेडिकेशन इफ़ द डिस्क इज़ कॉम्प्रोमाइज्ड. इफ़ द डिस्क इज़ नॉट कॉम्प्रोमाइज्ड you can still start with one medication because you'll be so surprised sometimes that कि उसमें PG analog से कितना ज़्यादा lower हो जाता है. So at least we'll know what is going on. But अगर disc compromised है then we have to start with more than one medication. और अगर pressure 40 से ज़्यादा है then we have to be very very careful because nothing is going in, so you first have to lower it by either Diamox, glycerol or other oral anti-glaucoma medications. फिर हमें क्या ऐड करना है, अगर पीजी एनालॉग है तो ऑब्वियसली टिमोलॉल उसके साथ कॉम्बिनेशन आता है. अगर फिर भी नहीं काम कर रहा तो डॉर्ज़ोलोमाइड, ब्रिंजोलोमाइड या फिर ब्राइमोनिडीन या फिर रॉक इनहिबिटर्स. बट प्लीज़ डू नॉट फॉरगेट पाइलोकार्पिन इज़ अ वंडरफुल ड्रग इफ़ द पेशेंट कैन नॉट अफोर्ड. बहुत सस्ती दवाई है, कुछ लोगों को टॉलरेट नहीं होती, बट अगर होती है तो समटाइम्स व्हेन नथिंग वर्क्स पाइलोकार्पिन वर्क्स, सो डो नॉट फॉरगेट अबाउट पाइलोकार्पिन. अगर ACG है तो येस यू विल हैव टू गो एंड डू अ पेरिफेरल आयोडोटमी बिफोर यू डू एनीथिंग एल्स. कई तरह की दवाइयाँ हैं, सबसे कॉमन बीटा ब्लॉकर ही यूज़ होती है. तो ये ध्यान रखना है भाई कि प्लीज़ कार्डियक के लिए हम लोग पूछ लेते हैं, ये भी पूछ लेते हैं भाई पल्मोनरी प्रॉब्लम तो नहीं है, एस्थमा वगैरह तो नहीं है, बट बी केयरफुल बिकॉज अ लॉट ऑफ यंगस्टर्स आर नाउ है taking antidepressant medication. They are very worried about their libido also. So all these things also, because beta blockers can create a problem over there. So please be careful about that. Punctal occlusion is a must in these kind of situations. Children में beta blockers के लिए careful रहिएगा because 1 drop of 0.5 is cardiac blocking dose in infants less than 2 years. Brimonidine में एक टिप यही है बस कि yes यंग लोगों में 6 साल से नीचे में नहीं यूज़ करना है. प्लीज़ ध्यान रखना, कई लोगों को इतनी नींद आ जाती है कि इफ़ दे आर ड्राइवर्स एंड ऑल इट कैन बी डेंजरस फॉर देम. and some of them will tell you that कि सर क्या दवाई दे दी, बिल्कुल मैं तो सारा टाइम सोता रहता हूँ, you have to change it. Also you have to tell them कि कई बार allergies develop होती हैं, वही दवाई कई दिनों से चल रही है, this is the only drug which will suddenly create allergies and which is looking very much like blepharitis. So be very careful about that part. ये हम पहले ही बात कर चुके हैं. और डोरजोलोमाइड, ब्रिंजोलोमाइड वंडरफुल ड्रग्स, TDS डोज में यूज़ कर सकते हैं, BD भी कर सकते हैं. सल्फा एलर्जी है तो अवॉइड करनी है. कोई भी कॉर्निया में डीकम्पनसेशन है देन वी शुड नॉट यूज़ दिस. PG एनालॉग्स ऑब्वियसली इज़ द क्लासिकल ड्रग. एक बार सिर्फ रात में पड़ती है, सो इट इज़ द बेस्ट वन फॉर अस. एंड कई लोग पूछते हैं भाई कौन सी सर PG एनालॉग में, तो बहुत सारी हैं. तो इफ़ यू वांट मैक्सिमम लोअरिंग देन डेफिनेटली द बायोमेटोप्रोस्ट इज़ बेस्ट. मिडिल में ट्रैवोप्रोस्ट आता है, और अगर बहुत ही एलीट पेशेंट है जिसको ज़रा भी लाली वाली से दुख होगा तो उसको लिए आप लेटानोप्रोस्ट यूज़ कर सकते हो इन सम फॉर्म. साइड इफ़ेक्ट्स इसके यू हैव टू बी वेरी वेरी केयरफुल. पेरीऑकुलर पिगमेंटेशन हो सकती है, डू नॉट अलाउ दैट टू हैपन. वंस इट सेट्स इन फॉर अ लॉन्गर टाइम इट विल बी इरिवर्सिबल. जल्दी पकड़ा जाए तो फिर वो इट कैन बी अवॉइडेड. लैश इलोंगेशन, ऑर्बिटल फैट एट्रोफी, sweating, cramps and muscle pain rare हैं, but you can have dews also. So you have to be very very careful about all these things. कई लोग कहते हैं कि भाई हम अगर जैसे कैटरेक्ट के बाद अगर प्रेशर बढ़ गया तो क्या हम यूज़ करें कि ना करें. यू कैन यूज़ इट, बट अगर CME डेवलप हो रही है then which happens in very few cases, but if it develops and you stop the drug it reverses on. So it's not that it is completely contraindicated. ROCK inhibitors are the new thing. The problem सबसे बड़ी उसमें यही है कि बस obviously there is a lot of redness, there could be a subconjunctival hemorrhage also. You have to also be careful that there could be corneal changes in that. Combinations we love to use because preservative free, tolerability, medication washout नहीं होता, dosing frequency less है, adherence is better. एंड ये कुछ कुछ चेंजेस कॉर्निया के रॉक इनहिबिटर्स में आते हैं. यू हैव टू बी वेरी केयरफुल. वी ऑल्सो नाउ हैव ट्रिपल ड्रग कॉम्बिनेशन विच टिमोलॉल, ब्रिंजोलोमाइड एंड ब्राइमोनिडीन इज देयर, एंड अ लॉट ऑफ पेशेंट्स आर बेनिफिटिंग बाय दैट एज वेल बिकॉज द नंबर ऑफ ड्रॉप्स आर डिक्रीज्ड. प्रिजर्वेटिव्स की इतनी सारी बातें हुई थी. वी हैव टू नो दैट येस वी ऑल नो व्हाट इज द प्रॉब्लम विद दैट. Mo has very beautifully shown that. And we do know that there are drugs which are now available which are in two types of bottles. Either they are Aptar bottles or Novelia bottles in which there are no preservatives whatsoever. There are different mechanisms, but we are lucky. I think Cipla has got a full range of them and it is great to use them, but they are expensive. So don't just start off with them because कई पेशेंट मेरे पास लौट के कहते हैं कि सर दाम बहुत ही ज़्यादा है. So when you need them, use them. Yes, they are very very good and the patients are benefiting a lot. So please explain what is glaucoma, what is the schedule for follow-up, explain punctal occlusion, and please tell them that they will be good if they follow up regularly with you. Thank you very much.
Thank you, Dr. Harsh. That was very nice presentation as always. So just two questions. Any like you said, the first line of drug is either beta blocker or prostaglandin. Anywhere you can use the other class of drugs like carbonic anhydrase inhibitors or ROCK inhibitors. There is so much hype about ROCK inhibitors. Can they be used as first line of drugs?
If there is some contraindication both to PG analogs and to timolol, beta blocker group, then yes, but using ROCK inhibitors as the first line is very tricky because invariably they will develop redness. But yes, there are patients who do not develop redness and you can try that. But the lowering of them is less than that of PG analog and beta blocker. So many people will like to start with a combination.
I have one question. Suppose if you compare timolol versus Rho kinase inhibitors. Now the Rho kinase inhibitor is having the problem local toxicity, while the beta blocker they have the problem with the systemic. What is your opinion? Because a lot of studies people have done timolol versus Rho kinase inhibitor. So that means still you will go for the timolol.
Yeah, if there are no specific contraindications for beta blockers, even cost wise they are better. And yes, ROC inhibitors are actually have just been in this, but we see a whole lot of side effects with them eventually. So if there are no contraindications to that, I would definitely like to go initially with a beta blocker, or if we feel that is not enough, then maybe a combination of beta blocker with brinzolamide or beta blocker with brimonidine, which gives a reasonably good lowering of the pressures.
So now we'll invite the next speaker, Dr. Taru Diwan. Dr. Taru Diwan is going to talk on how to modify depending on existing eye problems like corneal changes, uveitis or macular edema.
Mala, you should have congratulated me for finishing in 10 minutes.
Congratulations, sir.
Dr. Harsh's talk is always so precise, so practical and always within time. I think we take it for granted. And but anyway, congratulations, Dr. Harsh.
And Dr. Taru is heading the ophthalmology department now at the RML Hospital and Atal Bihari Medical College.
So we congratulate you before you start the talk.
Please start.
You should say all the best. It needs strength, not congratulations. So okay. Thank you very much. I am thankful to Sao for having me here. So I was allotted the topic to how we would modify treatment and when we have pre-existing conditions like corneal edema, uveitis and macular edema. But it would have been a little too restrictive. It's not just while starting our treatment, we want to look whether there is a pre-existing ocular pathology or not. The same question and the same decision would arise if your patient who is on glaucoma treatment develops the same. Whether it is secondary to your medication or unrelated, it would still, you will still have to take the same decision. So I thought it would be wise to understand what the AGMs actually do. And Dr. Harsh has beautifully summed up everything about the different AGMs, and I'm restricting myself to the topical AGM and just repeating a few things because they are clinically relevant. Like in carbonic anhydrase inhibitors, we know that for them to act, more than 99% of activity of these cytoplasmic and membrane-bound carbonic anhydrase should be inhibited. So when it is acting so well, we have to see that it may act on the other isoenzymes as well, which are present on the corneal endothelium, iris, RP, on RBCs, brain and kidney. So while the systemic has a lot of side effects, the topical do not have so many systemic side effects. Luckily, unless if we don't do what Devang told us to do, we don't tell our patients to do an NLD occlusion, and we are using it much more. But it's important to be aware of the same. And what most patients would come with disruption of taste and stinging and burning, but what concerns us most is the decompensation of cornea. So the decompensation of cornea can occur in, it may not happen in healthy corneas which may be able to tolerate these drugs quite a bit, but the corneas with borderline endothelial function including transplants may not. So but even if the corneas, they do show some changes, if you stop the drug right away, you can expect quite a good amount of recovery. Coming to beta blockers, it has been a good topic of discussion recently, and then they are very good. We have seen them time-tested products giving us good lowering of the intraocular pressure. But like all anti-glaucoma medication, but much more than others, topical beta blockers, they cause topical anesthesia, punctate staining, ocular surface disorders. So they are not very friendly for the cornea, but then they give us a very good IOP reduction, and we can follow the guidelines to prevent systemic side effects. They have to be used with caution in children, in people with the reactive airway disease and with a history of COPD, smoking, asthma, and they are relatively contraindicated in patients with CHF, as sir has already told us. So if patients with heart block, bradycardia and fainting, use with extra caution, because the CNS effects of depression, anxiety, confusion, everything can happen, including impotence and even alopecia, if a proper NLD occlusion is not performed.
the so much wanted PG analogs, they are acting on both receptors, the FP receptors and EP1 receptors. So we are getting patients with either a vasodilatory hyperemia, but we are also getting patients who might be having an inflammatory hyperemia. So locally acting, they can cause redness of the eyes, as we have already learned. But what we are concerned about the corneas, it can cause and has been known to cause reactivation of viral keratitis. In addition, post-cataract CME has been often associated with use of PG analogs, and as they are pro-inflammatory, so a word of caution in uveitis. The hyperemia, iris pigmentation, hypertrichosis, and even the periorbital skin hyperpigmentation in an early stage is reversible. So the key is to identify the same and to stop or change the medication. The alpha agonist brimonidine, it is more selective for alpha-2. It's not purely alpha-2, but it is more selective for alpha-2. And which means that you have to watch out for the other side effects if it is absorbed systemically. But higher concentrations of this product, along with higher concentrations of BAK or BAK at all, it causes more local side effects like the conjunctival hyperemia, periorbital dermatitis, which would be lower if you lower the concentration of the drug as well as remove the BAK. And as has already told us, in neonates and children, it could be rarely serious, causing apnea and coma, so we don't use the same in them. And also in elderly and frail, it could cause drops, and like people could sustain fractures, they fall down, it can cause mental clouding, lethargy. And it is absolutely contraindicated in patients on tricyclic antidepressants and MAO inhibitors. In Sjogren syndrome, this can precipitate the dry mouth. It can cause a lot of dry mouth. So again, occlusion of the NLD and orthostatic hypotension and bradycardia is also known with brimonidine. And myotics, we must never fail to address them. They directly act like pilocarpine, all of us know, have been there for such a long time. Locally, it causes problems like miosis, lacrimation, and induced accommodation and brow ache. Brow ache, of course, goes away after some time. But the thing is that just because we know about it, we can be very smart and we can decide not to use it, probably if you have a patient with a central cataract or something. Not just that it hastens up the cataract, but in cases with pre-existing cataract, it is natural to blur the vision. And as it disrupts the blood-brain barrier, it should not be used in ocular inflammation, because so that's a contraindication. We have been using 2% pilo. Now I don't think 4% is available at all. So even 2% is hard to find. It had to be restarted. So, and as Sir said, it would act only when IOP is below 40 millimeter. So if you have a patient who has an IOP above 40 and you are thinking of putting pilocarpine, maybe it's not a good idea. First lower the pressure and then put him on pilocarpine. While the chronic use side effects are known, the high myopes, you have to exercise a word of caution in high myopes, because high concentrations have been known to induce retinal detachments in them. But then this is about the anti-glaucoma medication to a large extent, but it doesn't complete the picture, because there is another more notorious and more all-pervasive component, which is the preservatives, and Dr. Devang has already told us so much about it. The adverse effects of preservatives in itself are so many that whenever they form a part of our glaucoma medication that we choose, we have to be aware that we are instilling another active drug. Because the BAK preservative, it promotes activation of lipooxygenases, icosanoids, inflammatory mediators, many cytokines like interleukins, and all these cause irritation, delayed hypersensitivity, and allergic reactions. So preservative containing, as such, the glaucoma drops can cause ocular surface disorders, but much more so if they contain preservatives like BAK. And also there have been studies which suggest that preservatives, large amount of preservatives, can make patients more susceptible to development of the pseudophakic macular edema. So it's not just the ocular surface, it could also be penetrating in the eyes and contributing to the development of macular edema. So a lot of information, and we can just unload all the information and apply it to our friends, to our patients who are our friends. And then there are particularly certain situations that we want to address. You may have a patient who has a pre-existing corneal pathology, so you would like to avoid carbonic anhydrase inhibitors, as we discussed, dorzolamide and brinzolamide in patients either who already have a decompensated cornea or those who are prone to develop corneal decompensation. So it might be a good idea to avoid them, like corneal draft and endothelial dystrophy or post-surgical corneal edema. And in patients with herpetic keratitis, it will be good to avoid PG analogs because reactivation can be there, and it has been reported. Use of ROCK inhibitors, ripasidil, which has become so popular now. The ROCK inhibitors, it has been used not just to decrease the corneal edema, but also there have been studies, more and more studies trying to show that it even increases the corneal endothelial regeneration. But I just wanted to share another picture. So it is a good choice, no doubt. But I wanted to share a picture of a patient who came to me last week, and he was on Nitalo. And if you can make out on this, you can see these tiny small specks on the cornea. So this is like the reticular edema that is being caused by, that was caused by Nitalo, and it went away within 1 week of stopping the drug. So as I said, more and more things will keep on coming. It's a new drug. Let us wait and watch before jumping to making it first line, I guess. But it's a personal choice, definitely. In cases with pre-existing uveitis, as we said, myotics are contraindicated, so we need not discuss that. But about the PG analogs, there is a controversy. Yes, they are pro-inflammatory, and there would be many studies and many people who would say that don't use PG analogs in case of uveitis. But there are also studies which would say yes, they were pretty safe in using in uveitic glaucoma. So it's like, and then people have compared the different type of PG analogs and favoring some, like saying bimatoprost may be causing less of uveitis than the other PG analogs. So ultimately the ball lies in your court. If you are aware of a possibility and if you are able to watch, you should be able to take a good decision. Brimonidine, which is like so freely used even in uveitis patients, one must be aware that if your glaucoma patient suddenly develops uveitis, look for cause like maybe the granulomatous uveitis is being caused by brimonidine. So this is also falling in that category. So exercise caution by prescribing these. Beta blockers, carbonic anhydrase inhibitors, ROCK inhibitors, they can all be used. Because again, more and more studies are coming for ripasidil and even promoting its anti-inflammatory effect. But we would wait and watch. And for macular edema, it is multifactorial. So macular edema in glaucoma has been associated, let's say labeled not only just the presence of glaucoma, maybe a type of glaucoma. They say maybe pseudo-exfoliation glaucoma has a higher incidence of macular edema. The PG analogs in itself, the having glaucoma in itself, predisposing them to having more macular edema, but using PG analogs increases the risk. Then younger age, having systemic hypertension, high untreated IOPs, and cases which are like post-op, not just post-cataract surgery, even post-glaucoma surgery, can all develop macular edema. So basically, have a cautious use of PG analogs in eyes who have a high risk factor for CME. But that does not mean that you cannot use PG analogs, because even if you decide against using PG analogs, then have a plan. You need to give a wash-off period of 3 weeks, and then you expect that PG analog will not contribute to the macular edema if it is causing. So have a good pre-op absence of PG analog and a good post-op absence of PG analog if you decide to go against it. And then this is a very extremely important thing which has been covered since morning again and again, pre-existing dry eye disease. So the topical anti-glaucoma medications with or without preservative, both, they have a negative effect on meibomian gland, more so the ones with preservative, but both have negative effect on meibomian glands, and also they have increased the ocular surface expression of inflammatory markers. So all in all, we find that anti-glaucoma medication with preservatives are going to cause a higher dry eye disease, will worsen the dry eye disease in your patients if it is already existing. So, but you have to choose some medication. So go for preservative-free medication. You can add on the topical anti-inflammatory, MGD targeted therapies, which we have all discussed since mornings, punctal plugs, or now we have like lifitegrast and the novel drug delivery systems. Basically, it's all about making wise choices. When you are initiating treatment, watch for the potential of worsening of the said condition, the potential of this new drug worsening the condition that the patient is having, and accordingly choose a safe drug. Go for preservative-free options, and keep lasers and surgical options always in your mind. And if the patient is already on treatment, watch for any worsening with the current AGM, and then you would be following the same rigmarole, going for preservative-free options, managing with supportive therapy, and probably deciding to switch to a safe drug, and again, keeping lasers and surgical options very well in mind. Every patient is not the same. Some patients are going to have a reaction, some patients are not going to have a reactions. The severity of the reaction would vary from patient to patient. The awareness that this thing can happen is the key to be able to either prevent or manage or treat the side effects. But the ultimate goal of maintaining a good quality of life must not be forgotten. Thank you.
So, like you said, and we'll ask, I think Vishnu also, he has done some thesis in the ROCK inhibitors, maybe that's why he asked. So Vishnu, would you like to start it as a first line sometimes?
We have not seen many cases of the subconjunctival hemorrhage or hyperemia. Hyperemia you see even in the Brahminidine cases also. But I don't know, we have conducted the 2 ROCK inhibitors comparative study at our center, and results were quite good, and we were really happy with that.
So results in the term of IOP lowering?
Sorry?
Results
we
in
have
the
not
term
compared with the TMO. We have compared 2 ROCks.
Sir, she's asking about IOP lowering.
IOP lowering and
or side effect profile?
Side effect also.
Both.
Yeah.
Sir का study है कि
Safety and efficacy both.
Can be used
as a first line.
And any drug can be used as a first line as long as it is fitting the parameters of the lowering you want. I mean, if you want only 20% reduction and you have a drug which is giving 20% reduction, then what is stopping you?
Without side effects.
Without side effects.
Yeah.
So nothing
Fair
is
enough.
stopping you.
Fair enough. So we can try any of these drugs.
And Dr. Harsh, what would you like in a patient of glaucoma having corneal, whose corneal endothelium is not very healthy? They say ROCK inhibitors have some role in...
Yes, ROCK inhibitors have that. Taru already, you were out, but Taru had told that. But the only tricky part is that it is actually to be given in QID doses.
QID doses.
So I was also quite shocked that I didn't know that. So somebody told me it is QID doses. So it may create a benefit by endothelial improvement, but at times then it can give rise to what she showed. And I have seen many patients with cornea verticillata and microcystic edema. So
I'm personally very fond of Ripasodil. So nothing against the drug, but then we have to watch. That's we have to be aware. That
Sir, if you have a patient of PBK with corneal edema and you have microcystic changes due to Ripasodil, so how do you distinguish between the two?
I think once there is a microcystic edema, you will stop it. You can't. You would be.
One is bullous keratopathy है उसमें हम.
The very look of bullous keratopathy is different from microcystic edema. I think.
नहीं, but it enhances the endothelial cell count.
हाँ भाई.
Yeah.
So
Anybody?
we are giving for that.
Tanuj, what do you say?
That is a very different picture. There is an epithelial involvement into ROCK kinase inhibitors. That is very different from the PBK you see.
सर वो basically स्ट्रेट बनाओगे ना तो एंडोथेलियम से ओरिजिन है PBK और इसमें इट्स मेनली एपिथेलियम एंड सब एपिथेलियम. तो वो पता चल जाता है जो क्लियर एरियाज ऑफ फ्री ऑफ बोलेगा you will see a very different picture.
And distribution is also a little different.
Decompensated corneas?
Classically you should, but actually the studies on brinzo is so less as compared to dorzolamide, but one has to treat it similarly.
sometimes we are not left with any other drug.
So I think in that regard, your question is correct. Then you use brinzolamide rather than dorsiflupine. As a last resort, if surgery is the last option.
And there theoretically many things are like that, no? Even for that, if you have somebody like Sir also said, somebody with sulfur sensitivity, it's like the salt, the molecule which is there in the antibiotic is very different from the molecules you have in these. So, but still we exercise a caution. So, I am yet to see a patient who is like sulfur sensitive and is putting drops and has developed a reaction. But it is our duty to tell the patient and not to use it as far as
metabolic
possible.
acidosis. कभी
Yeah,
इतना
metabolic
होता नहीं है,
उसमें हाँ, systemic absorption, but we have to keep a caution.
Is there any study showing that there is a difference between these two?
Yes, sir. I think more practical experience. And
ocular surface. Ocular surface.
There's no.
It's for ocular surface, I guess. That's all.
Both will be having side effects on endothelium. So I think if there is an endothelial problem, both are contraindicated.
नहीं, but वो last resort की बात कर रहे हैं, before surgery.
The last.
चौथे 5 मिनट line पे.
No, if the endothelium is decompensating, then it is.
Yeah, the message is don't use it. It's better to refer to the glaucoma department for surgery. ललित वर्मा सर देख लीजिए कितने टिप्स मिल रहे हैं glaucoma में.
हाँ, भेज देना.
असली टिप्स देने वाले अब ऊपर जा रहे हैं. असली वो आपकी तो डबल असली थी.
I don't think Tanuj needs any introduction, but I fondly remember him for teaching meditation. Because no, yoga se bhi zyada meditation, which has really helped so many of my patients.
No, I think I just want to say that Dr. Lalit Verma and Dr. Harsh are still missed in RP Center, because the amount of clinical acumen we have learned from them as residents, we will never forget, and that has been the key for our success in life. Dr. Dalit Sharma and Dr. Harsh, thank you very much. And once again, thank you for the invitation. So today's topic is a slightly difficult one, how to work up and to treat a glaucoma suspect. And these are guidelines published by the All India Ophthalmic Society, freely available, which you must download, and you will get a lot of information from these. And just before you start, keep an overview of a glaucoma patient, that it is not the eye you are dealing with, you are dealing with a human being. And you have to check not only the ocular history, you have to see for all the diseases from head to toe that the patient is having, the family history, what type of profession is he in, is he doing any yoga postures which can elevate the IOP, and then you come to the clinical examination. So before you start workup of a patient, examine him from head to toe for any other disease, and what is his profession, and what is his socio-economic status, and the family history. As far as important clinical examination, most important things which are often missed include the RAPD, which tells you that it may be a neuro-ophthalmic disorder. Of course, intraocular pressure taken 2 to 3 times, different times of the day, is very important. Central corneal thickness for ocular hypertension. And routine examination, the most critical elements include the fundus examination and the gonioscopy. So first we start with the ocular surface. It is important to highlight if there are any prominent vessels or dry eye which has already been covered, but you must rule out the telangiectatic vessels and ocular melanosis, because that has a huge impact on follow-up and treatment. And a very simple test is to run the conjunctiva over the So you just run the upper lid over the conjunctiva and see if it is mobile. So that will give you a risk factor whether this patient is suitable for trabeculectomy or not. And then of course this has been very well covered. You must see the meibomian glands, because these are the risk factors for post-operative endophthalmitis after trabeculectomy. You must rule out blepharitis and meibomitis in all patients who you are working up for glaucoma. Slit-lamp microscopy is very important because it gives you a hint whether patient has an angle closure. So the basic torchlight test, you have a shallow anterior chamber and a large iris shadow, makes you look that patient must have a mandatory gonioscopy. In addition, you must rule out pseudoexfoliation, the white deposits around the pupil. These patients progress very fast. Uveitis and any prominent shawl-based line which is visible, that tells you that the patient has got a developmental anomaly in the anterior chamber angle. Any sphincter tears pointing towards trauma, and of course patients of CRVO diabetes, before you dilate, please check for the new vessels in the iris and the angle. Coming to the basic examination, the gold standard is of course Goldman applanation tonometry, and this must be done before you do gonioscopy, and ask the patient to put the medicines and come for examination. Many patients, they report for evaluation and that day they don't take the medicine, so that is something you must warn the patients. Of course, you must rule out concomitant cataract because that will decide what type of modality you want to use, especially with coming in of MIGS. And in addition to the routine measurement of IOP, in patients who are progressing despite office IOP is showing control, then you need to check the IOP throughout the day. And in addition, you also need to check the blood pressure. Many patients develop nocturnal hypotension. So in the OPD, pressure is normal, but patient is progressing. So the reason is that they are having nighttime fall in the blood pressure. So that must be evaluated in patients who progress despite normal IOP. Now, when do you suspect? You suspect basis of three things. One is either the IOP is high, ocular hypertension or angle closure. Second is there is optic nerve or RNFL damage. And the third is visual field defects. So the first two are most robust elements that you suspect a patient of having glaucoma, high IOP or structural damage to the optic nerve head. Now, any patient who walks into the OPD, you have to answer three critical questions. Is glaucoma present? Yes or no? Is it open angle or angle closure? And if the patient has glaucoma, is it stable or is this progressing? So these are three questions you have to answer in any glaucoma patients. Can you start the video, please? So the most critical element in any patient with glaucoma is to have a stereoscopic evaluation of the optic nerve head. And you can see all three discs. There is a notching of the neonatal rim. There is a retinal nerve fiber layer defect. And again, inferior notching of the neonatal rim. So whatever may be the advances in ophthalmology, the basic stereoscopic evaluation of the optic nerve head to detect notching of the NRR to see for any RNFL defect is the primary thing you must master. Without that, all examination is a failure. So this is the critical examination. And the gold standard investigation for any glaucoma patient is to take a disc photograph and read like a MRI is read by the radiologist. So take a disc photograph when any patient, suspected glaucoma patient comes, and it will give you the maximum information. Like in this patient, you can clearly see there is a retinal nerve fiber layer defect visible and a disc hemorrhage. So any patient with increased cup-disc ratio and disc hemorrhage, flag this patient either has glaucoma or is going to develop glaucoma. So no patient you can leave in the OPD without taking a disc photograph, whatever may be the advanced testing you may have in the OPD. And this is very important because the first time patient comes, you have to document that whether it's an optic neuropathy, what is the damage. So normally in our teaching we are taught increased cup-disc ratio, but what is most important is to look for these retinal nerve fiber layer defects. These are the earlier sign of glaucoma and they are best picked up on the fundus photograph. Once you have documented structural change in the optic nerve head, then you can correlate that with the functional changes. So you have an inferior RNFL defect and a superior visual field defect. So that gives you a corroborative diagnosis, and that is the best objective way to diagnose glaucoma when your fundus and the OCT corroborates with the visual field. So if a patient has a high intraocular pressure and an open angle, very important, always check for steroid. This patient recently came to the clinic and in his pocket was this betamethasone for you are using for pimples on the face. So this is something we often forget. So any form of steroid you must check. And one more thing, increased stress raises the endogenous steroid, that you must check in any patient who is coming with glaucoma. Any recent stressful event or chronic stress can elevate the intraocular pressure. Any patient who has IOP more than 30, immediately you can start treatment. If the IOP is more than 25, if patient has following risk factors, pseudoexfoliation, pigment dispersion, cardiovascular disease, disc hemorrhages, one-eyed patients, family history, or on steroid, you start treatment. And below 21, then you need to see for any RNFL damage, and patients who have got a type A personality, you must discuss, and if they're very anxious, you may start treatment, because these are the patients who land up in medico-legal cases. So any patient who presents with glaucoma, the gold standard investigation is to put in a gonioscope and see whether the scleral spur is visible or no. So if the scleral spur is visible, it's an open angle. If the scleral spur is not visible, then it's an angle closure. So this is the basic investigation that you must master. The evaluation whether ciliary body scleral spur is visible or whether the iris is occluding the angle. So this above patient will go into medical therapy, below patient you must do a YAG laser iridotomy, and that is very important because blindness is 3 times higher in angle closure as compared to patients of open angle glaucoma. So this is the key investigation to identify that the iris occludes the trabecular meshwork, and these patients should immediately be subject to a YAG laser iridotomy. So you can see the iris blocking the trabecular meshwork, not opening on manipulation. So if you have this picture where the iris is getting touched with the TM, immediately YAG iridotomy has to be done. If there is a delay, start patient on pilocarpine. And finally, it's very important to take a medical history. Many of the patients are taking drugs for psychiatry or prostrate. They all can precipitate angle closure. So that is a very key element in your history taking and evaluation. And even after you have done a laser iridotomy, 1/3 of or more patients may progress. So you need a lifetime follow-up even after a laser iridotomy is done. And finally, just to show you how we work up glaucoma patient, this is a patient who was ruled out glaucoma. The disc cup disc ratio looks 0.5 and NRR is quite healthy. So this patient looks like doesn't have glaucoma. But when you look at this test, this is very important. This is the OCT pseudo color image on the spectalis OCT. Now you can see very carefully there is a RNFL defect visible here which you could not pick up on clinical examination. And then in this patient, when you do the OCT, you can see there is a RNFL defect clearly visible, which was not so visible on the disc photograph, and it is visible on this multicolor image on the OCT. This is an additional feature which you can use in the OCT, the multicolor imaging, to tell you about the RNFL defects. So that is why how you diagnose glaucoma. Another patient, this was referred to me, 35-year-old using Traverton because huge cup disc ratio. So that is not at all important. Large disc have large cup disc ratio. What is important is the RNFL on the OCT is completely normal. So this is a physiological cupping, and you can stop the treatment and just call the patient on follow-up. This is recently an ophthalmologist referred, and he looks like there is absolutely normal. But when we did the disc evaluation of OCT, there is an inferior RNFL defect which was missed on clinical examination. So when you see the OCT, there is a red area. You must go back and see the fundus image. This is what we missed. So that is how you can see that there is a structural damage occurring. Again, this was a recent IAS officer ruled out there's no glaucoma, came for second opinion. This photograph is showing RNFL defect, and this was missed because fields are nearly normal. But when we did the OCT, we saw there's a RNFL defect, and then we went back and we could catch that this is what we have missed on clinical examination. And finally, you have patients who present with normal pressure glaucoma and pallor. Now this is very, very important. You can save the life of the patient. Any glaucoma patient presenting normal IOP and pallor and open angles, you must do the visual fields. Even if vision is less, you must rule out RAPD, and such patients may end up having pituitary tumors which are masquerading with acquired cupping and pallor. So here is where a glaucoma specialist can save the life of the patient. So thank you very much for your kind attention.
Beautiful cases. Unfortunately, there was no politician in that. He is not politician.
No, but they're all high risk cases. I mean, you can't get flawed if you diagnose them or don't diagnose, you're in for trouble.
Sir, if from your presentation is ugly में case, politician का भी रखा.
Which party you have to tell?
Sir, anterior segment OCT and gonioscopy. Which one is more informative and what?
इसका सवाल एक ही है सर, इसलिए इसका जवाब एक ही.
नहीं, let me hear from the.
No, sir. Currently, still gonioscopy is gold standard because you can manipulate and see the appositional versus synucleal closure. So OCT is developing, but it is still not reached with AI. It is still not reached the stage where you can detect angle closure versus PAC versus PAC. So gonioscopy is gold standard. ASOCT is very useful if you have other pathologies like plateau iris or you have post-operative problem where you can't touch. But gonioscopy is still the gold standard for diagnosing angle closure.
Anterion? Yes, sir. Even anterion is not that good.
No, sir, none of the OCTs still, they are add-on to gonioscopy.
But what I have felt ki if you do an anterior segment OCT, the conversion rate to PI is higher.
No, that is if you
Yeah,
want
for
to
patient education it is very good.
Yes,
You can,
yes.
yeah.
नहीं उसके लिए तो फोटो भी खींच लो. अगर you are convinced by gonioscopy, then you just take a photo and tell कि
Yeah.
उसको
Otherwise,
कौन सा दिखना है
you will be doing lot more PIs if you just do AS OCT. False positive very high.
Thank you, sir, for a very informative talk. I had a question. The role of a disc photograph in an ACG patient, when you want to differentiate between the spectrum between PAC versus PACG, do you actually do disc photographs for those two? And do you do red-free or do you prefer colored disc photographs for your OAG patients?
See, any patient you're diagnosed glaucoma, the basic thing is you have to document optic neuropathy. To document optic neuropathy, the standard test is to take a fundus photograph. So any glaucoma patient, only thing is angle closure, you have to do PI and then dilate and take the photograph because you can precipitate acute attack. So irrespective of whatever the etiology, this photograph is mandatory. If you have the facility, take both red free as well as color. And nowadays you have these small pupil fundus photographs of the retina people. So both are, they are very good because you don't dilate and you get a good photograph. So that is, I think, ideal test, and every year you do that same, you can see on follow-up. You don't require any advanced investigations.
Sir, there are various software available where you can convert colored photograph to red-free photograph without taking any extra photograph.
Yeah. So actually we are only taking the color photograph currently, but I think your retina, with your retina advancement, those are very good. I have seen those cameras we don't have currently, but retina people are using. They are also very good. I think with both you can use retina as well as glaucoma.
Thank you so much, sir.
Thank you. Thank you. Thank you.
Dr. Devang, she will be talking about two different topics.
OAG with moderate damage and mild field loss on 2 medications. What next? Mix, stent, bang or KDB? Dr. Deva.
तनुज कहाँ जा रहा है भाई? इसमें तेरा फाइनल ओपिनियन चाहिए हमें.
At the outset, I would like to thank thank Sao and Dr. Harsh for giving me this opportunity. And this is the case that sir has given me, an open angle glaucoma with moderate damage and mild field loss, and what to do next. So we all know that glaucoma therapy has undergone a revolution over the past decade, more than a decade, in fact, over couple of years. That initially we started with medications, then laser therapy. The problem with medication being that 53% adherence side effects with medical therapy is there, and then if you know none of these are helpful, glaucoma surgeries like filtering or implants. There was no bridge between the two. So now with the newer surgeries that are coming in, which is the minimally invasive glaucoma surgery, MIGS, which can be combined with cataract surgery, can be done standalone. And as we all know that medications, they have a lot of side effects. Also, it adds to the cost, and more importantly, compliance is an issue with all these. And the traditional filtering surgeries like trab and tubes have their own set of complications which are sight threatening, and being mostly conjunctival sparing, these MIGS, they have offer a very reasonable and a high safety profile. So the new therapeutic option is MIGS, which is bridging the medical therapy with the surgical therapy. And what is MIGS? MIGS is it's minimally invasive glaucoma surgery or micro-invasive glaucoma surgery. It is an ab interno approach, minimally traumatic, proven efficacy, and it has a high safety profile. And the patients, more importantly, there's a very rapid recovery of patients. Most of the indication is in mild to moderate open angle glaucomas, and usually they are combined with cataract surgery. Advantage being that they are less invasive, conjunctival sparing with modest efficacy, early visual recovery, and lesser post-op shallow AC, and all sorts of complications that are seen with trabeculectomy is not there. So if you look at the classification of MIGS, so MIGS, it can be classified depending on the overcoming the resistance at the juxtacanaliculaar pathway, which is basically overcoming the traditional outflow. We have the trabecular bypass, we have eye stent, which is there, then we have KDB, then we have BANG, GAT, then the second is increasing the uvoscleral outflow via the suprachoroidal space like CYPAS, then subconjunctival space, and also the ciliary body. So the trabecular meshwork and inner wall of Schen's canal are the site of maximum resistance. That is why the MIGS like KDB, BANG and eye stent have come into vogue. And the most important thing for doing a MIGS surgery is the setup. The prerequisite is the positioning and setup. So you have to tilt the microscope towards the surgeon and the patient's eye away from the surgeon. The best view of the trabecular meshwork is achieved when the angle of microscope and the patient eye equals 70 degrees. So we tilt the microscope towards the surgeon nearly 30-35 degrees and rotate the head away from the surgeon nearly 30-35 degrees and use a direct gonioscope like Swan-Jacob or any of those disposable ones that are available. We also should know that all these surgeries have post-operative complications. They have they can lead to elevated IO because of retained viscoelastic steroid response. Hyphema is one of the most common complications that is seen, and prolonged inflammation leading to a formation of pus and closure of these clefts are also coming up. And more importantly, gonioscopy should be performed at each follow-up to check for the patency of the pus. So our case, what should we do if there is an open angle glaucoma with moderate damage, mild field loss on 2 medications? So I'll just tell you what BANG is. So BANG is bent ab interno needle goniectomy, wherein we are using a 26 gauge needle and bending it. And here, and we just incise nearly 3 clock hours, nearly 90 degrees of the angle under direct visualization. And since we know, all of us know that because it's a 26 gauge needle, it's usually free of cost, very cheap, and it can be, usually we combine it with a cataract surgery. The second option is KDB. So KDB is the Kahook dual blade. So we can see the magnified view of the blade. So it is basically a double-edged blade, and through the temporal phaco incision, we insert the KDB blade first. We mark the amount of incision that we want to do, nearly 3 clock hours. So first we mark, and after marking, like BANG, we just start incising the trabecular meshwork, stripping off the trabecular meshwork. And this also we combine it with cataract surgery. This is how the KDB glide looks like, and it has a ramp, and it has the added advantage is that both the ends of the blade are cutting, so there's a very smooth cut while moving the blade. The tapered sides and rounded heel are atraumatic, as they say. And then we have the last option we have is the eye stent. So this is the eye stent inject, video courtesy Professor Tanuj Dada, and in this already one stent is injected. So what is important is that in all these angle surgeries, we need to have a very good en face view, wherein we are directly seeing the trabecular meshwork where we are injecting. So that is the first thing. And once we can clearly see the trabecular meshwork, only then go and inject the stent. There is no urgency because injecting is just a microsecond. It's like a nanosecond. And once you're confident that you are at that level, only then inject. So eye stent is basically heparin coated titanium alloy. So we have the first generation eye stent, then we had eye stent inject, now we have eye stent infinite, which has from starting from 1 stent to 2 stent to now 3 stents, and we don't know how many may come. So this is a case, This is a 68-year-old female, known case of glaucoma care since 2012. She was a known case of pseudoexfoliative glaucoma. There was a family history of glaucoma in her father. There's no systemic illness, and she had undergone right eye phacotrap with IOL surgery in 2025. So this is the left eye that I'm showing. So left eye, the pressures were 24 millimeters of mercury on 2 AGMs, which were not controlled, borderline, and she has pseudoexfoliation, and the cataract is significant, and the cup disc ratio is 0.6. These are the clinical pictures. And so in this, KDB was done for the patient, and the baseline IOP is 24 at day 1 until 6 months. It is maintained without medication. This case courtesy is to Dr. Sunita Dubey ma'am. So to summarize, MIGs are not so potent, but they provide a non-bleb and safe option for certain patients, eliminating the need for resorting to invasive glaucoma surgeries. Combined cataract and MIGs, they have a good efficacy and safety. There is no impact on the success of future filtering surgery. With judicious case selection and selection of the MIGs, glaucoma surgery can be individualized according to patient's affordability, the stage of disease, and the nature of the glaucoma. The greatest advantage of MIGs is that it preserves the conjunctiva for a more invasive glaucoma surgery. As we all know that glaucoma is a chronic progressive disease, so eventually patient may require another surgery. And regarding MIGs, there is a long way to go. We need more long-term evidence for the long-term outcomes of this MIGs. Thank you for your patient listening. I would like to acknowledge Professor Dada and Dr. Sunita Dubey ma'am. Thank you.
So Tanuj, we have stopped you only for this. Please tell us clearly that if I have a patient like this, what would I do? Do you think Bang is good enough? Because a lot of people are coming back and telling me that it lasts only for 6 months. And should I choose KDB because patient may not be able to afford the stent, and how much actual lowering is there?
So sir, I think we have to be very clear that all these MIGS, trabecular MIGS, the IP lowering is quite minimal. And recently there was an American Academy report published, outcome of trabecular MIGS, eye stent, KDB, Hydrus. So at 2 years, the IP lowering attributed to these devices is between 4 to 8% maximum. IP lowering.
Oh my God.
IP lowering and
percent. 8 millimeter to बहुत होता है भाई.
And the drug lowering, amount of reduction in drug is 0.4 at 2 years.
Where is this published?
American Academy of Ophthalmology Journal.
Abhi.
Yeah, a report on trabecular MIGS procedures. Yeah. But the issue is how they are getting successful, because the effect of cataract surgery is 20 to 25%.
Exactly.
So all of these we are picking back on the cataract surgery. So the expectation is that maximum you can lower the IOP by 5 to 10%, and maybe one medication you can take off the patient after 2 years, because the effect of cataract surgery may last 1 to 2 years. The second issue is, sir, like what we have seen, we have done Bang or KDB, very good. So after the patient comes back, after 2 years they will start failing, because the iris creeps up and there is you are cutting the TM, there is fibrosis of the outflow channels. So after 2 years we did a study on aqueous angiography, so entire thing is blocked then. So there is rebound increase in IOP after 2 years or more. So because like we are doing TRAV, we are using mitomycin C. Here we are cutting, there is so much of bleeding, so it will fibrose. We don't have any antifibrotic. So the wound healing will definitely cause failure. So I think you have to be clear that what you are expecting. So minimal IOP reduction over short time, definitely you can use, but long time for our scenario it is not helpful. And for Bang, actually we modified what we do, because the dimension of the TM are much smaller than the 26, much larger than this mismatch.
Yeah.
So we use a 30 gauge needle. So what we do is, first we go and we inject viscoelastic to balloon the canal, and then we incise. So advantage is that you are not damaging the outer wall. Both the KDB and the needles, we are ripping the TM, but the outer wall is also getting damaged because it is collapsed. So if you put viscoelastic, then at least you tamponade, and secondly, the bleeding also gets rest. The moment you get bleeding, there is going to be fibrosis and failure. And regarding last point, eye stent, you saw me doing eye stent because we did, this was for a study they provided us. So after putting eye stent, you have done the eye stent, it is in the TM. So when we injected the indocyanin dye to see, it is not going through and through because you are only seeing the outer portion. Where inside it is going and whether it is going in the Schlemm's canal, you are not sure because it is already viscoelastic you have injected. The Schlemm's canal is collapsed. So outer view is okay, you are seeing the device, but where it is going inside, you are not sure. So we found even though anatomically it's very good, but when you inject the dye, it is not going through and through. So all these technologies are still far from perfect. So they are not really, they are not going to cure glaucoma, but transiently, definitely they will lower pressure. But you have to prepare the patient that it is going to fail and may require second surgery. So that is why mostly cataract surgeons are doing this, because they refer for glaucoma to the next person.
Thank you so much. That was so beautifully explained. I think that was wonderful.
So the money involved, the hype created, and the percentage of lowering IOP.
Yeah, and sir, the American Academy also said that the IOP lowering is 5 to 8%.
Yeah.
And this is also spurious because
Cataract.
most of our trials have got, the authors are from the company. So there is a bias in publication.
So I think we have understood what you said.
Yes. So in RP center, that is the advantage. See, if I am private practice, then I have to survive also.
Yes.
So that is different story. And femtocataract also same thing, no? So we have femtocataract with eye stent now coming in.
We understood what Tanuj said, but I am telling you by vast experience, I think you conveyed it like Harsh said very, very nicely.
I think Kirti is also there. Kirti was doing something and she was also quite...
No, we are the poorer center, so we don't have all these angiographies and everything or femto. But we have done bang, and we in fact have done better results in ACG with bang. But as agreed, we only have a 1 year follow-up till now. And in the 1 year follow-up, the percentage of clefts. Now the problem with our follow-ups in our hospital is all the patients don't come back to us. So our follow-up dropout rate is at least 30%, but the people who've come back to us, the clefts are maintained for at least 6 months. And we don't have angiography, aqueous angiography, any facility, but they are mostly off drugs. And we only do the case selection for mild to moderate with 2 drugs. We don't do for advanced glaucomas naturally.
With cataract.
With cataract, with significant cataract, not clear lens. No, we have done 2. We have done in both the way. We have done clear cataract surgery. Absolutely, agreed. We can't say kaun se wala kiska effect zyada hai, but we have done now, right now 2 theses are going on. One in bang with cataract surgery in significant cataract patients for open angle, and the similar one for ACG. So what I'm saying is, comparing the 2, for the OAG we had 1 year follow up, for the ACG we have now more than 6 months follow up. 1 साल तक सर ठीक है, जितने भी follow up सारे आए हैं सब ठीक है. They are off medications, at least minimum 2 का drop आया है medications का, not 0.4. But the IOP reduction कितना लेंस के कारण है और कितना उसके साथ है, we are doing a case control study of clear, just the clear phaco alone, not clear lens phaco, but plain phaco alone vis-a-vis phaco with bang, and we'll come back to you in a year's time.
कुछ बोलना है?
No, actually in IGO we just published bang results. So 1 year outcomes very good. There is no
But
doubt
for
about that.
long-term
And advantage is free for the patient, 26 gauge needle.
Right.
So
Bleb नहीं है.
definitely, but what I'm saying is you have to see what is happening inside. Even though cleft is there, but the outer wall is getting fibrosed, which you don't see.
Right. So that is very clear. Angmo, you want to differ with any one of them? Or you agree?
She wants to go to her next presentation. Please do.
Please do.
Can I ask one question, sir?
Tanuj, you can move now.
That is the problem, sir. Active follow-up, if you see long-term follow-up, then they all start failing. And
नहीं, वो सर्जन पे भी डिपेंड करता है. सर्जन अच्छा हो तो वो ठीक हो जाता है.
No,
no,
not
no,
really.
please,
Ma'am, wait for my presentation. Wait for the next presentation. Okay.
So I think the summary what they've said is the makes minimally invasive glaucoma surgery is equivalent to minimally effective glaucoma surgery. Makes is MEGS.
So the next case that I got is open angle glaucoma with advanced damage with cataract controlled on anti-glaucoma medications. What to do next? So now is the time to decide what surgery to do. So this is the case wherein a 64-year-old female who was diagnosed glaucoma since 5 years. There was a family history of glaucoma in brother. She had history of diabetes and hypertension since the past 3-4 years on systemic beta blockers. Her baseline IOP were 34 and 28. And if you look at the corneal thickness, slightly on the thinner side, and she is using 3 medications. So when she presented to the OPD, the IOP was 18 and 20, and she presented with a gradual diminution of vision, and we can clearly see that in the right eye the cataract was more significant as compared to the left eye. The disc was hazily seen in the right eye. Nearly, if we can see, there's only a superior rim which is there, inferior thinning is there. In the left eye, it is slightly more advanced as compared to the right eye. It was open angle, and on the fields, there was an advanced visual field defect. So this was a case of POAG with advanced con. So now what is the next? What is the management? The first thing that occurs to us is target IOP, whether it has been achieved or not. So the patient has an IOP of 18 to 20 on 3 topical medications, and in advanced cases, the target IOP that we want is between 10 to 12. So definitely she is out of target. And what next would want to do? Would one jump to do a cataract surgery, or would one want to do a combined surgery, or do a sequential surgery? So in this case, after admitting the patient, we recheck the IOP, because we all know that POAGs, they have a diurnal variation. So on diurnal variation, we came to know that there was a peak, especially early in the morning, which was there, and we definitely had to operate. Now what to do? So the management decision in these cases is it's kind of difficult. It is multifactorial. It depends on many things. Depends on the patient profile, wherein we have to look at the risk factors, whether the patient has a high risk or a low risk for progression of glaucoma, whether the patient has a family history of glaucoma, what is the corneal thickness of the patient, whether the patient has associated ocular problems, whether she had PEX or subluxation, the age of the patient, whether the patient is fast progressor, and various systemic illnesses that the patient has, and more importantly, whether the pupils are dilating or not. That is also one important thing that we should see. The patient compliance is also important, whether if we are planning just to do a cataract surgery, whether this glaucoma patient will follow up and put medications is another question. The affordability of the patient, whether the patient can afford for 2 surgeries or the patient can only afford for 1 surgery, the stage of the disease, advanced or end stage, what would be your preference, and also surgeon preference also comes into play, because some surgeons, they prefer sequential single surgery and some would do a combined surgery. So in this case, for this particular case, because she had multiple risk factors and the target IOP was also not achieved, I went ahead and did a combined surgery. So combined surgery, I prefer to do a 2-site combined surgery, doing a temporal phaco first and then doing a superior trabeculectomy. So in this case, you can clearly see that the patient was dilating well, so I went ahead and did the combined surgery. So after doing a routine phacoemulsification, we come superiorly and do the rest of the surgery. And then we close the wound. So more important thing is that whenever we are doing combined surgery, I prefer and make it a watertight closure, prefer even by micro incision phaco surgery, I prefer to close the wound for a good watertight closure, for a good chamber formation post-op. So this is the follow-up of patient that I had. She had a pre-op IOP of 24 on 3 medications, and she's nearly now 2 years follow-up. IOP is 12 on no medications at all. Patient has no other complaints. She is regularly coming. Thank you for your patient listening.
If the IOP is controlled on 2 medications, because we have been doing it now that even with advanced damage, well controlled IOP, maybe we just go ahead with the cataract.
So that is
Balaji, what is your thought?
IOP is controlled on
2 medications.
But with advanced glaucoma.
With advanced glaucoma. Maybe 2, even 3, let us say.
So
because so many patients, I'll tell you in practice because your place is different, and they'll say, sir, cataract hi kar do bas. हमें नहीं ये complicated चीज़ करानी ज़्यादा. And I am quite shocked that even very advanced damage, sometimes we are doing only cataract, telling them that if there is a problem, we may add up a trab later.
So that is what I asked, sequential.
Right.
If you are not doing a combined, then do a sequential. But only doing a cataract surgery will not serve the purpose. You have to prepare the patient for a sequential surgery.
Yes, you have to, but many a times if the, yes, rightly like you said, that if the pressures are not controlled, even then, or they are in the higher ranges and not meeting target, then you have to go for combined.
Which role of the SLT in these cases? Suppose if you want to reduce one drug.
So there is basically, as we all know, that SLT has a very temporary effect. So our part of the patients at 64-year-old don't want to regularly follow up. They want that I want to come at 6 months. Now she comes annual follow up. So for that also you have to
I mean, somebody can come for the follow-up.
Yes. For younger patients, we are giving first SLT, but SLT has a very short-term effect. So over the time it wears off. So you have to add medications later on.
If the patients don't agree for a trab, would these be the patients, if you're doing a cataract surgery, that you would want to combine with the mixed procedure? Because you don't really have.
I did not get your question.
Would you like to do a cataract surgery with a mix, for example, a band for such a patient, if it's not agreeable to undergo a trab?
That's what I'm telling you. So if when we are preparing the patient for sequential surgery, then you can always do a combined mix with that.
I think with that we come to the end of this very nice glaucoma session. I'll request all the speakers and Dr. Lalit sir and the people on the dais to come for group photo.
Thank you, Dr. Harsh and Vishnu and everybody. We'll break for lunch and we'll be back right at 2:30 to start anti-VEGF session. Thank you so much.
इसमें भी नहीं हो रहा, खुला हुआ है कहीं पे, ये कह रहा है यहाँ ये खुला हुआ है इसलिए ये बंद कर दो ना, खुला हुआ है प्रेजेंटेशन।
should be heating debates and discussions in this. My purpose of having all these sessions under one roof and one conference was so that we discuss, deliberate and learn from each other which to use when. Believe me, all of them have indications and all of them do work, some better than the other, or some more duration or drying effect. There may be difference. A lot of newer anti-VEGFs have entered, a lot of biosimilars have come in. And believe me, there is a storm of anti-VEGFs in this country. And India is proud to have the first biosimilar. Now US has adopted biosimilars. So Japan, Korea, everywhere there are biosimilars. Biosimilars came with a very big bang just to reduce the cost to the patient. But whether they have actually served the purpose of helping the patient, I am not very sure. But they do offer good value reduction. So in the first session, we will have the conventional anti-VEGF agents, meaning thereby we will talk about eccentrics or ranibizumab and biosimilars, and then we will have sessions on longer duration biosimilars in the subsequent. So without wasting much time, I will request Dr. Rajpal to please join as a chairperson. Dr. Rajpal, we all know, is now leading the retina department at the Apex Institute RP Center. Welcome, Rajpal. Then we will have Dr. Shashank Gupta. Shashank, I just saw him, Shashank. Arun, can you call Shashank? Arun, Shashank ko bula. Then Rajiv Jain also will be joining. Meanwhile, I will ask Dr. Avneet Gupta to please help in moderation of this very important session. So we will have 9 talks. My only request, Shashank, my only request to chairpersons will be to moderate in such a way that some tips go for the audience rather than having endless discussions, because discussions, believe me, are endless and you can keep debating at one talk for days and days. So, and speakers should stick to the time so that we can have more questions from the audience, because this session we have titled as tips in practice, how, when and what to give. So with these few words, I'll ask Rajpal and Dr. Avneet Gupta and Shashank to take over from here.
Thank you, Dr. Lalit, for inviting us in this conference. I would like to call first speaker, Dr. Upadhyay is there? Yes. Dr. Amnish Upadhyay will be talking on DMV, the planned cataract surgery, time to see the difference.
Good afternoon all, and thank you Lalit sir for having me here. So my topic for discussion today is DME with planned cataract surgery, time to see the difference. The topics which we will be covering is whether we have incidence and prevalence of macular edema post cataract surgery, whether to treat pre-operative DMEs in these sort of patients, and if there is not significant DME, how to go about. And we'll talk about cytokines, about how do they actually influence DMEs, and some studies related and some treatments with respect to DEX implants. So this is my financial disclosure. So coming to the risk factors and incidence of macular edema after cataract surgery. This was a very nice surgery which was published way back in 2016, and it had a database of close to 82,000 patients. So in this study, they could actually analyze the cause for or the risk factors for patients having DME, post-operative macular edema, and the causes were capsular rupture, intraoperative complications, and secondary comorbid conditions such as previously diagnosed ERMs, vein occlusions. Along with that, we had diabetic retinopathy, also another cause for macular edema. And two things which came out from this study was, if you have diabetic retinopathy, the chances of incidence of post-operative ME is definitely there, and with the severity of diabetic retinopathy, the chances is more. Second thing which we want to discuss is about the prevalence of diabetes and diabetic macular edema. So if you have a patient who's coming for cataract surgery, what could be the prevalence of diabetes and related diabetic macular edema in these patients? So in this study, they had close to 3,400 patients, and of which close to 745 patients were diabetic. And in these sort of patients, they had non-clinically significant macular edema, which was roughly around 20%, and the remaining were having, close to 5% were having significant macular edema. So this study actually highlighted that if you have a patient of the relative number, so 1/4 would possibly have DME and diabetic retinopathy, and of that 1/4 of diabetic retinopathy, one quarter would definitely have some sort of DME. So if you have a patient who is coming for cataract surgery, please do your OCTs and just see whether the patient is having any sort of macular edema or not. And if the patient is having diabetes, it is likely that the patient may show some sort of non-clinically significant macular edema. So the next point is whether if you have a patient who's coming for surgery for cataract and you do an OCT and it comes out to have a macular edema as well, does that actually help in influencing the visual outcomes and the product of the patients? So this was a study by the Italian group, and they had some consensus with respect to patients who had macular edema with respect to diabetes and were going cataract surgery. So these were some of the consensus. So one of the consensus was edema in patients who had diabetes with pre-existing macular edema. There was a definite risk of macular edema worsening, and mainly after 2 months. And second was diabetes with higher risk of developing macular edema. And so OCT does play a crucial role, and these sort of patients, when they were injected with dexamethasone implants, they had better visual outcomes, as well as the subfoveal thickness was comparatively better as compared to patients who were not treated. So the fourth point is patients which actually have early DMO or the diabetic macular edema, where they don't have much of an edema and they would show some subtle cystic changes. So in these sort of patients also, if you tend to see post-operatively by 1 month, they do tend to have some sort of macular edema which is worsening. So the study actually showed around about 80% of the patient had some sort of worsening of subfoveal thickness. So by 4 months, they said that the CME deteriorated to almost 65%, and there was a visual drop of 8 to 6 letters with respect to best corrected visual acuity and subfoveal thickness. So what we can say is that if you have a patient who has cataract and who has relative diabetic diabetes, please do your OCTs. If the patient has some sort of macular edema or maybe very subtle changes, that will progress into full-blown clinically significant macular edema. And plus treating these patients with if the patient has pre-existing DMEs, so you have to treat these patients first rather than going for cataract surgery individually. So I would skip to this part. It is well known that cytokines are the predictors or the markers of macular edema in patients with diabetes, and there was a study by the Indian group where they have used dexamethasone implants to check on the intraocular cytokines, and they have actually said that these patients were subjected to 2 groups, where one group was given injections within 3 months of surgery, and the other one was given after 3 months. After 3 months, the patients were again re-evaluated. You can see the cytokine levels were where the injection was given, it was fairly decreased. And secondly, when after 3 months, there was a rebound in CME, which was actually seen in these patients. So when to actually give these sort of injections, one is whether to go simultaneously with the surgery or whether to go pre. So this was one study where they showed that if you can give 1 month before, the amount of subfoveal thickness will definitely will decrease, but 1 month as compared to the patients which were given simultaneous injections, they would possibly have some sort of foveal thickness would be more. Just 1 minute, sir. So one thing which they could say was, if you are giving the injection simultaneously, the chances of anatomical correction would be better as compared to patients which are given 1 month prior. So with this, I would just want to conclude. So if you have a patient who has diabetic macular edema with planned cataract surgery, you need to be extra careful with the possibility of worsening of pre-existing DME. Secondly, if you have these sort of patients, you should tell them that this problem is going to increase, and you may have decrease in visions, where using DEX implants as a treatment. Okay, sir. Hello. So DEX would definitely decrease these inflammatory cytokines and thus reduce worsening of these sort of patients. Thank you.
in your practice, what do you practice giving at the same time or pre-operatively?
So I possibly
how many days pre-operative?
Usually a week before I do tend to do. We don't give simultaneously per se. So 1 week before we tend to do.
What is the reason why you don't give simultaneously?
So it's I don't say that there is a risk, but I do practice in that way. So I have not actually done a study where, but I do tend to give a week before. So it becomes more easier for me when sometimes the anterior segment surgeons are the ones, they say that we don't tend to give, maybe I am not available to give it. So that is one thing. So I plan it a week before, and then possibly the anterior segment surgeon would do the surgery.
I think steroid definitely have a role in after cataract surgery, because we know after cataract surgery there is a lot of inflammatory mediators, and steroid is preferred as compared to anti-VEGF, because this anti-cytokine activity, what Ashwini has told us, decreases after you give Ozurdex. If you have to treat, like many patients, what we have diabetic macular edema, and we are treating this patient on anti-VEGF. Now, will you like to shift this patient to Dex implant, or you will continue with the anti-VEGF in these kind of patients? So how do you decide patients whether
we should
switch?
So first thing, I think OCT biomarkers are the ones which would actually pick us whether to go for DEX or maybe anti-VEGF implants as the first go. So if the patient is having subfoveal detachment, large cystic spaces, hyperreflective dots, those are the indicators where we would want to treat those patients earlier with DEX implants rather than anti-VEGFs. Second thing, I would want to titrate whether the amount of vision drop is more significant with respect to cataract or whether it is more respect to the macular edema which is persisting. So if it is not so much, the cataract is the main cause, because what actually happens with anti-VEGFs is we do tend to give anti-VEGFs at the same go. But when the patient comes after a month where the amount of cataract was not that significant, the patient is not very happy with your anti-VEGFs, because these sort of edemas, they start to kick in after 4 weeks, 6 weeks after the cataract surgery. So that is where steroids would have an upper hand, because where the patient will be more compliant with you, because he would actually have sustainable, like with time you can always say to tell the patient that maybe after 4 weeks you can come back and we'll see. And if you're giving anti-VEGF, so after 4 weeks there is a chance that the patient may not have, the patient may complain there is not significant improvement, and when after 4 weeks he'll come back with decreased vision, where he'll not be happy and possibly drop out. So those are the ones I would definitely want to treat with steroids as compared to anti-VEGFs.
Clinical tip: if you are giving Ozurdex in simultaneously cataract surgery, be away from the site of incision and paracentesis, because the moment you press below the paracentesis, the ACA will become shallow. And second thing what you can do is don't wash viscoelastic. First give Ozurdex and then wash the viscoelastic, so you will have a hard globe or tensions will be higher. Giving Ozurdex will be easier in these kind of cases.
You see, tip number 1 is to try to dry the macula before only. That is tip number 1 always in diabetics. Second is it makes, from the patient point of view, clinical this thing that you do it at the same time rather than before. Because before means 2 visits and other things. Ozurdex may float up near the PC also. That also may happen sometimes. And third is you yourself mentioned that the peak incidence of DME worsening is around 2 weeks. So a lot of people give later on also. But the other question which you asked was, there are reports that patients who are maintained dry on conventional anti-VEGF agents, they were divided in 2 groups. One they allowed to continue on the conventional anti-VEGF, one they shifted to steroid implant. So people, even though they may be dry on conventional anti-VEGF agent, be it ranibizumab, be it aflibercept, anything, but steroid group definitely did better, and these patients had worsening of edema. So that goes in favor of steroid implant. So this study is also available.
So I think somebody.
If cost becomes a limiting factor in giving an DEX implant, would you give IVT in these cases when you think that patient is certainly, there are high chances of developing DME post-cataract surgery?
I think IVT does work good in those sort of patients, because at the end of the day, we don't want patients coming back to us with DMEs. And the amount of DME is also a factor. So if the amount of DME is not so much, we can still wait for some more time. But if you definitely have DME, definitely treating either with sometimes combinations also help with an IVT and anti-VEGFs also. And as sir was asking whether to switch, what studies have...
Yes, sir. You can answer. Meanwhile, I'll request Dr. Prashant, Dr. Ashish Vaidya from Bombay to get his presentation ready. He will be speaking on deep diving into RVO management. You can answer meanwhile he is ready.
The thing, sir, when you are asking when to switch, the studies have shown that minimum 3 injections of anti-VEGFs, and if they are not showing at least 5-letter improvement or at least 10 to 20%, there is some studies have shown 10% or some studies have shown 20% of reduction in subfoveal thickness. So from the base, if it is not happening after 3 loading doses, that is the time to switch. And with respect to DEX implants, at least 2 injections of DEX to be tried, and then if it is not working, that is the time we can switch.
Lalit sir, if I may, if there's a significant macular edema in one eye and the other eye has a total cataract that you're planning, would you plan it with a simultaneous injection, or would you wait to see the post-op retina and then decide?
I would rather wait for those patients for the cataract surgery. Otherwise you can't see it. Yeah, so that patient definitely needs to be counseled before. That since the one eye which you are actually having macular edema, the other eye would have a possibility of macular edema as well. So those patients I would rather treat the cataract first, see the patient after 2 weeks and then decide about injections.
You can also do a cataract surgery and indirect ophthalmoscopy on the table.
Or you can do a B-scan also.
You can decide whether you want to give anti-VEGF or a DEX implant. So
retinopathy is a symmetrical disease but not necessarily equal disease. You know asymmetry also happens. One eye may have 6-9 other eyes. So it's better to wait and
do you check
because
on
peak
table?
occurs. Yeah.
Always you can
after 2 weeks there is no, we don't lose much. So unlike AIMD, you don't lose much in that retinopathy even if you delay treatment. Things will come back. Things will come back to their normal levels.
And you can also have a 20 megahertz B scan and you can make out an elevation of the macula.
Thank you.
Thank you. At the outset, I would like to thank Dr. Lalit Verma for inviting me here. My talk for today is RVO management. RVO is a common retinal disease associated with rapid visual loss. As we know, it can be divided into branch retinal vein occlusion and central retinal vein occlusion. Branch retinal vein occlusion is more often seen than central retinal vein occlusions. RVO management involves a multidisciplinary approach in which the systemic factors have to be treated along with the available ocular treatments. The systemic factors include age, smoking, diabetes. In our country, it also includes hyperhomocystinemia, because a lot of people are vegetarian and for them the homocysteine levels may be elevated. So this is something which I think we should look into. Now, what are the clinical outcomes with ranibizumab in BRVO and CRVO? The Bravo and the Cruise trials showed us that these patients who received ranibizumab did much better than patients who took the conventional therapy. And if you see over here, from 6 months, these patients got shifted to taking injections and their vision improved. So the moral of the story over here was that start early, because if you started the injections early, they would achieve a much better response. And even if you haven't started early, you can still start even at 6 months, because even at this stage, the vision still tends to go up, but doesn't come up to this level. Now the next study showed the same patients over a span of 12 months and over a span of 4 years, which also showed that the patients who received injections early and the patients who took continuous injections were much better off than patients who started the injections later on. The second question was, does combining laser with ranibizumab offer any additional benefits? So again, over here you had patients who took only ranibizumab, patients who took ranibizumab plus laser, and patients who took only laser. In patients who took laser, the vision improved, but it did not improve as much as patients who took the injections. And even over here, ranibizumab with laser did not offer any significant advantage, and the results were comparable. Again, the median time to gain 15 letters. So how fast does my vision improve? So the median time to gain 15 letters also was much lesser in patients with ranibizumab than in patients who took laser. Patients with ranibizumab took about 85 days, while with laser it took about 266 days for the vision to improve. So this is another important thing which tells us that we should be injecting these patients. Again, patients with lower baseline visual acuity achieved higher visual gains at month 24 than the patients who had a better vision. The other question was, does switching to ranibizumab after laser therapy offer any additional benefits? Your patient who has walked in, has done laser somewhere, and would you like to switch to ranibizumab? Yes. This was a patient who was switched over here, and the patients who were switched again did better than the patients with laser alone. So if a patient walks in with laser done previously and you still have edema, you can still give the patient injections and the patient will still do better. The next question is, how do treatment outcomes compare when you add ranibizumab plus a DEX implant? Now there's a little controversy over this, because whatever the studies were, they showed that the DEX implant was to be repeated after 6 months. However, we all know that DEX implant doesn't last for 6 months. It lasts for about 3 months or so. So that's the reason why these studies may not be actually holding true in our clinical practice. The next is, what are the outcomes of ranibizumab in different clinical situations with ischemia, if a patient has ischemia, and with the increased disease duration. Again, it was shown that even if the patient had ischemia on the FFA, you could still give the patient ranibizumab, and these patients again had an improvement in vision as compared to patients who were treated only with laser. Again, what does the scientific evidence from the RCTs translate into? And that shows that this was a luminous study, which was a 5-year observational study all over the world, which showed that if you are more compliant and you take more number of injections, your effective vision is much better than patients who took only 0 or 1 injection. Again, the clinical benefit is seen in the real world, in practice, in which the patients improved by about 60, a lot of patients improved from 49.2 to 61.1, and in 2 years from 53 letters to 59.3 letters. Now this is the story of 2 patients. One patient got BRVO in 2009, was lasered somewhere else. Patient consulted 2 other retinal specialists. Everybody said, well done. Patient was happy that nothing more could be done. Patient had extensive laser up over here, and patient came back in 2014 with a vitreous hemorrhage, for which the patient was treated. The vision of the patient was 636 right from 2009 till the time I saw the patient. And if you see over here in the upper part, the retina is thin and atrophic because of the laser maybe, and maybe because of edema, which has now settled down. Now this is the second patient. Patient had a CRVO, and patient's vision was 2/60. The patient kept on coming for follow-up. He kept on coming every month. In the first year, he took 6 Accentrix injections. The edema waxed and waned. In the second year, he took 4 Accentrix injections, but he still kept on coming every 2 months. Third year, he took 2 Accentrix injections. He still kept on coming. So he was very upset. But at the end of it, the 4th year, 2 Accentrix injections, no further injections after that, and the patient's vision is 6, 9, and 6. So it's up to you which one you want to choose, injections or just do the laser and let the patient go with a reduction in vision. So what are the clinical presentations that we see? We can see patients who come with venous stasis retinopathy, fresh retinal vein occlusions in our clinic. If there is edema with these patients, then we should inject. We should also look at the systemic status of the patient and then decide if the patient has blood pressure or diabetes. First control the diabetes, control the blood pressure, and then we have to go ahead and inject. Sometimes patient comes with the extreme thing with the NVI or NVG, and many of these patients sometimes lose their vision also. So to conclude, addition of laser to ranibizumab does not offer any additional benefits. Ranibizumab has demonstrated well-established efficacy. Early, intensive, individualized treatment with ranibizumab provides good visual gains. Thank you.
We had just touched upon the macular edema part of it only, because in contrast to BRVO, CRVO is not a very good disease. Their laser may have a role primarily to if there is CNP or anterior segment neovascularization or NVG, or because for macular edema it's perfectly okay.
Yeah.
Because BRVO is a very benign kind of disease. It's suffices with a couple of injections and laser. That's the end of it. But in CRVO, the problem is the main vascular RVO. The main problem is CRVO, not BRVO. So there, what agent would you prefer, and role of laser there?
So I think maybe in today's era, if the patient is affording, aflibercept offers a much better resolution of the disease. And also in the first year, the patients who took aflibercept had a higher incidence of the vision improved much more as compared with ranibizumab, as per the latest 2022 study which has come, I think, in Archives of Ophthalmology. It's an Australian study. But even over here, the 2-year follow-up is not been done. So maybe at 2 years, they may tend to go together. But in the first year, they definitely did much better.
Are you implying that the choice is aflibercept?
The choice, if the patient affords, may be aflibercept for these patients.
It's not an issue because there are so many schemes available now. Plus biosimilars.
So whatever the studies show is that aflibercept has done better than ranibizumab in these patients.
Yeah, it's a known fact that aflibercept would be more effective, especially in patients who have moderate to severe diabetic macular edema. If it's very mild, okay. Yeah, even in RVOs, definitely the result with aflibercept is so much more potent, so much more faster in fewer injections, and the duration of effect is so much longer that you need to give much fewer injections. So this, I think that's very clear in our practice as well as in literature.
Dr. Vinod?
Sir, I think I agree, sir. We have been taught in PG to distinguish between ischemic and non-ischemic CRVOs, and I think that's very important. The moment I see ischemic CRVOs, you know at the outside that these patients are not going to do too well. So these are the patients who require more diligent, more follow-up and treatment. On the other hand, ischemic CRVOs do tend to become better. Non-ischemic CRVOs do tend to become better with anti-VEGFs. Again, aflibercept, definitely I've tried in few of my patients where ranibizumab or bevacizumab did not work, and those patients did improve after aflibercept.
Rohan, BRVO?
So BRVO, like Dr. Lalit sir has already mentioned, is a much more benign disease. So we have to be more careful about the late.
We have to be follow-up in BRVO cases. Future consequences are there. We are getting patient of vitreous hemorrhage or TRD, all these things. So regular FA should be done, Professor Lalit. What is the? Because people are not doing just injection, then leave it. Later on, patient comes vitreous hemorrhage with TRD.
No, the end result ultimately is an FA, that because you have to rule out non-perfusion either by Opta or by FA, that you have to take care of non-perfusion also. Usually some patients you may take care of macular edema, but CNP and utilization may still be there.
So the Octa will still give a posterior pole only. If you have a wide field FA, that would be a better.
There, but ultimately, or either way, either invasive angiography or non-invasive angiography, you have to rule out all this.
Okay, thank you, sir.
Thank you.
Thank you. Dr. Chinmay Sahu is there. He will be talking on the first and best biosimilar.
So I think
role of anti-VEGF in management of PDR.
Thank both Chinmay Sarkar as well as Ashish. They have flown all the way from Bombay to be with us.
Yeah, thank you Lalit sir for this opportunity, and good afternoon everyone. So coming from torrential rains in Mumbai to a much more pleasant weather in Delhi, it's a nice surprise out here. So we all know that diabetes is an epidemic, and by the year 2030 we are likely to have more than 100 million people with diabetes, of which almost 20% of the patients are likely to have severe sight-threatening diabetic retinopathy. Now, pan-retinal photocoagulation has been the gold standard for treatment and has shown to reduce the incidence of severe vision loss in PDR by 50%. One of the reasons it's popular is it's believed to have a long-lasting effect and is cost-effective. But what are the challenges? Almost 40% of the patients of PDR do not respond to PRP. 32 to 39% of the patients can develop vitreous hemorrhage, a large percentage of which will end up needing vitrectomy. It does not really improve, PRP does not really improve the vision acuity, and there is a risk of developing macular edema and loss of field. So we all know that there is a causal relationship between the level of VEGF in the vitreous and the development of PDR. Now, the RISE and RIGHT trial, which was done to evaluate diabetic retinopathy outcomes with ranibizumab in patients with DR and DME and the risk of progression to proliferative disease, clearly showed that at the end of 2 years, the risk of these patients developing PDR was down by almost 2 times, and by the end of the 3rd year, it was down 3 times. Also, if you look at protocol I of the DRCR.net study group, where they looked at diabetic, laser with ranibizumab with prompt laser, deferred laser, and triamcinolone acetonide, and they looked at the worsening of diabetic retinopathy in both the groups in which there was PDR and without PDR. They showed that ranibizumab with deferred laser reduced the worsening of diabetic retinopathy. So these two studies laid the basis for trying out anti-VEGFs in proliferative diabetic retinopathy patients. Now, what is the evidence at hand? If you look at protocol S of drcr.net, where they divided the patients into two groups. The first group took 6 injections of 0.5 milligram ranibizumab monthly, and the other group was, where PRP was done, and they compared the two groups. The important take home out here is that in the group which had diabetic macular edema, the vision letter gain at first year and at second year was maintained and was statistically significant. In the second group without diabetic macular edema, the vision letter at first year was significant, but it tapered off by the end of the second year. So in the patients who had concurrent diabetic macular edema, definitely the ranibizumab injections did better in terms of vision gain. Now, even if you look at secondary outcome measures, the visual field loss in the group with ranibizumab was lesser. The number of patients with diabetic macular edema in the ranibizumab group was at 9% versus 28% in the pan-retinal photocoagulation group, and the vitrectomy rates was 4% versus 15%. Now the common problem is like, okay, this is fine, but what about the cost effectiveness? Now actually we tend to look at it as the immediate cost to the patient. But if you do a incremental cost effectiveness ratio, and if you look at it in terms of the quality adjusted life years, what this particular study coming out from the drcr.net group in US showed that the patients with vision impairing DME along with PDR, it actually was more cost effective to give ranibizumab injections compared to just doing a pan-retinal photocoagulation. Now, two other studies, the PRIDE study, which looked at the safety and efficacy of ranibizumab with or without PRP compared to PRP alone in patients with PDR. They looked at the area of neovascularization, and they found that there was a complete regression or leakage from the neovascularization, and it was much more in the group which was getting ranibizumab versus the group which was only getting PRP. If you looked at the Proteus study, which looked at patients with high risk PDR, and they compared ranibizumab with PRP compared to PRP alone, again in this group they found that the amount of patients who were getting a complete regression of neovascularization was more in the combination group compared to only PRP, and the time to complete regression was almost shortened by half in the first group. So there was a superior outcome. Now if you look at meta-analysis done on this particular topic, there are two big meta-analysis studies which have come out. This particular study, which covered around 15 studies and almost 3,000 eyes, showed that 0.5 milligram ranibizumab per month had a best effect on vision improvement, and the change in the central retinal thickness was more in the group which had ranibizumab with PRP, and the overall incidence of adverse reaction of PRP was greater than that of ranibizumab. Another meta-analysis, which had 5 studies and 630 eyes, showed that there was a 4-letter gain compared with PRP at 12 months, and there was a 10% absolute risk reduction in the need for future vitrectomy and vitreous hemorrhage rates in the group which was getting ranibizumab. So what we have established is that ranibizumab can help. Do we give ranibizumab before or after the PRP? So this particular study showed that giving ranibizumab prior to PRP decreased the kind of need of laser, the intensity of laser, and additional treatments. So just to conclude, in real time, in real practice, what is feasible? When you have a patient of proliferative diabetic retinopathy with clinically significant macular edema, definitely considering ranibizumab with PRP is the way forward. If you have patients in certain special interest situations like dense cataracts, vitreous hemorrhages, neovascular glaucoma where corneal edema is significant, vision is, laser is not possible, definitely considering ranibizumab or anti-VEGF is useful. patients where there is PDR with no traction and the patient compliance is good, both the PRIDE and Proteus study showed that the regression of the neovascularization is much better if you are combining it with ranibizumab. So on an average, there is data out there to support the usage of ranibizumab or any anti-VEGF in certain special situations when you're dealing with proliferative diabetic retinopathy. Thank you, sir, for your patient here. Thank you.
Yes, anything, Dr. Lalit? Dr. Rohan, you have done this study. What is your
very nice take-home message is actually the effectivity of ranibizumab in PDR with DME.
Right, sir.
That is very important.
Yes, sir.
Because people should not go with the impression that PDR alone.
Yes,
because
it's mainly with the
protocol S, what the study where people push ranibizumab only in PDR. That is not a very wise choice. With DME, yes, the both quality of vision. But aim is when to do. First injection or first laser, or first injection, then laser, and then more.
So I think still most of us, when we deal with proliferative diabetic retinopathy, if there is a clear view and there's a
problem is PDR is not one entity.
Right, sir.
PDR, you have to divide mild PDRs, HRC PDR.
Right, sir.
With issues like
so, sir.
We are not talking of PDR with complications.
Correct, sir.
TRD has to be so we are talking mild versus HRC PDR.
Correct, sir. So I think in patients where it's PDR, you have a clear view. There is no coexisting macular edema. There's no dense cataract. Vitreous hemorrhage is not present. Still, panretinal photocoagulation is the way forward. But given the other features, if you're having vitreous hemorrhage which is impairing, you're doing the PR. So basically the take home, sir, here is if you have coexisting diabetic macular edema, starting off first with the injections and probably waiting for the edema to also settle a bit and waiting for the neovascularization to regress a bit, and later then completing the treatment with the panretinal photocoagulation. That could be because
Sir, PDR with DME is not an issue to discuss. Actually, everybody starts with anti-VEGF and do the PRP.
Yeah, that's what I was going to say, that when there is PDR, we don't give so much importance to DME. We do inject and start laser at the same time.
Yes.
And
it's the cases with high-risk PDR. I would like to know what Rajiv, Rohan and Vinod and then Shroff and Saurabh, what you are doing. Cases with only high-risk PDR, you are doing only PRP or you are combining with anti-VEGFs?
Rohan? राजीव इधर आ जाओ, आपकी चेयर.
So I start with PRP only, but I give spacing between PRP a bit longer. Normally I give 1 or 2 days in between, so that we don't want this traction to increase.
So you don't give anti-VEGF along with PRP in high-risk PDRs? Vinod and Rohan.
I think there are two issues here. Sometimes you don't have any center involving macular edema, but
it's center involving macular edema.
I'm saying there's not there.
See, there is no edema. It is just high-risk PDR.
So even if there are some cystoid spaces off the center, I have low threshold for giving anti-VEGF in these cases. Number one. Number two, if I feel there is sometimes there is high risk of bleeding once you will laser. So that is very individualized, no definitive rules, but I feel this patient is at a higher risk of bleeding post PRP. I do not hesitate to inject.
Absolutely right.
If you are talking of only high risk PDR, not going to what again sir was saying that there is some element of traction or TRD, less than that, just high risk, not a very aggressive PDR, then and no macular edema, I would still go for PRP.
No anti-VEGF.
No anti-VEGF. I can add it later if I see that the resolution is not good, but at the day one I would go for PRP.
What are you doing again there?
Like my opinion.
Yeah.
So I think
basically
I think a larger decision to give an injection in high-risk PDR also depends on the quality of the posterior hyaloid, and I think that really makes a difference. So if you have a very taut posterior hyaloid, I think I would like to avoid an anti-VEGF. But otherwise, if the posterior hyaloid is not so taut and you don't have a very thick membrane or something like that, then I think yes, sometimes giving a anti-VEGF before doing laser does help in certain situations. But so it's very individualized. So and definitely macular edema then plays a different role altogether. That's different. Yeah.
So for
there's a high risk of vitreous hemorrhage. It's better to give an anti-VEGF because the vitreous hemorrhage will obscure your laser. So your laser gets difficult. If you give an anti-VEGF, start the laser, you'll be able to continue your
Exactly.
Yeah, but
I have started doing this, like I do the laser first sitting to the patient is there, and then I give anti-VEGF and then carry on with my PRPs.
You see, remember that laser can induce macular edema also. Also keep in mind, there should not be too much of gap between them. But if there is a high risk PDR, yeah, I would start lasering and within few days inject also.
Yes.
And then complete the PRP.
Just to reduce
because
the level of hemorrhages.
I don't want only only anti-VEGF.
If I can just add a couple of points, like especially if you have insulin-dependent diabetic patients with coexisting nephropathy, or if you have patients who are young coming to you with PDR, at times they progress very rapidly, and when you do PRP, it does take time for it to take effect. So such cases also probably considering the anti-VEGF at the straight away and then adding the PRP might help. Yeah.
What to say? Anti-VEGF decreases the diabetic severity score. In some studies, it has found.
So that's what they have shown, that in those patients with that particular diabetic retinopathy severity score of 37 to 52, the progression to PDR, they showed that giving the anti-VEGF injections did reduce the progression to proliferative stage.
Okay, thank you, Dr. Chinmay. Now, I will invite Dr. Gupta, who will be talking on Razumab, the first and the best biosimilar.
Dr. Rajiv, can you join us?
Dr. Rajiv, you are on the chair.
Thank you, sir. Thank you, Sao, for giving me this opportunity. Shifting to biosimilars, Razumab, the first and the best. If we look at the load of retinal disease, wet AMD and diabetic retinopathy are among the leading cause of blindness globally. And more than 1 crore patients are affected in India, and the disease burden is increasing day by day. The available anti-VEGF in the markets are Bevacizumab, Ranibizumab, Aflibercept, Brolucizumab and Faricimab. So few questions starting, all 1 CR patients are getting effective treatment. The answer is no. Does the cost matter to the treatment? And the answer is yes. And because we'll see in further slides that because of the cost, many patients don't follow up with the treatment. I'll be covering my talk on the following headings, and if you look what is a biosimilar, biosimilar is basically a chain of amino acids, and it's not as simple as a molecular agent like Ramipril, which can be made easily in the lab. Monoclonal antibodies are always produced through live tissue, that is E. coli cell culture. So biologicals are recombinant therapeutic proteins that treat and cure diseases, and biosimilars are biologics, that is highly similar to the reference product with no clinically meaningful difference in terms of safety, purity and potency. If you look at the peptide mapping of the innovator product, that is Lucentis, and the biosimilar Razumab, the peptide mapping is almost similar, thereby telling us that product what we are using is almost similar to the innovator product. But where is the problem? The problem is number of injections. We know over a period of time that 1 injection is not sufficient to treat a disease, and this causes an increased cost burden to the patient, and this is the main reason for discontinuation of the treatment. If we look at the protocol T results in diabetic macular edema, the number of injections in year 1 was 9 injections in almost all groups, Aflibercept, Bevacizumab and Ranibizumab. And if we see 2 years results, the number of injections in the second year was 5, 6 and 6 across the group. So the total number in treating diabetic macular edema within good 6 to 7 letters improvement in vision, you require at least 14 injections. If you look at the AMD data, to get a gain of 7 to 8 letters, you need 16 injections of Ranibizumab and 18.2 injections of Bevacizumab in cases of over a period of 2 years in cases of age-related macular degeneration. Across various study in age-related macular degeneration, you get an improvement of 8 to 10 letters from PRN to treat and extend, and the number of injections what you require is 7 to 8 injections over a period of 1 year. So the poor compliance to anti-VEGF treatment is a major concern, and around half of the patients, that is 51.54% patients of DME, AMD and RVO are lost to follow-up because of non-affordability, and that is 41%. If you see the data, 41% patient lost to the treatment. So it's better if the patient is not able to afford and then shift on to biosimilar. In comparison to the present biologics, the biosimilar agent lead to 50% reduction in treatment of cost. If you look at the cost, Razumab is available at 5,000 rupees, Ranuzumab at 18,000, Aflibercept, if you take Eylea for You program, is 18,000, Pagenex is 28,000 and Vabysmo is 24,000. So the total estimated annual cost of treatment was between 140,000 to 2 lakh for innovator molecule, in comparison to 80,000 to 1,20,000 for a biosimilar. So the cost becomes almost half. The second problem, if you look at the data, 18 to 22% of Indian population is below poverty line. Treatment costs are not covered by insurance company, but now, previously it was not covered, but now it is covered. But the main problem with insurance is that you get a coverage of 10% of the total amount. Like if the patient has a coverage of 2 lakhs, he'll get an anti-VEGF of 20,000 per year. So with that, in a policy of 2 lakh, you can give only one anti-VEGF under insurance cover. So it's better to give a biosimilar rather than go in for an innovator product. And approximately 70% of Indian pay from of health care expenses out of their own pocket. So biosimilar makes the medication affordable and helps to reduce the substantial cost burden on the patient. Since it was going good in our market, Indian market, West country has also adopted to biosimilars, and various biosimilars are now available, like with Samsung FYB201, SB11. These are both European markets and FDA markets approved, and you have CKD 701 in South Korea and XSB 001 just launched in US. The second point, apart from the cost, whether it's safe and it is effective. So what we did is an clinical efficacy and safety study of Razumab, and this was published in IGO, and this was one of the first studies what we did. And the aim of the study was to evaluate the efficacy and safety of Razumab for treatment of chorioretinal vascular disease such as diabetic macular edemas, choroidal neovascular membranes and macular edema. The primary outcome was to measure the improvement in CDVA and CFT from baseline 1 month to 3 months. The secondary outcomes were safety of the drug and systemic side effects seen in our patients. I'll skip this. The number of eyes what we did were 153, and out of this 153 eyes, 121 were treatment naive eyes. The logMAR CDVA improved from 0.062 to 0.042, and 45 eyes had gain of more than 2 lines of visual acuity. The CDVA improved in 97 eyes, remained the same in 55 eyes, and worsened in 1 eyes. If you look at the CFT values, it improved from 405 to 271, and there was a marked statistically improvement in central foveal thickness. Across the group DME, AMD and RVO, you can see a substantial increase in visual acuity, and CFT decreased from 436 to 275 across all groups of DME, CNVM and RVO. Another, what were the usage of biosimilars among vitreoretinal surgeons across India? And a survey was done with the help of Interbios and VRSI. In this survey, an 18 questions online survey was done, distributed by Vitreoretinal Society of India with official email and WhatsApp. It was done between July 29, 2023 to August 18, 2023. So what were the results? 80% of the doctors who took the survey said that the Ranuzumab is the most preferred biosimilar among the Ranuzumab. 75% of the doctors said that both innovator product and Razumab has equal efficacy. 90% of the doctors said because of the decreased cost to the patient is the main or the prime reason why they are using a biosimilar as compared to the innovator product. And if you think, do you think biosimilar drugs have made anti-VEGF treatment more affordable? 94% doctors said yes. And 95% doctors said that they will keep on using biosimilars in their practice because the results were almost comparable to the innovator product. Ranibizumab biosimilar makes up the majority of Ranibizumab uses for clinician practice in India. They are considered equally safe and efficacious compared to the original Ranibizumab. It is cost effective, approved by DGCI, and Ranibizumab has become the first line of treatment for patients of AMD, DME and vascular occlusion. Thank you very much for your kind attention.
Abhinand, you didn't answer the question. Ranibizumab is the best.
So that VRSI surveys are already answered because bulk of the doctors in Vitreoretinal Society, almost 80% of the doctors are using it. Second thing, we also adapted this molecule after doing our own analysis on our patients, and the study what we have done of 201 patients, we showed there is an efficacy with minimal side effect. So
today a patient comes to you, a politician, he says, I have no issue, cost is not an issue. What do you ask him? You use this or this?
If molecule is Ranibizumab, I will offer him Ranibizumab only.
Sir, I have a question for all of you. How do you decide which biosimilar you want to use? Like the options we have is Razumab, then Renize and Usiva, and all of them work well.
Better is not to discuss this because I think pura evening waste ho jayega.
Cost, sir, because it's very difficult. These people keep on coming, they keep on showing you some studies done somewhere.
I don't think so studies are required. I don't think studies are required because maximum there may be some safety issue at all. Because whenever a new even Ranibizumab had that polysorbate, some issue was there in the 18th batch or somewhere. But believe me, all these molecules work equally well. I don't think so there is any edge of efficacy. Safety is prime concern. So initially all of us test, suppose in my hand Renize works, so I start using Renize. So Ranibizumab was the first batch that had the advantage. क्योंकि सबसे पहले लॉन्च हुआ तो उसको एडवांटेज हो गया. So that is the reason Ranibizumab became very popular. Now it competition हो गया तो they have lowered their prices. So the advantage of competition is for the patient. So my main concern, which we will not talk about it because in the सारा session में हो जाएगा, is primarily cost then pass on to the customer. Patient is not getting the. You see today if you talk of biosimilars, sometimes they are more expensive than Eccentrix also. Because although the MRP is 18,000 rupees, but the cost is 5 plus maximum 5, they should be given at 5, 10 maximum. But they are being offered at 23. That is the issue. So they become more expensive than Eccentrix then. Because Eccentrix has 2+1 scheme also. So therefore don't ask this question, which of the biosimilar? Believe me, all of them. Answer is all of them were equally well. There's hardly any edge. So whichever company gives you some scheme, some benefit, you should. We have used Renize, we have used Ranizuril, we have used
all work very well, sir.
Vizumab, they all work. Only problem came was with Optimab, which is now withdrawn.
But it takes time. It takes few eyes before you withdraw that. You decide.
Let's move on. If anybody has any answer to his questions, he can, but I don't think so.
Can we now invite Vinod for his interesting cases on anti-VEGF? Thanks, Vinod.
So Vinod is known to dissect all this, he's very critical of his presentation.
I would like to thank Dr. Lalit Verma, sir, for having me here. So I'll break the routine a bit. So I'll be presenting 3 of my cases. I found them little off normal routine. So that's why I'm presenting them here. So each has few things to learn from each one of them. So I'll not going into that, but I'll just present my cases. So this is my first case, 68-year-old male who presented to us with decrease of vision in his left eye for past 2 weeks. The best corrected vision at that point of time was 6/9. He had obvious polyps on ICGA and a well-defined neovascular network. So he was started on aflibercept loading dose. This was the OCT on presentation, and you can see the polyps here. So this is 2 aflibercept later, and the patient was 6/6, and this was after 3rd dose, and he was nicely flattened out. The vision was good, patient was happy, but unfortunately he was lost to follow-up. So he presented to us again 8 months later with visual acuity of 6/8. You can see now the PEDs are much larger. There is some subretinal fluid there. So the patient was again started on aflibercept. This time the subretinal fluid went away, but the PEDs remained there. So you can see this is one aflibercept. In fact, I had put him on treat and extend because there was no subretinal fluid. The PEDs were not getting smaller, but the subretinal fluid had gone. This was after 3 aflibercept 6/12. He did not regain full vision, but this is how he looked like. But he was again lost to follow-up. Came back this time after a shorter interval of 3 months, and this time the visual acuity was 6/60. You can see the PED has flattened out a bit. There is some hyperreflectivity which is coming beneath the PED, and there is definitive subretinal fluid with some shrem beneath the retina. So again at this point of time again started with aflibercept, and the fluid came down and the PED also coming down, but not totally. And you can see even after 3 aflibercept some amount of subretinal fluid was remaining. So the patient was getting fatigued out, so were we. So at this point of time we talked to the patient and counseled him. He was agreeing to switch, and we switched to brolucizumab. So this is after 1 month of first brolucizumab, 2 months of first brolucizumab, then he received a second brolucizumab, and it's been 8 months after second brolucizumab. He has dried up totally, and till date after 8 months of second aflibercept has not required Paginex, second injection of Paginex, brolucizumab has not required further injections till now. So what happens subsequently remains to be seen. So this is my first case. This is again a very long story of elderly female who presented to us with neovascular AMD back in 2016. Elderly, a 78-year-old female. She presented to us with decrease of vision in the left eye and metamorphopsia for past 1 week. The best corrected at that time was again 6/9. The right eye had poor vision because of a large disciform scar. At this moment she had, you can see a large nice network here. On OCT, though there was some shrem, no subfoveal fluid, but there was retinal fluid in some other area. The patient was on PR and Avastin from 2016 to 2021. She had around 20-22 injections during this period. It was not a very aggressive disease. But in 2021, the frequency of injections increased, and she required around 5 injections in 2021. At this point of time, she was kind of, I don't want to receive so many injections. We had Paginex, new one, counseled her, shifted on to her Paginex, and till March of 23 from October 21, she was stable on 3 injections of Paginex. The vision was 6/9. But here, till here everything was normal, and then the things turned for bad. In April 23, she presented with sudden decrease of vision with this. She had a massive bleed, which fortunately for her was sparing the fovea, not too much beneath the fovea, but below and above the arcade there were massive bleeds. But because there was not much bleed beneath the fovea, so we injected her with ranibizumab at that particular time, and injected 0.3 ml C3F8 and advised prone position. 2 weeks later, after this injection of gas as anti-VEGF, she presented with a breakthrough hemorrhage. So being one-eyed, we took her for vitrectomy along with the repeat ranibizumab injection, and a SF6 gas was injected. But after 2 weeks vitrectomy, again she did not improve. The vitreous cavity was full of hemorrhage, and again she underwent a vitreous lavage 2 weeks later after this vitrectomy. So after the vitrectomy she came back, she had improved. You can see all the blood had gone. We had a large massive RP dip here in the temporal retina away from the macula. The subretinal bleed was all getting organized. The vision fortunately for us improved to 6/12, and you can see the OCT, the fovea still looks good. So again she was stable. This was in August 23, this was in November 23. Because usually most of these patients do not rebleed and there was no activity, we did not choose to inject this particular patient. So in April 24, she has activity on OCT. She underwent an injection of Paginex, and in May 24 she again presented with a massive bleed, this time involving the macula. You can see a bleed here. Again, this patient we injected, I did a air fluid exchange because the eye was already vitrectomized, injected SF6 gas along with the ranibizumab injection. So this is in June 24. This time again she improved. All the subretinal, subfoveal blood was gone. We could see the bleed in the other places, and this is in July 24. Recently she had improved to 6/24, and the OCT again looks good. So this is a story of patient, a long story, where she had massive bleeds after a quiescent period, which is relatively rare. And I always wonder, she received one Paginex just 1 month before the second bleed. So I don't know why she bled like this again. Unfortunately, I think if we could have done angiography, maybe ICG or FFA, could have given some answers at that point of time, but it's difficult to tell now. So this is my second case. I think time is over. If you allow, I can go with third case, or we can stop here as you say. It's a short case. I'll quickly go through the case. This is a patient who presented to us in COVID era, 43-year-old male, had a CSC with subretinal fluid and a subretinal fibrin. You can see the eclipse sign here. The vision was very bad. So at that time there was no CNV. Did a subthreshold fovea, laser at the fovea. The patient improved. This is how presented with August 21, 6/24, and slowly the PED started enlarging with some hyperreflectivity beneath the PED. The vision was 6/36. Again the patient was though improved but still was not happy. So discussed with him. So this is how he presented with. So I gave him one injection of Paginex, the brolucizumab. You can see the PED came down, the hyperreflectivity beneath the PED came down, and after 3 injections of Paginex, it's almost flat, and the patient improved to 6/9. He remained so for almost 2 years stable, but now again has presented with enlarging PED and decreasing vision. You can see the vision has come down to 6/24. I have again advised brolucizumab for this patient. Let's see how this patient comes out subsequent. Thank you.
Second patient, what we have learned ki after doing your first vitrectomy or after when the lesion was acquired, we could have done an ICG angiography which could have given us a clue where the polyps are and if they are extramacular. Then we could have done a focal laser or a thermal laser for these patients.
Actually, yeah, you are right. Retrospectively, yes, we could have done. But looking at the fundus, it never looked like as if there was any activity. It was all quietened down, not a speck of hemorrhage anywhere. So, yeah.
Vinod, the problem is that you made a statement, no activity, no injection. Believe me, making out that no activity clinically is not answer. You can't say no activity on clinical medicine, because all the diseases, we don't treat disease at all. We just treat the effect of the disease. If the edema occurs, we inject. If hemorrhage occurs, we inject. Vision falls, we inject. But for for it to be labeled as no activity, I think what Aegis says that you have to have an ICG, and then also you have to be on the guard. The problem in all the patients is lost to follow up and then comes with massive bleeds. So therefore IPCV, they have to be, they sometimes will bleed so heavily that, these patients have to be on reasonably continuous dose of injections.
Yes,
you are the moral of the story from second patient.
But here we are dealing with a patient who did not have a central PCV. He had a type 1 CNV in the center, and subsequently she probably developed a bleed due to a peripheral, you can say PHCR or CNVM, whatever you want to say it. And so there was a peripheral rip here that again signifies something separate happened in the periphery. So again, I think we have seen lots of PHCRs or peripheral CNVMs.
But lesson to be learned from your case is that counseling is very, very important, because you can't afford to lose this patient, because these patients, you were lucky, patient was lucky that patient regained 612, 624 vision, but ultimately counseling has to be very, very important.
Yeah. So something similar I would like to say. Like first thing is that only the ICG thing, and to your first case, right, Vinod, I had something similar case. I had presented in DRF. So this case was like something a very tall PED and with a shallow SRF. I kept giving aflibercept. I had done a baseline ICG and FFA. There was nothing on that. I kept doing, giving aflibercept. The patient was like very too pro to the injection. 4 or 5 injections I gave, and after that, still the SRF was coming again and again. All of a sudden there was a very heap of SRF. So that time I was a little doubtful ki now is it something different. So I didn't repeat ICG and FFA, in which I got 2 things now. I got a CSR leak and I got a polyp. So that was a surprising thing that above, like even after 5 aflibercepts, the polyp arose. And I called these guys and I told, aflibercept giving rise to polyps. So they were surprised.
Again,
so I mean that, BVN might be there, which may not be visible. So even in that patient, I did on Octa. Octa also didn't show me anything. And kind of a pachychoroid, I would say. It was a basic component which involved both the factors. Then I had to do a CSR. I did a focal laser. And then, finally the SRF resolved. And again, I repeated aflibercept.
They both can coexist. That happens in quite a few patients, and you have to tackle both of them accordingly.
Thank you, Dr. Vinod, for presenting interesting cases.
So one last.
Now I would like to invite Dr. Rohan Chawla,
Dr.
Malika Goel, who will be talking on why I prefer aflibercept in a wet ARMD and DME.
So again, thank Malika from core of my heart to have flown there from Hyderabad for this particular meeting.
Thank you very much, sir. Thanks for this honor and privilege. It's my pleasure. So this topic, why I use aflibercept in most of the retinal vascular diseases, I'll be speaking about my own experience. So when ranibizumab was the only available agent, it was also working wonders, as we know. However, in non-responsive cases, we started switching to aflibercept. And that is when we realized its strength, efficacy, speed of action and longevity of response. So as we see here, typical case of CNVM, we keep giving every month ranibizumab, it's only getting worse. And this is a recent patient, last month itself. And then as soon as you give aflibercept, everything resolves. So in these patients, we started realizing its undeniable strength and speed of response, which leads to a better final visual outcome because it prevents foveal damage from chronicity. And the longevity of the drug reduces the treatment burden, which is not only the reduced number of injections reducing the cost, but also the risk. Every injection has a risk of endophthalmitis. And then we also started seeing that many of our patients were actually able to go off therapy, even in PCV and AMD, for long periods of time, and even sometimes they could stop treatment indefinitely. And so with these benefits, it then became the drug of choice very rapidly. And then gradually, as newer agents are coming in, we are also realizing that while it is as effective as the newer agents, we have the additional advantage of safety. The inflammation and the occlusive retinal vasculitis, which are seen and reported with the newer agents, are not seen with this drug. So this is its, I would say, the biggest advantage of aflibercept, which is why I have continued to stick to it. And these newer agents should therefore be avoided in treatment-naive patients is what I think, definitely, because of the risk of occlusive retinal vasculitis, which is reported with both the newer agents. For example, right now we are dealing with one patient with post-brolucizumab occlusive retinal vasculitis. She has a retinal detachment, very severe occlusive vasculitis, for which we are treating her with other anti-VEGFs, steroid injections, laser has been done, and systemic steroids. And for the last 2 months, we are still treating her. This was the picture yesterday. She's much better now, but started with AMD and landed up here with occlusive vasculitis. So this is one of the major advantages of continuing with aflibercept. Now we know that it is a very strong molecule with dual mechanism of action, and because of this, protocols have been modified worldwide to include a Q16 protocol, and it is also found that patients on this drug are 3 times more likely to be able to stop treatment for AMD than if they are on Avastin. And this is what we have also seen, that we are able to stop treatment. Now this is an elderly gentleman with PCV. You see a polyp here on the ICG. Ranibizumab did not work, 3 injections. So then we shifted to aflibercept, and you see with 3 loading doses, he became quiet. And at this point, the polyp also disappeared on the ICG. So within 6 months of starting aflibercept, he was free of the disease. But we still gave him Q16 to Q24 injections, 3 to 4 injections, and stopped treatment. And he hasn't had any recurrence after that. So rapid weaning off of treatment. And this is another similar lady, which I think was being discussed. A large PD in a PCV. Here's the polyp. Now we gave 5 injections, because at that time we did not have any other drug to say that, okay, let's shift. We gave 5 injections, and by this 5th injection she suddenly flattened out. And that was within a year of treatment. The polyp has also regressed. So within a year the disease has gone, and the polyp has never come back. Another elderly lady, bilateral AMD. So I'll speak only about one eye, because the 2 eyes I have found generally behave very identically in terms of response and frequency of injections. So here we gave 1 injection, and you see that she never had a recurrence after that. Vision improved immediately, and at 6 months after the 2nd injection she had some fluid, but thereafter she did not have. So we still injected at 6 months, and that was 1.5 years back. And now, so after that we have never injected her, and there is no problem at all. Similarly, another lady with gave an injection, no activity, still injected at 6 months, no activity. Then at 11 months after an injection there was an activity, and then again that has settled down, and even the CNVM has regressed on the octa. So treatment intervals can be much longer than 6 months, even 11 months in this case, with retention of 6/6 vision in most of these patients. Similar story here. 2 months later there is some fluid remaining with 1 aflibercept, but after that there is no activity. Now it's 17 months since the last injection. When I saw her last in November, there was no activity at 17 months with 6/6 vision. Peripheral PCV, we can be even more lenient in our injections, less frequent, because the margin of safety is little higher. So here we can give, we give at 6 months even, or even longer sometimes, depending on the activity of the disease. So that was about AMD. Now about DME. Again we started with cases that were recalcitrant, and we burnt our fingers because we waited too long before we switched, and we lost a lot of vision in that. For example, this patient, he was responding initially to IVTA, but it stopped responding, but we still continued because of financial reasons. Then we shifted to Dex implant, no response, and after 3 years of all this struggling, we shifted to aflibercept with immediate response and immediate visual improvement. And then now, initially he required every 5 months, and now he doesn't, since October he has not required any injection. So if we had switched earlier, we might have preserved better visual acuity, and hence we have shifted to this as the drug of first choice in every patient. Sometimes the anatomy may not be that good, but the visual response is very good. As you see here, see the vision is 6/12 N6, and that is 9 months after an injection. So he gets an injection once in 12 months and with excellent vision. So visual results are often superior, and near vision is usually better, responds better than distance vision. An interesting fact we found in these patients is that the hard exudates respond very well to aflibercept, just 2 injections and it's gone. So it's not necessary to shift to steroid just because of hard exudates, because we know steroids cause cataract, raised IOP. And we also found that aflibercept remains unaffected in vitrectomized eyes. The effect lasts for 3 to 4 months, as does a DEX implant, and that has been supported by literature as well. So this is now a drug of first choice, because 1 injection, and you can see that even 5 months after the injection, the vision and anatomy continue to improve. And recurrence happens at 14 months after the last injection. So these are the advantages. So this is the concluding slide. Due to its strength, speed of action and duration of action, it has drastically improved the prognosis and reduced the treatment burden of AMD, PCV and DME. And most importantly, it has the highest safety of all available agents. Majority of my patients are extended to beyond 612, and 30 to 40% can be extended beyond 616, sometimes 6 monthly, 8 monthly, or even off treatment after 1 or 2 years. Now we wait for aflibercept 8 mg, which has the same safety but with much more extended treatment intervals. Thank you.
Thank you, ma'am, for the excellent talk. One question. In cases of PCV, do you treat sub-RP fluid also, or you stop when intraretinal fluid dries up?
Well, we do attempt should be made to flatten out the RP, because it's always a risk for coming back with massive submacular hemorrhage. So definitely it indicates some activity, but there are patients who do not respond, then that time you accept it.
My question is, when do you start extending it? Like once the intraretinal fluid flattens down, then you start extending it, or you keep on giving 1 monthly doses till the sub-RPE fluid flattens?
Yeah, so if I find that in a couple of injections or 3 injections, the RP height is not changing, it's not going down, then I accept it. Then I accept it and start extending. But if I find it is progressively reducing in height, that means I could do better and I would not extend.
One question.
For you, no other molecule exists except Eylea?
Practically, because I would not like to take the risk with brolucizumab. I showed that case. If I talk to the patient, I tell them in non-responders that I can offer you another drug, but there is a small risk with both the newer agents of occlusive retinal vasculitis or inflammation.
Other biosimilars or,
So if you are already using aflibercept and it's a non-responder, it's not going to respond to ranibizumab biosimilar.
You achieve 11 months or 17 months, but after how many injections generally?
It's variable, sir. Sometimes even after 1 injection, I showed many of those bilateral cases after 1 or 2 injections.
Plus this statement that hard exudates resolve after 2 injections is not very common.
No, not
very common to see hard exudates resolving.
Sir, it also depends on the systemic control of the patient.
Yeah.
If this systemic control is good.
So because if you make this statement that hard exudates resolve after 2 months, I know diabetes is a multifactorial disease and so many factors play a role. So everybody will switch on to one.
Actually, in the interest of time, I had to remove those cases where I had to show it went only after several injections. Yeah. But both topics combined, I had to cut it out.
Dr. Kunal, you have a question.
Ma'am, if the patient is a non-responder after 3 loading doses, what is the next choice of drug that you'll have?
See, 3 loading dose is not necessary. 5 or 6 is also, in many of these trials, it's 5. For example, in my case, which I showed when PCV, it was after the 5th injection, it immediately flattened out, polyp regressed. So there's no such thing as 3. You can give 5. I had a case of PCV where the PED was not going away with aflibercept. So I gave DEX implant and then it immediately flattened out. So it's known that steroid may be added to an anti-VEGF in a non-responding PED.
To be given and it's not responding. Yes, majority patients will not be keen to carry on with more than 3, though she is right that certain cases do respond on 5th and 6th also. So it's a fight between Broly and faricimab, whichever you are comfortable with your.
Just one point about hard exudates, sir. It is my observation that they need much more intensive treatment every month or every 2 months. If they take longer intervals, it starts coming back. And then systemic control is extremely important. It doesn't work without it. These two things.
Ma'am, one question. If you have an hard exudate with a normal lipid profile, will you start antilipidemics to these patients or no?
Generally, I don't start if the lipid profile is normal. But the field study says that fenofibrate works even if the lipid profile is normal. But I don't do that. To answer sir's question whether aflibercept is the only drug I have, actually it's not the drug I have. I do offer other agents, but I give them the option saying that you could lose your vision from these things. So then most patients don't want it.
Poking just because to take
No, I have used faricimab for 20 patients actually. So I have used. It's not the only agent, but it is the bulk of the drug.
No, I agree. If, even with aflibercept, you can extend till Q12, Q16. Aflibercept, there is no doubt that you can extend. In fact, sometimes I jokingly ask, what will 8 mg do in addition to this? We have already started using more. You see, aflibercept, the volume is already higher.
Yeah.
We inject sometimes more.
Double,
also,
yeah.
Chal, thanks a lot.
Thank you, sir.
I think with this, we move to our next speaker, Dr. Gagan Bhatia, who will be speaking on molecular differentiation of anti-VEGFs.
So good afternoon everybody. On the outset, I'd like to thank Dr. Lalit for this opportunity and SAO. I think going from all clinical data, I think we go back to the basics, which is molecular differentiation of molecules that we have. So many of these slides have been provided by Bayer, and we go back to, I think, studying the basics. I think whenever we talk about any product or we talk about a molecule that we are using, we basically talk about binding affinity, potency, half-life and clinical targets and the molar dose. So going one by one, I think if we compare the molecules that we have at present. So binding affinity basically is that how strongly a drug attacks or attaches to its targets. So if we see over here, there's something known as a KD value, which is the equilibrium dissociation constant, and which seems to be the lowest with aflibercept, making it one of the most efficient molecules to bind to its target. Second is potency, and if we come to potency again, I think faricimab, we still don't have the current values present, but out of the other three molecules, again aflibercept seems to be more potent as far as the lower IC value or the inhibition constant is concerned, which is basically the minimal amount of drug required to cause the maximum effect. Then coming to half-life, I think that is again the concentration of the drug. Again, we have aflibercept, which seems to have the highest half-life, proving it to be a little more better out of the other three. As far as again the binding target is concerned, I think this is a newer thing that we have all talking about Angst2 and PIGF and the fight between the two. So aflibercept is more of a multi-targeted approach, whereas faricimab, the newer drug, is dual target, and then we have brolucizumab and ranibizumab, which are basically single target molecules. So if we compare this whole data at one, we see that definitely I think aflibercept, being a smaller molecule, has a higher molar dose, and that over and above that, I think aflibercept seems to be the better molecule out of all of this, based on the basic definition of a molecule per se. Now coming to the signaling. So if we go from the molecule part to the pathological part, so basically we have VEGF receptor 2 and VEGF receptor 1, and VEGF A is something which attaches to VEGF receptor 2 and PIGF to VEGF receptor 1. So one of the other important things is PIGF. So there is basically, it is about covering PIGF and Angst2. So PIGF is basically a placental growth factor, which kind of causes damage by leading to inflammation, neovascularization and vascular leakage, and this is a molecule which basically attaches to a separate receptor, which is VEGF1. So it increases the monocyte, it attaches to the endothelial cells and causes angiogenesis. The other point is that, once the endothelial cell is kind of activated, it is a bi response, and it again goes and activates the tissue macrophages, leading to further damage. So if we see this in an in vitro study, if we see that, so there is in DME as well as RVO, there's almost 61 or 154 times upregulation of VEGF, and whereas there is also upregulation of PIGF in both the diseases. And post anti-VEGF molecule, you see that the PIGF levels as well as the VEGF levels do decrease, and it's not like they are concurrent. And why I say this is because of the next slide, which basically we talk about Ang2. Now what is Ang2? So Ang2 is basically usually in a low VEGF state, it is Ang1 which is binding to the Tie2 receptor. So as we spoke earlier, PIGF binds to VEGF-R1, whereas Ang2 which is present in faricimab binds to Tie2 receptor. This Tie2 receptor in normal states is bound by Ang1, which is basically more protective, and it basically leads to homeostasis, it leads to vascular stability, and also inhibits vascular permeability. Whereas in high VEGF states, what is seen is that the Ang2, there is a reversal, there is a change from Ang1 to Ang2, and the Tie2 receptor becomes more susceptible, or Ang2 acts as an antagonist, which basically leads to destabilization. So it could also be said that basically Ang2 is upregulated when VEGF upregulates, and it's not like Ang2 is upregulated when VEGF is down. So it's probably they both are related. So which brings the question up that whether do we really need to directly go and kill Ang2 directly, or it is just the down regulation of VEGF which is automatically going to decrease Ang2. Now this was not that this was not studied, it was studied, and based on this again an in vitro study where it was seen that with all three molecules, the other molecules which have nothing to do with Ang2 were also able to significantly reduce the Ang2 levels upon therapy. And it was not like the other molecule which has a dual multi-target approach did not study Ang2. There was a trial which was Onyx and Ruby trial which was done by Bayer and Regeneron, where they used a molecule known as nesvacizumab, which basically targets Ang2 much strongly than the Ang2 that we see in faricimab, whereas this trial was basically not carried forward after a certain phase because there was no difference that was seen in the visual outcome. And so then there was this it was basically discontinued because as you see over here, there was no change which was seen between the aflibercept arm and aflibercept along with nesvacizumab, which is a pure Ang2 anti-Ang2 molecule. And this was also again studied in Avenue study, which was basically a study between ranibizumab and faricimab. So which again said that ranibizumab as a single target molecule was potent enough to decrease Ang2 in comparison to faricimab, again questioning the fact that whether Ang2 separately needs to be really brought down or not. So and this was again seen, so even again it was seen that faricimab also decreases the Ang2 level as concurrently to ranibizumab. Coming to the most important trials which was done, and this is one slide which I really want all of you to see, was basically the Tenaya and the Lucerne trial. This was basically a trial which was done in AMD patients, which was between aflibercept and faricimab, and this is not to really bring about any molecule up or down, but what we basically need to see is that in the Tenaya trial, basically what faricimab basically points out is almost 48 or 47% of patients were at a 16 weekly extension period, right, which is basically a 4-month extension, which is, and whereas the others, and in this trial aflibercept was kept at a Q8 interval. Now that is because aflibercept was given as an FDA approval at a Q8, so there's nothing wrong in that. But the point over here to make is that if you see very clearly, which even I have not been able to answer, is that why is it that both these trials were done at the same time during the same year? It was the same protocol, but if you see the Q8 of faricimab in both the in Tenaya and Lucerne, the outcomes are different, whereas even in Q12, the outcomes are different, right? And secondly, if you see at the curve, the Q12 and the Q8 curve of Lucerne especially, of faricimab is very wavy, right? And whereas of aflibercept, it's quite stable. And secondly, the vision differentiation between the two is not much. So definitely, and secondly, Tenaya and Lucerne did not allow a rescue treatment kind of a thing. So maybe, the reality of the data is that if there were some people, some patients who could have been rescued at 16-week interval, or if there was a rescue treatment protocol, maybe they would have been in the Q8 arm only. So, which again kind of questions, where we go with faricimab and aflibercept as a molecule. And I don't think that just going by these two studies saying that probably aflibercept is just a 2-monthly molecule or faricimab is a 4-monthly molecule, which should be the right take-home answer from this. The second thing that I would like to, project after this study is that that if you only compare the Q8 arms again with faricimab was not as great as aflibercept Q8 arm, which again points that if we compare two drugs, side to side, I think probably aflibercept seems to be the better molecule. So I think just to conclude, I think aflibercept with 2 mg molecule is already giving us good results. I think we still need more molecular differentiation and more data based on this. And I think with Tenaya and Lucerne, I think one message that was there was that when with a very, a protocol devised trial, there was no take-home message on why there was a difference between the two arms. I'm 100% sure that we also need to have our own, kind of treat and extend criteria in mind before we start extending based on these trials itself. And as I think Dr. Malika had already pointed out, I think Pulsar trial is already, I think out, and the 82% as they claim is there. So I think we have good days to come with both the medicines in there. Thank you. Yeah. Yeah.
If you see a Q16 arm of Lucerne, that is not showing wavy effect.
Yeah, it's not.
Q12 is showing.
Q12 is showing.
How do you account for this?
So that is what I don't know. So
because you said that you have to see this slide very carefully. That's what we did that.
Yeah.
We saw very carefully.
Yeah. So
if you see Q12 arm is showing wavy, but Q16 is progressive.
The Q16 is definitely progressive.
So what is the answer for this?
No, I really don't know. Probably, but even if you compare Tenaya and Lucerne, they both. Yeah.
So maybe that's a selection bias. The Q16 must be the milder DMEs which are getting the milder AMDs. Which
AMDs.
AMD, sorry.
No, one thing is, see, as far as one is that probably there's an area difference because they both had the similar kind of patients, but probably the area was different because they chose different hospitals. So that could, so either there is some sort of a, difference in. It was a multi-centric trial.
Sir.
I would say that even if it's the area is different, probably being a multi-center will obviously kind of. But even the Q16 arm, if you see of Tenaya and Lucerne, is different. Why should that be?
The only thing is, what I would have said is that the aflibercept was not given chance to be extended.
No, that is. Yes.
But the issue is of this seesaw. I definitely think Q12 is seesaw.
Yeah.
Q16 is actually very good and stable.
Yeah, 16 is quite. No, if you compare the same 16-week to Altair trial, then you will almost get the same thing with 16. So definitely that part that it was not allowed to, this thing was one thing that I put to, so one thing that I put to my mind was that probably there was no retreatment. So criteria allowed, so or a rescue treatment criteria allowed. So whether the 8 and the 12 arm could have been, there would be people who would be going up and down in that, which were not allowed again.
Honestly speaking, they are not comparable.
Yeah, they're not comparable drugs. Yeah.
Sir, actually, if we see that trial, sir, I mean, it was based on disease activity at that point. So basically, the ones which went to 16 week didn't have disease activity at those 2 weeks, at the week 20 or at 24. So they were better cases. But actually, when you have a disease activity at 20, that means 8 weeks is not enough for that. So you shouldn't have continued with 8 weeks. You should have actually brought it down. Similarly, a patient which had a disease activity at 12 weeks, that is 24 weeks, they should have brought down. So you are forcefully treating
Yes,
at an
there was
extended doses where
exactly.
that interval was not holding.
Yeah, it was not holding. That could be, that is what would have caused this seesaw, maybe. Yeah.
With this, I'd like to invite Dr. Rohan Chawla.
Thank you.
Who will be speaking on, I will still use the first anti-VEGF, that is Avastin.
Yeah, I just wanted to reiterate Dr. Gagan Bhatia's point that the Q16 that is shown is already there in Aegis and Altair trials, where you have 40% at Q16, 60% at Q12 plus.
I agree with you, Malika, because those are real-world trials, Altair and Aegis, and this is RCT. So we have Rohan to tell us that he still uses Avastin.
Okay, thank you,
You have to give
sir.
the
Thank you very much for this invitation and this topic. So I have to talk about a drug which seems to be fading away from the memory of, at least from the presenters. Like I saw in the previous presentation, there was no molecular description of Avastin at all. But anyway, so this is a drug which we have been all using, and let me add some points which can prove that old might still be gold, and we might be using it preferably in some situations. So I have no absolute financial disclosures for this. So let us go back in history to understand. So Avastin was first given FDA approval for colorectal cancer, but it was injected by Rosenfield in 2005. At the same time, trials were going on for ranibizumab in AMD, which got approval 1 year later, 2006, where in 2005 it was already established that Avastin is effective. So why make ranibizumab at all? Because it was a problem of the company. The preclinical data of Genentech said that bevacizumab will not be able to penetrate the retina, it is not going to be effective. It was only that Rosenfield's team thought, let us inject and see if it helps. And it helped, and this has been later proven false. So basically, had this not been there, they would not have spent so much money on developing ranibizumab, not spent so much money on calling us for so many conferences and spending so much money in marketing it. We would have been just doing Avastin itself. So you see, bevacizumab is a larger molecule, but it has a larger half-life also. That is a plus point which you are all talking about, Eylea. So that you already have with Avastin. Then we also know that initially we were repeating it also little less frequently, not 4 weekly, maybe even 6 weekly the patients were doing fine. So can we compare the two? Yes, there have been many international studies which have already compared. We know of the CAT trial, which has so many patients, 1,200 patients, and it has shown that bevacizumab is not inferior to ranibizumab. And obviously in any study, monthly dosing is always going to be better than a PRN dosing. There are even the side effect profile, the death rate, if you talk of the systemic absorption and all, and also the same. So they are comparable in the ocular activity as well as the systemic activity. Similar study was conducted in IVAN in UK, which also had about 610 patients, and they also said that there are similar results with ranibizumab and bevacizumab, and continuous treatment definitely gives you a better results, but sometimes it can also lead to geographic atrophy in some of these cases. And not just these two, there have been studies similarly in many other countries showing similar effect, and not just in AMD, we have studies in vascular occlusion, and also the protocol T of Diabetic Retinopathy Research Network did not find a significant difference between the 3 drugs at 1 year in DME. There is also a Cochrane review on treatment of avascular AMD, which also said that the mean change in BCVA from baseline was similar in all 3 drugs, and there is a lot of cost difference between the 3. When we talk of DME, if there is now a recent study, this study in New England Journal has shown some advantage of aflibercept, which says that if the vision is poorer, then maybe yes, 1 year gain, the number of letters gained in 1 year are better with aflibercept, but the number of letters is 7. So if you see the ETDRS chart, that amounts to just 1.5 lines. So there is a, which is statistically significant according to the study, but it is only 7 letters. That is only 1.5 lines. So 1 line I think is almost we say it's negligible gain. So they are saying its p-value is significant. But anyway, so why I still say you use Avastin? Efficacy is proven beyond doubt. Systemic safety is proven beyond doubt. There is no intraocular inflammation with this drug. It is the least expensive drug. At AIIMS we are giving it at 1200 rupees for a single injection, whereas even the biosimilar would be a 7 to 8 times more costly than this drug. Why other people are afraid of using it? Because it is an off-label use. But even if you have a mishap with this drug, it is on how you argue in the court. There are enormous literature favoring this drug, and we also have now AIOS and VRSI guidelines for this use of this drug. So you can save yourself even in that situation. But yes, if you do not have a facility of proper storage, if you do not have a proper facility of making aliquots, if you cannot follow that protocol, if you want to keep that vial for a month and keep reusing it again, then I will say please don't use Avastin, please rather use a biosimilar. If you can use it safely, if you have enough patients, then I would still say please go on using it. But again, to be practical, I will talk of some specific imaging parameters where I say yes, maybe some other drugs might be better. So I say, like I said, if you compare bevacizumab with ranibizumab or its biosimilar, I think there are no significant differences at all. But yes, there might be something different with aflibercept, brolucizumab or faricimab. Let us just touch upon that. So what is little newer special about these newer molecules? Either they are smaller and so they are capable of penetrating much deeper, or we can pack them much more in a single injection. They are smaller in size, or they also inhibit some additional proteins. So does this give us some advantage? Yes, the smaller and better penetration may give us advantage when we want better penetration. So we might want better penetration only in PCV, type 1 CNV or large PEDs, but the same may not hold true for diabetes, which is an inner retinal pathology. So in diabetes, I don't want a very small molecule, even a molecule which stays in the inner retina might suffice. So for more superficial pathologies, I don't think that we need to go in for such larger, the newer molecules. But yes, for type 1 CNPs. Regarding angiopoietin, we already have had a discussion that we need much more real world data to say whether actually inhibition of ANG2 helps or not. So let us be practical. Like I said, for DME, if there are economic constraints, please do not push your patients for these molecules. For severe edema, you can also try the steroids. Even an intravitreal tricot can be added. And like it was said by Dr. Arvinder, that in the first year you require 9 injections for DME. In the second year it reduces to 5 to 6. The same may hold true even for Avastin. So if you are regularly giving 9 injections in the first year, then in the second year, even if that patient has a good systemic control, the injections might just reduce. You don't have to just switch over to a expensive molecule. So I would say for specifically this disease, if the patient cannot afford, please do not push for the newer molecules. For this disease, like I've already discussed, if the patient has a deeper disease, then yes, I would prefer the newer molecules. So it's not just me. But if you go to the Israel public health system, they still do not allow you first line use of other molecules. They would want you to give Avastin, and only switch is permitted if poor response is demonstrated. So availability, and I would just say that once we have a single use Avastin available to us, that again might increase its utility and use by all of us. Thank you. Thank you so much.
Thanks, Rohan. I think most of us shifted from Avastin to ranibizumab was to save ourselves besides saving eyes, right? There is no institutional protection to most of the private practitioners who are down there. And trust me, once you go to the court, you can't reason those fellows who are sitting there.
No, I don't agree with you here. I don't agree with you here.
Because I've been to court in 2 cases and I've seen the way they have argued. So it all depends on the person who's sitting up there. What he wants to listen and what is his, predetermined thoughts about doctors. So I think without wasting further time,
I think RP Center should pressurize courts actually to accept this. In fact, USA there is a study started now, prospective randomized, just to answer this question. They are and within 1 or 2 years you will have single-use Avastin available now. They started only in June, July only.
I think, sir, we are already conducting a trial for ocular use of
Good.
bevacizumab. We have completed phase 1 and most probably will get an exemption from phase 2 because dosing is already established. So we'll soon be starting the phase 3 trials for ocular bevacizumab. They currently in India are being trialed by 2 companies. One is Reliance and another is Genova Pharmaceuticals. So we are doing one of.
So that is specifically for ocular use.
So are they planning to come in a
Yes.
single dose?
Yes.
Single dose
One
vial?
company,
One
in,
company
one,
has
one
started.
company
Yes.
in US is
Yes,
doing
they have
trials
started.
for ocular.
So single dose vial? Or
Single dose.
Single dose.
Ocular single dose.
And what we are doing is that would be a preloaded syringe of ocular dose.
Thank you.
Thank you.
Next. Sir, I have just one question regarding this. So what is
I'll
the house
request-
opinion
just
regarding
second.
nephropathy with
Just
Avastin?
We'll call Dr. Prakhar Goel. You can ask the question. Dr. Prakhar Goel, please come to the dais and
So
will be presenting on my choice of anti-VEGF. Yes.
So nephropathy, definitely there was one study which showed that the nephropathy incidence was higher, but I think again they have not compared it with other anti-VEGFs. Probably if at all it is there, it's just one study, so you are not sure whether it is actually there or not. But if at all it is there, it would be similar to others also.
Because I had 2 cases, so I'm really, I think.
See,
the
diabetes
study
anyway
reported
will develop
almost- that is the
nephropathy.
thing, that you don't know whether it is the diabetes causing it, whether it is the hypertension which is causing it, but the medicine people say no, it is your drug.
No, I would say that
So,
you should not blame
I just
any
wanted
of
to
the
know the opinion of the
anti-VEGFs
house
right now.
about
because
nephropathy.
Known to cause severe nephropathy. I'm forgetting the exact word, the TMA, it's something called like that. But it causes permanent renal dysfunction. So we need to be aware of it, and so we need to
No,
accept
but all the safety studies have shown that these drugs are quite systemically safe, so we do not.
Nephropathy has come up now, more recently. More recently, it has been recognized. It was not recognized earlier. Probably they didn't even look at that angle. No, that's not specific for Avastin. That is specific.
Yeah, that's what I said. It's not specific to one anti-VEGF.
All anti-VEGFs.
Yeah.
You see the interest in GFR or eGFR, a lot of studies now people are asking. Previously we used to have consultation with cardiologists, now say clearance from nephrologist also. And a lot of studies have published, but it's not specific for Avastin. They are true for all anti-VEGFs, all anti-VEGFs.
Sir, just to add one more thing, if we get Avastin approval in a preloaded syringe, I think the cost will also go up. So probably a biosimilar ranibizumab and Avastin will
That's
cost
what
same.
they are saying. Market value will be somewhere between 3.5 to 5,000.
So that is a
for
biosimilar.
doctors. Yeah, biosimilar will cost the same.
So again
So I
points
don't
to
know
the
whether
same
we'll
point.
start
So I
using
think
Avastin
Rohan
or not.
defended his point. Rohan defended his point very well. Believe me, it's not easy to in this hall to speak only for Avastin. So 3 cheers for Rohan. It's not easy. I'm telling you, it's not easy. Plus, believe me, if the reason Avastin is not used is not because of its non-efficacious thing. It's primarily because it's not approved. And this is a company fight. You see, if you go to Italy, Rome, there are court cases against other companies who have not allowed this comparison to happen actually, and they have won. They have won. You are right. They have won. It's as good. Yes.
Was higher with Avastin, sir. It was at 66% vis-a-vis 33% with aflibercept. So when it doesn't work, but then it's weaker than the others.
No, but I think its comparison is more to ranibizumab
The reason why I gave this talk to Rohan was because believe me, in US still preponderance of anti-VEGF usage is still Avastin. So Avastin is not dead.
Okay, thank you. Now Dr. Goel will talk.
Good afternoon, everyone. So first of all, I'd like to thank Dr. Lalit Verma and Sao for giving me this opportunity to speak along with all these eminent speakers, and it's a great feeling, and I hope to put forward my point with this presentation. I'll be speaking on my choice of anti-VEGF. I have no financial interest, and I think all the presentations which have gone till now, it's a mix and match of all these presentations what I'll be doing. I basically work in Narnaul, which is a very small place, a peripheral, very small place where the affordability becomes the biggest issue when I'm advising for an anti-VEGF. So my topic objectives will be to discuss my choice, when to discuss the options in different scenario, and to discuss the issue of affordability or limitations in my practice. So if you have guys missed out on Dr. Gagan Bhatia's presentation, this is just a slide which is summarizing all of this from starting from pagatinib, the first anti-VEGF which acted against VEGF 165A, to the latest Vabysmo, which is now acting against VEGF-A isoforms and Ang2. And also these are the biosimilars which are usually, means I have used these three biosimilars in my practice, and I must tell you all of these work effectively good, and as Dr. Rajiv said, that it is the cost which makes the decision to choose which anti-VEGF. So while choosing an anti-VEGF in my OPD, I see what is the disease under the treatment, the affordability of patient. In this case, being a doctor, I am not the chooser, but the patient is the chooser. Nature of edema, is it acute, chronic, or an intraretinal edema, or if there is a presence of NSD or not, and previous history of any treatment. So first talking about the disease, which is RVO, BRVO and CRVO, we have seen almost all anti-VEGFs work equally in these conditions in naive patient. BRVOs show very good response, CRVO also show equally good response in most of the cases. So my first choice in these cases is Avastin, and if not, if the patient can afford, then I choose for a ranibizumab biosimilar, which is Vizumab, which is based on affordability. If no response, then I directly switch to Orodex. I usually do not advise for aflibercept in my practice because the patient actually runs away if I advise aflibercept. That is a true scenario. So this is just a case where a 56-year-old male presented with ITBRVO. I injected Avastin, and after 3 injections of Avastin, the best corrected visual acuity was 6/9, and patient was maintained, but he developed recurrence after 3 injections. After 3 months of that, I advised the injection again, but the patient was lost to follow-up. Another patient who had a large macular BRVO with large edema, I injected 3 injections of Vizumab. BCVA was attained at 6/9 and 6 months follow-up since the last injection of Vizumab, and the patient is maintained on 6 parts. This is a patient, 63-year-old female with BCVA CF2 meter, CRVO. I injected Avastin. There was minimal response 1 month post Avastin. Then again second dose Avastin was given. After the second dose also there was not much response. Then I tried to counsel patient to give Orodex, but then patient went. They didn't want to take any other further injections. Now talking about diabetic macular edema, which is most common disease in my clinic, and it is actually most difficult to treat because there are very high cases of loss to follow-up. My first choice in this case is any biosimilar, especially I'm using Vizumab these days. Avastin only if the affordability is issue, and if no response, then I switch to Orodex or Eylea. So this is a case in which 59-year-old female, one-eyed patient who had a lot of hard exudates and NPDR, injection Vizumab was given. There was a decrease in the edema, but then there was these hard exudates which had migrated to the center, but still the patient was maintaining a vision of 6/12. At this point I thought I'll do a focal laser. I did a focal laser 1 month, she was fine, and then second month she developed edema again, and I now plan to inject her again. Now coming to this case, this is a case of bilateral moderate NPDR with massive cystic edema. In right eye, I injected Avastin, there was no response, so I switched to Vizumab. After Vizumab also, there was no response, patient was having 6/60 vision. Then finally, I gave Orodex and there was flattening of the retina and the BCVA improved to 6/12. If we talk about the neovascular AMD, my first choice in this case is Eylea or Zeltrap. I have been using Zeltrap also in my practice, which is basically a Ziv aflibercept, is an isomer of aflibercept. Second choice is Vizumab or Eccentrix, and I usually avoid Avastin in cases of PCV because the response is not very good in cases of PCV. Though in other CNVMs, myopic CNVMs or any other CNVMs, the response is good. So this is a patient in which the 63-year-old male BCVA was 4/60. I injected 2 doses of Eccentrix, but there was no much improvement in this case. And then I switched the patient to Eylea, and after 2 doses of Eylea, there was flattening of the fovea, the SRF had gone, and the patient's vision improved to 6/18. This is a case of myopic CNVM. In this, if you can see, patient presented high. Patient was a 17-year-old male pseudophakic with a BCVA of 2/60. There was a subretinal fluid and a subretinal hemorrhage at fovea. I thought that gas can be a problem because the patient was high myopic pseudophakic and there was a staphyloma. So I just injected Vizumab. Post 2 weeks Vizumab, there was reduction in the SRF, but the heme persisted. Post 1 month, there was complete reduction of SRF, but there was some hemorrhage which was seen over here. And
Prakhar, can you finish?
yes, I'll just. And post second injection, there was complete flattening of the fovea and reduction of the fluid. So my practice in nutshell, in RVO, I prefer Avastin or Vizumab. In DME, Vizumab or Avastin. And so on. In ROP, I usually give Avastin. I have not given any biosimilar. And I have no or limited experience with Pegenex and Vabysmo. So take home message from my slide is, in most cases, prefer Indian biosimilars. Avastin in cases of RVO or where affordability is an issue. Eylea is first choice, especially in AMD or where patient wants the best irrespective of the cost. And if no response in DME or RVO, then we should switch to Ozurdex. Thank you. Thank you.
Thank you, Dr. Prakhar. I'd like to thank all the speakers who have traveled across the country from Hyderabad to Bombay to Delhi to come here and present. And on behalf of my co-panelists, I thank you all.
One point,
and
one comment.
Last point, Dr. Malika.
Dr. Goel, you said that you shift to Ozurdex for financial reasons. But actually, if you see the with the Eylea support program, that will be half the cost. Ozurdex's MRP is almost 40,000, whereas Eylea will come to 25,000 with the support program.
So, so the thing is, when I tell that patient about the patient support program for the first injection, he still has to pay 55,000 rupees. But then that first injection becomes the limitation for the patient. They say that, okay, if you give me a 37,000 injection, plus I tell them that may not suffice with one. But with Ozurdex, you will be interval period free for 3 to 4 months. So that suits them better. And with Ozurdex, I know that the edema flattening will be there. That confidence is a little more with Ozurdex. That is why.
Okay. Thanks, Savinder, Rajpal, and Jen. We have the reason I am hurrying up is because Dr. Chaitra is online and she has to leave in 5-10 minutes, and therefore I requested Dr. Mishra and Dr. Vinod to please take the chair, along with Dr. Avneet Gupta also and Dr. Harish. Dr. Chatra, sorry, but I think you can. You're not audible.
Yes, sir. Sir, I'm unmuted, sir.
Yeah, now it's okay.
Okay.
So we have with us Dr. Chatra, who will be speaking about breaking the clinical dilemmas in DME management. Should we treat early and aggressively? Dr. Mishra is already in the chair, and we hurried up primarily to, so that you are in time.
Chatra, welcome, and it's always a treat to hear you. So we're eagerly waiting for your presentation.
Yeah, Dr.
Thank you, sir, and apologize that I had to go in first. I have to be at another event, so I'm really sorry, and I'm
Dr.
grateful
Kunal,
for the
Dr.
opportunity. So today, sir, can I start?
Yeah.
So today I'll be speaking on breaking the clinical dilemmas. Should we treat early and should we treat aggressively? And if yes, why so? So now we already know, I think several of the previous talks have already told us that DR is a leading cause of blindness, and particularly in our country, PDR and DME becomes sight-threatening compared to all the other different stages, and this is what the treatment burden is on our society and our specialty in particular. And we've seen a good, evolution of DME treatment. Pre-1980, we had no treatment options, and then we only were looking at halting the progression. And then we came up with, more and more therapies where we're now looking at optimizing and improving vision for our patients rather than just preserving what they have. Why is it important is because these patients with vision loss and DME can have life-changing consequences, whether it is performing near vision, whether it's difficulty in driving, reading, increased risk of depression has been noted in these patients, difficulty in perceiving colors, and also increased mortality compared to those with normal vision, because most of them have other comorbidities. And you have many of these, elderly patients who are coming into a clinic and saying, "Doctor, I can't read anymore. All I want to do is just read the newspaper, as I used to comfortably 5 years ago." So yes, it has life-changing consequences, and we do need to treat them timely and well. And as much as a 5-letter gain in vision can significantly increase their ability to read, to drive, and also drive under difficult conditions, because most of them, surprisingly, the first thing that they ask is, can I drive? Or can I continue to read? So these have a major impact. So we require a treatment that gives us maximal and sustained visual acuity gains and requires fewer injections in the long term. This is what we need to benefit the system and our patient population. So the first question we're addressing is, should we start early treatment? How important is it? Should we or not? Well, the resounding answer is yes, we should start treatment early. And now let's see, a couple of reasons why. One of the most important reasons is from the very, very early clinical trials and real world experience, we already know that delaying anti-VEGF treatment can lead to irreversible loss of vision or suboptimal, visual acuity. So this was the rise and ride, which already has shown us that delayed ranibizumab treatment can give suboptimal vision gains, and the majority of patients who achieved it only after early treatment with sufficient dosing. Then a 24-month delay in therapy in the sham crossover group resulted in smaller visual acuity gains than that was achieved in the ranibizumab group, and a limited visual acuity improvement with delay in treatment suggests that chronic macular edema results in potential vision being irreversibly lost. So this was what we saw in the rise and ride. These were a few other, the ETDRS study, which shows that without treatment, 24% of eyes with CME and 33% of center involving CSME have a visual loss of more than 15 letters. And the RESOLVE study also showed that during 12-month period, in the absence of treatment, patients lost an average of 1.4 letters. So almost all of the studies do convey this reason that you have to treat them very early, and that is the one that gives us the highest amount of advantage. Also, one of the reasons why early treatment helps is that there is a decreased proportion of patients with persistent edema when we start early treatment. So this was the protocol I, which showed that 9% reduction was observed in proportion of eyes with persistent DME when they got 6 loading doses compared to with week 12 after 3 loading injections. So that is again shows that early treatment is good. This also adds an impetus to the intensive treatment arm. Protocol T also showed that proportion of eyes with persistent DME through week 24 was much higher in the aflibercept in the Avastin group or the bevacizumab group compared to aflibercept or ranibizumab group. Of course, we also want to reduce the treatment burden or the injection required. So treating early has also shown that over long term, or at least from the second or third year onwards, the number of injections required is rather less. So this was the one that showed that with intensive treatment it was associated with reduced burden, and you can see the number of injections actually start coming down from the year 2 onwards. So the reduced burden is an added advantage in a country like ours. Because access to healthcare is rather less. So even though we have to give them early and intensive, maybe in the long run it is for the benefit of the patient. And I think the most important reason is that we have the best or the better visual acuity outcomes when we treat them early. This was the RESTORE and the Protocol I study that showed that highest visual acuity gains was given when the treatment was intensive, especially in the first year. And Protocol T also showed clinically meaningful vision gains when patients received early intensive treatment. So we've seen all of that, and this is another study again that showed that early initiation of treatment led to approximately 76% of patients maintaining visual acuity of more than 69 letters at month 21. So then the last reason is that intensive treatment in year 1 is also associated with disease modification. So this is the diabetic retinopathy severity scale. If you can see, early treatment has led to more than 75% of patients achieving a 2-step improvement with diabetic retinopathy. And Protocol T showed that DME eyes with NPDR at baseline experienced improvement in DRSS scale as well. So we saw now convincingly that early treatment is important, but should we also be aggressive? So the difference between early and aggressive is early is we start, immediately, and aggressive is that whether to give it as a loading dose or whether to space out the injections. Well, should we aggressively also treat these patients? Most of the studies and the real world experience show that we should. What are the reasons here? Real world evidence has shown that pure visual acuity is poor when a smaller number of injections are given, indicating under treatment. So these are the different clinical trials and the real world studies that have shown that visual acuity is much lesser as the number of injections start coming down. And we know that chronic macular edema can lead to irreversible damage and permanent vision loss as well. And this is another study that showed with those patients, gained 4 to 6 fewer BCVA letters over 3 year period when they got lesser number of injections. So these were some of the post-hoc analysis that showed. And deferred treatment also led to poor outcomes compared to the intensive treatment in the first year. So the more frequent the number of injections, it contributed to better anatomical and functional recovery from DME in the first year onwards itself. This was another study that showed that prolonged functional and anatomical outcomes were seen when it was maintained. And in fact, the visual acuity and CST was maintained, the improvement in the second year with fewer number of injections. As you can see, 6 in the first year and 2 in the second year. Again, another real world evidence that shows the importance of intensive treatment. And this is, of course, the 5 year outcomes again, which showed that, up till 5 years, you could actually maintain the visual acuity when you treated well. So now it comes to the important question of whether early and aggressive treatment is adequate, or do we need something more? We already have enough drugs, so should we just treat them early and aggressive? Well, I think the molecule also makes a difference, and we've seen that because despite giving adequate treatment, some eyes just don't respond. Whether it is the molecular pathway or whether it's tachyphylaxis, it's difficult to tell. And in fact, the survey among Indian retina specialists has already shown that 45% of physicians felt the need to reduce the burden also. So not only are we having non-responders, we also are having patients who require more frequent injections. So that brings us, to the question of durability. Do we have a better option, or are we still waiting for more? Well, some evidence from the Kestrel and Crites study with brolucizumab has shown that early intensive treatment with Broly has given us significant improvement in BCVA with reduced injection burden. So I think that becomes a very important option if you're looking at both durability at the same time long-term visual acuity gains. It also showed better outcomes with respect to both fluid and thickness with the reduced injection burden. So I'm just showing you a couple of quick examples here where we've used brolucizumab for our patients. This was definitely early treatment because these are treatment naive cases, and intensive in the sense, at least for the first 4 to 5 injections, we treated these patients at regular intervals of at least 4 to 6 weeks, and after which we've been able to taper off the treatment. Patients in fact don't even come back for follow-up many times because they're doing quite well. So this is a patient who presented with 618 vision, and final check visual acuity was 66. Patient received just 2 Broly injections 6 weeks apart. Here you can see the injections here. This was at first visit. Since we saw improvement at this was visit number 3 or 4th week, we didn't really treat this patient. And then you can see here one more injection was given at 6 weeks and the patient maintained quite well. So we've just given 2 injections to this particular patient. Now, coming to the next patient here, this is a 62-year-old female. Vision at presentation was 660 and at final check was 618. This patient is still at follow-up. You can see this was the kind of edema which sometimes would prompt me to consider a steroid because there's a lot of subretinal fluid, hard exudates as well. But this patient also responded very well to brolucizumab. Patient is still on follow-up with us. And this is another patient. Again, I'm just going to run through the images. Extremely large edemas here, doing extremely well with just couple of injections here. These are the treatment naive patients. Of course, we have a lot of patients whom we have switched and they're also responding well. So I'm just going to go to a quick summary. International guidelines do recommend the support of early intensive treatment because I think that's most important to preserve the visual acuity and to improve on it for a long-term, maintenance of the vision. Early intensive treatment gives good results, and that's what we need in a long term to maintain a proactive extended dosing regimen. Which gives us the best possible, experience for our patients. And all these studies have shown us that this treatment protocol does help in maintaining the best visual acuity for our patients. Thank you so much.
Thank you, Chaitra, for this wonderful talk. We all understand the early and intensive treatment is a must. Any questions from anywhere?
Ma'am, an excellent presentation. What is your choice of drug for a mild DME? You still go with the brolucizumab, and what protocol would you follow with it? You will go for a
mild DME, if the patient, it all depends on mild DME, whether it's center or non-center involving. I'm presuming you're saying center involving and the patient is symptomatic. right? So if the patient is symptomatic and the patient has access to a higher molecule, I would go with that. If the patient cannot afford it or does not have access to healthcare, then I will go with any other anti-VEGF as long as I treat the patient early. It is not necessary that we have to go with the highest only. We have seen, I mean, that's why I put in all the studies there. All the studies have shown that early and intensive treatment works. But what we're looking at is durability. So if there is a drug that can give me longer intervals, fewer injections, and a patient can afford it, then that would be an option.
Thanks, Chitra. You see, we had a very nice discussion in conventional anti-VEGF. Now we are shifting to newer anti-VEGF agents, and this session is being chaired by Brigadier Mishra, and we have Dr. Obli as well as Kunal to help us out. And just to have few words about Brigadier Mishra, because he's an inspiration to a lot of people, because couple of points I've written down here is that there are in army, a lot of people may not know that 62 centers, and he has ensured that all the 62 centers develop to a premier standard. Other thing which I came to know very recently, all these big machines which I thought are available only in RPC, you see in all these centers he has made it available. And 10 apex centers of army he is developing this single-handedly. He has taken this challenge, in fact, and approval also for this advanced center which is coming up. This also I didn't know. Kirti, you knew about this? This approval of five-story state-of-art center coming up in Delhi. No, Sanjay nahi. Question is of 55,000 square meter being built up. It's a huge task, believe me, which will add a lot of value actually. Plus, here is a man who has operated upon so many VIPs and has so many awards to his credit. Very silent worker, and a lot of people don't know about him. Like serving presidents, governors, it takes a lot of guts to operate these people. Plus his teaching skills as well as research. He has so many international publications and a national publication. So I thought he will be the best person to come and help us conduct this. And he has a lot of data on newer anti-VEGF agents, which include Brolucimab also. So I thought he will be the best person to help in chairing this session.
Thank you, sir.
So welcome, Sanjay.
Thank you so much. Thank you, sir.
So can we now have Dr. Bhuvan for the first talk of this session? And he'll be talking about PCV.
A very good evening to all of you. I like to thank Dr. Lalit for this for arranging this meeting and all the chairpersons, and really hats off to sir. Looking at his energy, it's growing day by day. I have recently interacted. Sir is holding so many meetings and is such a good inspiration for the coming generation. So thank you, sir, once again. So I think now we have so many anti-VEGFs in our arsenals, and I think that's good. To each patient we can offer a good treatment, and according to your practice, as we have seen the previous speakers also, somebody wants something which is low cost, somebody wants which has got a longer duration. So now we have got a good so many tools in our arsenals. So I'll be speaking about the management of PCV and my approach. So I'll just discuss few clinical data, some studies, and then how do I apply the use of brolucizumab in my clinical practice, and then probably I can learn from all the experts which are sitting here. So just very briefly, I think all of us know what is a pachychoroid. I'll not go into the details of it. And This is a classification of a polypoidal choroidal vasculopathy. There can be a quiescent one, or it can be active, which is exudative or hemorrhagic, or combined. So ICG is still the gold standard despite presence of Octa. It's very difficult to pick up a polyp. Sometimes you can, but still ICG is the gold standard for the diagnosis of a polyp, in which you can see a hot spot and a surrounding halo. So although OCT gives us a good indication of the presence of a polyp, in which you can see there is a tall peak PEP or a thumb shaped or this notched PED. So there is a very high sensitivity, but the specificity is slightly lower. But still, in most of the cases, we can diagnose this patient as having a PCV on a OCT only. So now coming to the clinical data in the Hawk study, these were the number of patients, Japanese patients, which had PCV. So approximately 59% of the patients in the Japanese eyes, that is the number is 89, had the presence of PCV. So this subset, this analysis I will be showing in the Hawk study. So in these, the baseline characteristics in all the three groups in which they use brolucizumab 3 mg, 6 mg and aflibercept, they are comparable. So when we see the change in the visual acuity at the end of 48 weeks and at 96 weeks, it's almost similar in all the three groups, slightly more superior with brolucizumab 3 mg. But however, with 6 mg, it is more easy to achieve 12 weekly dosing, and hence 6 mg brolucizumab is used. And the drying was also more superior with brolucizumab in the Hawk study. So when we see the absolute reduction in the central macular thickness, as I said, with brolucizumab 3 mg and 6 mg at 48 weeks and 9 weeks, the drying was much more in those patients which are maintained at 12 weekly dosing. So that is why we are using a dose of 6 mg brolucizumab. The proportion of patients presence with any intraretinal fluid or subretinal fluid at 48 weeks and 96 weeks was also much lesser in the group which was treated with brolucizumab 6 mg. So the anatomical results were much more favorable. Similarly, the presence of sub-RP fluid was also much less with the brolucizumab as compared to aflibercept. So the anatomical results, I think now we all have seen, those who have used brolucizumab have seen that the effect is much more earlier, and there is much more superior drying as compared to the other anti-VEGFs. So now coming to a few cases, the main problem with brolucizumab, again, as we all know, is the safety concerns, because there have been few reported cases of occlusive vasculitis, which is a condition which can of course lead to a severe loss of vision, which can even be permanent. So everybody was very scared to use it, and so was I. So this is one patient, one of my first patients in which I used brolucizumab. So this was a patient, although not a very typical PCV, but the patient had got a choroidal neovascular membrane in both the eyes, which could be a PNV. The left eye, in which the center was not involved, was amblyopic, and hence the vision was 2/16 in both the eyes. Now this is the right eye OCT. With the Octa images, you can see there is IRF, SRF, Shrem is there. The left eye, there is a extrafoveal, just a parafoveal CNV with subretinal fluid, some Shrem. So I decided to treat this patient with aflibercept because I was scared to use brolucizumab. And after giving a single injection of Eylea, the vision improved to 6/36. There is a reduction in the intraretinal fluid, subretinal fluid is still there. There is presence of this large PED. I gave a second injection. The PED is still there, there is some SRF is still there, and although the SRF has reduced, the vision is still improved to 6/36. Now since the left eye was amblyopic, I decided to give a Paginax in this patient because I thought that the margin of error is much more. So probably even if something happens, although I explain everything to the patient beforehand before giving a brolucizumab. So this was my first patient which I treated with the Paginax, and in the left eye, after 1 month of giving Paginax, there was complete drying of the fluid and everything disappeared, and the patient's vision improved to 6/36. This is a amblyopic eye, so the vision was less. So again, the vision was equal in both the eyes. So this is the patient himself insisted me to give a Paginax in his other eye. So because the vision was not improving, I gave him a 1 dose of Paginax. Initially the concept of Paginax was giving a loading dose as per protocol and then going to 8 weeks or 12 weeks. So I gave one Paginax, and you can see that the subretinal fluid has for the first time completely dried. There is a reduction in the height of the PED. So after giving a loading dose, I maintained this patient on 12 weekly treat and extend dosing with Paginax. So you can see both the eyes, they have improved significantly. There is no subretinal fluid, intraretinal fluid, and this was my first patient which was treated. So because of the confidence gained, this is another patient. This is a chronic recalcitrant patient. I decided, since the vision is only 3/60, this is another patient I decided to give Paginax because the chances of improvement are very less. and after a single injection of giving brolucizumab, the vision improved to 6/36. Again in this patient, I gave a loading dose at 4 weeks and at 8 weeks. And this is the third injection, and after that I did not inject this patient, and since then the patient is stable, there is no recurrences. So again, with brolucizumab, what I saw initially was the response is very steep. There is a wow effect. The fluid disappears very quickly. There is a reduction in the height of the PED, which I have not seen with any other anti-VEGF, or probably even if it happens over a longer period of duration. So this is 24 weeks from the last injection, and the vision is maintained at 6/18. Now this is another patient. So this patient I have been treating. She has received around 10 ranibizumabs and some Eylea. She's a one-eyed patient on a wheelchair. And this is her picture. She never improved. This is her only functioning eye. She was a patient on a wheelchair, and during COVID, the patient again came to me, and this was a patient again in 2022 in which I injected one brolucizumab, and 4 weeks after giving the brolucizumab, you can see that there is a complete drying of the macula, although there is presence of scarring, but the patient has some good vision. So I gradually had this, the guts to give it in a one-eyed patient, but this patient did not want to come to follow-up, and I thought that this was a suitable patient, although I explained her all the risk, told her the telltale signs when to come and visit me, and this is the improvement. And this patient has passed away, but I think she enjoyed some vision in her final days. So I'm happy for her. So this is another very interesting case. This is a 40 years young female. She presented to me with some strain. So I saw a huge PED. I did OCT. The vision was 6 parts. There is no subretinal fluid, no intraretinal fluid. So I advised her to do nothing. This patient came to me in February 2023. I very nicely remember. After 1 week only, she presented with a distorted vision, and this is her OCT picture after 1 week. So from a complete drying, there is presence of this subretinal fluid, some intraretinal fluid. There is some complex, some wrap-like complex which is also developing at the upper edge of the PED, which could be a CNVM membrane, which I could not pick up on an Octa, and the patient denied ICG. So this patient I offered a brolucizumab, and after explaining all the risk, doing a good examination, doing a peripheral examination, ruling out all signs of inflammation, and after giving a single injection of Pagenax, 2 weeks after the single injection, you can see that there is almost complete flattening of the mount, of the PED mount, and there is some residual SRF. This is after 12 weeks, only a single injection this patient has received, and there is a complete resolution, and this patient is doing fine till now. Her vision has improved to 6/6 parts. So these are some very encouraging results which I have got from brolucizumab. Now this is another patient. He presented with a classical PCV with a huge submacular hemorrhage in the right eye. Now when I did the OCT of the left eye, that also had this double layer splitting sign with a CNV complex and subretinal fluid. So a PCV with a hemorrhage, my first line of treatment is usually brolucizumab, as the vision is already less, and as I said, the margin of error is much more, and even if something goes wrong, he won't have much to lose. So I gave a Pagenax in the right eye, so I'll show both the eyes simultaneously. And after a single injection, you can see that all the fluid has gone away, the hemorrhage has reduced, there's some shrem, the vision has improved to 6/24. I gave a loading dose in this patient, and I maintained at 12 weeks, you can see following the loading dose at 12 weeks, I just went to a PRN, there is no fluid, no intraretinal fluid. So the patient somehow was lost to follow up. He presented at 16 weeks, 4 weeks after that, after the loading dose, and after 4 weeks there was some subretinal fluid developing. So I decided to continue him on a treat and extend 12 weekly regime, and this is his final picture which I achieved with brolucizumab. Now the left eye, since being the better eye, I decided to go with aflibercept. So I treated the left eye with aflibercept because the left eye, this was the picture. After single injection, again complete resolution. After 12 weeks, after the loading dose, there is complete resolution. And as I said, when the patient came to me after 16 weeks, there was a worsening in the right eye. Just to show again. So this was the worsening in the right eye after 16 weeks when the patient, when I extended it. Now I'll just show you the worsening which happened in the left eye. So the left eye has somehow become, in this whole clinical picture, much more worse than the right eye. So again, this was one more patient who asked me himself that you should give me a Pagenax only, because my worst eye, which was the vision was hardly 6/60, went on to 6/9, so I want a Pagenax only. And after giving a Pagenax after 4 weeks, there is complete
drying, the PD height is reduced, the SHREM has reduced, the outer retinal contour has become much better. And again, now this patient is on treat and extend 12 weekly. He's still on 12 weekly because the moment I go beyond 12 to 16, the fluid starts to come again. So as we can see, the right eye has completely dried. The left eye had a recurrence at 16 weeks, but now it's completely stable. There is no intraretinal fluid or subretinal fluid. This is my last case. This is a doctor. He's a doctor. He received ranibizumab. There was no response. I gave him aflibercept. Aflibercept led to drying, but the problem with aflibercept is that after every 6 to 8 weeks, there was this recurrent subretinal fluid and the vision decreasing to 6/9 and 6/12. We didn't have faricimab at that time. Probably I would have also offered that. But this is a patient I after brolucizumab, and after giving a consent, I gave a Pagenax in this patient because he had to receive a Eylea after every 6 weeks. Otherwise, he would present with the subretinal fluid. So after Pagenax, this is his picture, and complete drying. I went straight on to a PRN, which I think we can do with the brolucizumab, and after a single injection Pagenax at 10 weeks, his vision is 6/6. There is no recurrence of fluid. I have followed this patient on a PRN regime. He needed another Pagenax at 12 weeks. So I am following this patient on the Pagenax. So just to conclude about brolucizumab, I think the case selection is very important. You have to rule out any signs of inflammation. You have to tell the patient about the adverse effects. It shows a good response in non-responding patients and patients who are dependent on aflibercept, as I said, who need frequent aflibercept injections at 4 weeks or 6 weeks or 8 weeks. A non-compliant patient, you can give it because you get a longer duration of drying, but you have to counsel the patient about the side effects and when to report. In a large PCV with a large bleed involving the macula, I would prefer to give a brolucizumab. I would rather underplay the side effects because I know that the response is most superior with this, and I have got more margin of error. So even if I offer it as the first line treatment, most of the times the patient denies the use of it because of the concerned risk of occlusive vasculitis, although the risk is less than 0.5%, around 0.2%. Just to conclude, I think anatomical outcomes and dryings are most favorable with brolucizumab as compared to any other anti-VEGF. Informed consent is very important. Patient selection is very important to have maximum visual gains, and I think that our aim is to we should be intolerant to IRF, and we should have the longest treatment interval for any patient. I think that should be the ultimate aim, to have a longer duration of drying and minimal number of injections. So that also reduces the risk of every injection. And with brolucizumab, we have the advantage that even after single injection, you can move on to a PRN regime. Now we don't need a loading dose with brolucizumab. So thank you all for your patience and listening to me.
Dr. Bhuvan, a very great and a very concise talk. And any comments?
Sir, Dr. Bhuvan, I want to know right now, do you use it only for PCV or you use it for other diseases also?
So see, as I said, the use of other, what do you mean by other diseases? I will not use it for a retinal vein occlusion. But if you are talking about neovascular AMD, I think yes, it has got the most superior.
Diabetic macular edema, have you used
diabetic macular edema, I have used it in recalcitrant cases, and it does not have that wow effect that it has with a PCV.
Right. So my experiences are pretty much similar. That I initially was one of the people who are very afraid of the injection. I used it only for people who had multiple Eylea and not responding. But yeah, the response is very good. That now I am using it first line, even in PCV, even in AMD. And touch wood, I don't have any occlusive vasculitis till now. And yeah, I concur with you in the fact that I use it PRN from the beginning. I don't use any loading dose. I think it's a drug which is apt for PRN because of the extended activity of it. But even I have used it for DME patients, and it works even the same amount of time as PCV and NAMD.
You see, our experience at CFS has been, we have had 4 or 5 patients of adverse events also.
Yes, sir.
And out of those 5, 4 recovered completely.
Only one had a loss of
some
vision, sir.
But believe me, out of the 256 injections which, Shweta, how much we analyzed? 256 injections what we have given. We haven't seen wow effect like Bhuvan said with any other drug as with brolucizumab.
Yes, sir.
See, wow effect means absolute flattening with big PEDs flattening. And I agree with Bhuvan that maybe PCV it is becoming the drug of choice. And other very good point which you said, which I have at least 5-6 patient ask for injection. because of the good effect in one eye, they will ask, why not same effect? Or if he is one-eyed, he will keep coming at frequent intervals. That's why मुझे वो वाला injection लगा रहा है. That is the frequent.
Yes, sir.
And based on this only, you see, it has become like a first choice in PCV or symptomatic PEDs, and maybe in pachychoroid also.
Pachychoroid it is the first line.
Yeah, pachychoroid also. Because the molecule is small, it has a propensity to penetrate deeply and affects the disease.
Even in vitrectomized eye, it stays for longer because of the smaller size.
The only issue is that everybody has a fear. Everybody has a
Yes,
fear.
sir.
So I was talking to Malika, who is, who told me that consent is very important.
Yes,
Consent is very important. You talk to the patient, the less he holds you accountable, because there have been reports of vasculitis, but not at 4.6%, maybe at much less
Yes,
percent. In our this thing, the incidence of side effects was around 2% or so. Out of those 2%, if you discount those 4 patients who recovered, rest, it's okay.
Yes, sir.
I would
Lalit sir, I'll tell you about the experience we have. We have a large experience on brolucizumab. We have given more than 2,000 injections till date. So it's a huge load of brolucizumab. In fact, when it was launched, there was a lot of apprehension about this side effect, and almost everybody, including RP Center, were hesitant to use this. We took it up as a challenge. We started a thesis topic, and we were the first one to RCT we did a RCT in AMD cases, and we published in an international journal. So I'm going to present my data also. So 2-3 important things that, as compared to the adverse effect which was reported in Western media, it is not that many, first. Secondly, those adverse effects were manageable, either with oral steroids or PST. Thirdly, one reaction does not guarantee you that you may not get another reaction, or even the next time also you may not have any reaction. The same, we have given same patient 3 more injections after having one reaction. So that means even after one reaction, next reaction may not elicit any further reaction. So this is one thing which we have to keep in mind. But counseling, like Dr. Malika said, it's very, very important, because you're shifting. There is always a fear that the patient may have reaction. Small amount of reaction is fine, but you have to counsel the patient, because the results of brolucizumab is actually, especially in PCV, is phenomenal, remarkable. And we have started giving in RVOs also now. So we are giving RVOs, we are giving DMEs. And we are DME, we are giving straight away as PRN therapy. And we are going to present a RCT on DME in these cases. So definitely it's a drug to watch. If you want to give lesser number of injections, yes, this is the drug. In fact, we have started with faricimab also now. And we'll have a one-on-one data comparison on these 2 drugs.
Somehow, if you see the PED, PED fluid decreases maximum with brolucizumab, but we don't see much of RP rip in this kind of case. What's your experience, and do you have any reason why it doesn't occur?
No, sir. I slightly differ. There have been few cases of RP rip with brolucizumab, because being a smaller size, there are more chances of a rip occurring with it. Rather, I had one patient who developed a rip, but fortunately the vision was not much hampered. But that should not stop your treatment. That is not an indication to stop your treatment. But there is a risk. The larger the PD, with any anti-VEGF, there is a risk of rip. And I think it is either same or slightly more with brolucizumab because of the smaller size.
So one question to Dr. Mishra. Sir, once you've had a side effect with brolucizumab, and if you are injecting it again, why is it that is not happening again?
So, could be probably because of the idiosyncratic reaction. It may not exactly be the reaction. We have not able to understand the reason for this side effect. So we have seen in patients that after 6 weeks we have injected again, no reactions.
So Kunal, there has been some literature which says that a reaction can occur after the first injection, or even after the 5th injection. Initially it was linked to the dose of the drug. Like in Merlion trial, they stopped it because they were giving monthly injections for 6 months, and that led to more incidents. But now there have been cases which are saying that there is
we have given 2 doses. Again, I'll tell you.
Yeah, even after 2 years you can develop it.
Sir, you have to distinguish between the reactions. One is due to biologics, which is kind of a vitritis-like reaction, which can occur with any biologic, whether it's ranibizumab or aflibercept or brolucizumab. The thing what we are worried is an
Occlusive.
occlusive vasculitis. We are not worried.
Exactly.
So you have to distinguish what kind of reaction you have. So if Colonel Mishra has an vitritis kind of a reaction, I think it can be due to some purification process which is.
Sir, I have one question, sir. If anybody has a reaction
we should move on.
Sir, just once more.
We have got a lot of,
If somebody has a reaction with brolucizumab, maybe a vitritis, will he use brolucizumab again? Sir, not you, who is in a private practice, a single practitioner, will he have the...
Because maximum the company people or even the trials they say if the patient has had an adverse event to any of the constituent, you should avoid. So if tomorrow we get caught in a soup that once we have had a reaction and again we are using the same drug, no judge is going to spare us.
So that is
why I asked Dr. Mishra that if we have had a reaction once.
So that is what I am saying.
Because
the message
that is the difference if you are protected.
It is not an occlusive reaction.
The second time will be much worse than the first time. The
So
second
that is
time
why
will be
my
much
point
worse.
was, if we have had a reaction once, one vasculitis, why we are not having it again? I'm particularly asking for that.
Yeah.
Dr. Mishra, I think we should move on.
Yeah.
Because this is a non-ending debate.
Okay.
Believe me, only thing I would like to say till the next speaker is coming, that fear still remains. Fear still remains.
100%.
And we have to be very cautious.
Very cautious. That's very important.
Talk about it. Don't give loading.
We have and we have to follow up these patients.
Yeah. So
Now we have
you
Dr.
may be lucky that patient does not have, but others may not be.
So now we have Dr. Vikram for his talk on the durability with brolucizumab.
Yeah, very good evening to all. Thank you, Dr. Lalit and all the esteemed panel. So I'm delighted to be here. It's not moving. So this is the disclaimer. So this is my first slide. So we all know that we have evolved from a similar ancestry, but still, what separates humans is really is quite thought mind-bending. So if our closest relative, the chimpanzees, have almost 99% DNA as ours, but we don't see them doing such conferences, do we? So what separates them? So is it our brain? Is it the brain, or is it the attitude that we have? So the anthropologists say that it is basically a combination of those two, and there is something called as a ratchet effect. So now what is a ratchet effect? It was a new term for me as well. So a ratchet effect is defined as when one generation does things in a certain way, and the next generation then does that same thing in the same way, except they perhaps add their own modifications and improvements to it. So there is always an improvement with the next generation. The subsequent generation learns the improved version, and which persist across generations until further improvements are made. So to simplify, we used tools earlier days. Then we developed weapons with those tools. Then now we have this modern warfare. Every time our efficacy and our accuracy is increasing. So this is because we never settle. We keep demanding more and we keep pushing boundaries. So the same holds true with the evolution of all anti-VEGFs. So it is not that ranibizumab doesn't work. It is not that aflibercept doesn't work. It is that we want more durability, we want more drying. So that is why we have these newer drugs. So brolucizumab, we all know, is the smallest of all the anti-VEGFs available, and with the 6 milligram dose, the equivalent molar dose is 11 times that of aflibercept and 22 times that of ranibizumab. So we also know the landmark clinical trials in DME and NAMD about chitin crystal, who had fairly good number of patients. So in both of them, they showed robust improvement in central subfoveal thickness. The good point to note here is that the effect started from the first injection itself. So the drying effect was always higher with brolucizumab. So even also if we see the presence of fewer patients with brolucizumab had IRF or SRF at week 32 and week 52, and brolucizumab achieved this with lesser number of injections. So we see there is more durability. So this was for DME. The same holds true for AMD as well. We see that there is the drying effect is persistent, and it starts with the first injection itself, as we all have seen the wow effect of the drug. And it is statistically significant number of patients had lesser fluid. So this data suggests that brolucizumab achieves better fluid reduction than aflibercept, resulting in better visual outcomes, and brolucizumab achieved better fluid control with lesser number of injections. So we know that brolucizumab is potent and durable. So now, but in the context of our real life, so does this data translate into real world experience? So that is the thing, where we don't have similar follow-ups, we don't have similar protocols. So now we analyzed our 94 eyes of wet AMD who completed minimum 52 weeks follow-up from first brolucizumab injection. Among these eyes, 24 were treatment naive, while 70 were switch patients, and a total of 36 eyes completed actually a 2-year follow-up from the first injection. So our results, the mean follow-up after the first brolucizumab injection was 87 weeks. There is almost 1.5 years. So we had a lot of good data here. The treatment naive group received a mean of 3.8 injections, and the range was 1 to 6. Although there were only 24 patients in this group in the first year itself, and a mean of 2.3 injection in the second year. The switch patients who we were treating it with for quite many years received mean number of injection. The mean number of injection required was 3.2, and range here of course was 2 to 5 in the first year. Among switch therapy group, the injection interval was significantly longer after the switch, with a mean difference of 4.2 weeks from the previous anti-VEGF injection. So earlier, if the patient was on 8 weekly, we could extend it to 12 week or 14 week. If it was 12 week, we could extend it to 16 week with brolucizumab. So conclusion that brolucizumab increases the previous treatment interval by more than a month on average in recalcitrant cases and reduces the number of injections in treatment naive group in both the first and second year, hence increasing the treatment interval and reducing the treatment burden. So this is just a similar case. This is the treatment naive patient. She is a 70-year-old female who presented with diminution of vision since 15 days, had good vision. The only thing is that she is one-eyed and they don't stay, she comes from out of station. And we gave injection brolucizumab on 24th of April. So just after one injection, we have this beautiful OCT that the fluid has gone, PED is almost settled. Now the treatment here is in the real world, patient don't follow up, and the patient comes back after a year with diminution of vision since 1 week. Now since she's one-eyed, so we rely more on her that she will be very accurate about since when she's having the complaint. So now this time again we see the PED is height is there, SRF is there. We again give the second injection, and within after a month she's well. This time we counsel her hard that you need to have more frequent follow-ups. It's very important to have frequent follow-ups, and we have then, and we see that she comes in May, then in July, but in November again she starts to have some activity. So we gave a third injection in November 23. So again on 28th of November, then we see on January she's doing well, and now she comes back. After almost about 7 months, she again has a recurrence. So she received a fourth dose. So we gave a total of 4 injections in 26 months. So that is really very durable. And the second case, again, a treatment naive patient who comes with this large PED, mostly a PCV with SRF, and we see the wow effect just after the first injection. But again, after second month, patient again gets back the disease. Now we again re-inject the drug. Even after 3 months, the patient is doing well. Then again, and after 4th month, we again see the activity is coming, and we gave him third injection after 4 months. So this time, after the first injection, after the second injection, we could extend the period to 16 weeks. And after the next injection, he comes in after first, we can see a very good response. But now again, he started to show some activity, so we injected him again. Although there was no SRF, but the PED highs, it definitely increased. So there is activity. And we can see a beautiful response. So in total, this patient received 4 injections in 14 months. So the response is really is good and is variable from patient to patient. So this is another recalcitrant AMD. So he's a 47-year-old male who has a PCV. We can see a large polyp, serosanguinous PED. FFA doesn't give much information. Even ICG don't show a definite polyp there. But of course, the OCT confirms that it's mostly a PCV. So we went ahead with Eylea, the aflibercept. At that point of time, he received the first dose. After the first dose itself, we see there is some resolution. Second dose, there is still, it looks more or less same. Third dose, it still looks more or less same. It received the 4th dose itself, but now the patient, we could not explain this to the patient that even after the 4 injections, the disease activity is going up. So we had to switch the patient to brolucizumab, and once we gave brolucizumab, this is just 1 month after brolucizumab with such great drying effect. So the patient then again came back almost about a year, 10 months later with some activity, and again we gave him another injection, and just post injection is doing well. I actually called him again. I called him up before coming here, so he still not have any injection anywhere. So that is a very good response. So to conclude, I would say brolucizumab has the best drying effect of all anti-VEGF, probably because of its high molar dose. The effect is persistent and increases the durability of the drug. It reduces the number of injections in treatment naive patients. So more reason that why we should not offer them the best. Although there is a concern of of safety factor is there, but if the patient has understood those issues, then this should be the first line drug, and increases the treatment interval recalcitrant cases by more than 4 weeks on average. Thank you.
Sir, Dr. Raja will be here online or?
Yeah, I'm online.
Hi, Raja.
Dr. Vikram, that was an excellent ratio effect that you showed us.
Welcome, Raja. Waiting for you.
Hello, sir.
So, do you have any comments, quick comments from Dr. Mishra sir or Dr. Abninder?
So we'll have comments together only because
We'll have it later. I think we'll let the presentation be finished.
So can we now have Dr. Raja from to present his talk?
So Raja, everybody knows from LV Prasad, he will tell us about how to break the barriers in management of NAMD. Yes, Raja.
Yeah, I hope you can see my slides. I think a lot has been spoken about brolucizumab. Some of the information probably will be a repeat, but I have tried to add some cases from my experience. And I will slightly deviate from just brolucizumab, but to an understanding of ARMD and CNVM. So CNVM is a sign, it's not a disease by itself, it's like cough or fever. As of today, we are treating, when we treat with anti-VEGF, we are treating that cough or fever. We are not treating the basic pathology of the disease. That's why we have to keep on injecting and injecting and injecting, and the disease keeps coming back, or unless the disease runs out its own course. So CNVM can be a manifestation of various diseases as is shown in this photograph. But we also need to understand that what kind of CNVMs are seen in which kind of disease, and what is the likely duration of the disease, or how rapidly the disease can progress if the CNVM is associated with a particular kind of disease. So type 1 CNVMs are under the RPE, and if you do an FA, since fluorescein is not good for imaging behind the RPE, RPE is like a curtain, so type 1 under the RPE will be seen as occult CNVM. So FA is not able to detect them easily, whereas type 2 CNVM is above the RPE, that is just under the retina. Or when we do an FA, it's easily visible because RP is not blocking the fluorescein in case of type 2 CNVM. This is called as classic. And type 3 is intraretinal, which is also called type 3 MNV or RAP. Now, the diseases which cause type 1 or type 2 CNVM are listed here in general. So AMD, PCV and CSR cause more or less occult CNVMs. There can be some classic component in ARMD, but PCV and CSR typically cause type 1, a pure type 1 kind of lesion. And classic type 2 lesions are seen in all other conditions such as myopia, inflammation, injured streak and everything else. But why we need this information? It's important to understand and communicate with the patient that type 1 CNVMs progress slow and respond slowly to treatment, such as ARMD or CSR or PCV. Patients, if you ask them, they will say, doctor, I have been having vision loss, I don't know since when, maybe 4 months, maybe 6 months. And when you inject them, the response will be slow, like AMD, CSR, CNVMs, you keep injecting, you don't see in one injection that will go away compared to a myopic or inflammatory CNVM. So type 2 CNVM such as myopic and inflammatory CNVM, they progress fast. The history will be of a few weeks. The patient will tell, doctor, I was okay till about 2 weeks ago. And when you inject, let's say, MacTel CNVM, they resolve rapidly as well. So this information is very important for us to understand. The other information I just wanted to share with everyone is we use a lot of OCT angiography. But OCT angiography is a highly individualized investigation. You can't just rely on the printouts from the machines. You have to be with the machine. Here there is a subretinal hyperreflective lesion on the OCT-B scan, but if you switch on the angio flow signal, there won't be any angio flow signal from that particular lesion, and everything that is subretinal should not be considered as a CNVM, and that's why everything that is subretinal should not be injected. As you see now, the angio flow signal has been switched on. There is no red spots within that hyperreflective material. It could be CSR as well. Coming back to ARMD, what has been the most unmet need? VRSI, ASRS, we have all done surveys, is the reduced treatment burden which everyone has been clamoring for. And now fortunately we have numerous injections available compared to what we had earlier, including the latest one of faricimab. Brolucizumab is a very small molecule, and that's why it can penetrate the RPE much more than ranibizumab or even aflibercept, and it can have a significant drying effect in cases of choroidal diseases compared to retinal diseases. So if you have retinal disease like DME, you might not have much of a wow effect with brolucizumab, but with ARMDs and PEDs, you will see a wow effect with brolucizumab compared to other anti-VEGF agents. This graph has been shown multiple number of times. I am not going to go much into the detail. It just shows that there was no difference between brolucizumab and aflibercept. But I have one point to convey here, that when you look at any of these trials, ARMD, DME, RVO, you will see that there is a takeoff or a lift-off phase as you would have in an aircraft, and then the aircraft reaches a cruising altitude. The takeoff phase or the lift-off phase is reasonably quite similar for all diseases, for all drugs, for all protocols. Then the first 3 months or so, the plane actually takes off or the drug takes off, and by the 4th month it reaches a cruising altitude. But the cruising altitude varies. It depends on the disease, it depends on the drug, it depends on the protocol that we use. So typically for ARMD, the height, that is the gain in vision, is just about 5 to 6 letters. That is just one line. If a patient has 624, when he comes to you with ARMD, you give an injection, they are likely to improve only up to 618. You don't have to promise 6 by 6 or 6 by 9 or 6 by 12 to the patient. Whereas if it's DME or RVO, the takeoff is the same, but the cruising altitude is much higher, which means the gain in vision is 3 to 4 lines. If a patient with 6 by 18 vision comes to you with just DME, no other drill, no ellipsoid zone loss, no optic atrophy, you give that patient aflibercept, that patient is going to improve 4 lines. You can communicate with the patient that with aflibercept, if you are 618 today, you can achieve 6.9 or 6.6 vision. In Hawk and Harrier, brolucizumab had much more drying effect compared to aflibercept, and more than the difference was more than 30% in terms of the drying effect. And this drying effect is not just for intraretinal or subretinal fluid, but also for sub-RPE fluid, which we call as PED, pigment epithelial detachment, which is the serous type. Brolucizumab has a much better drying effect. And also patients could be maintained at 3 monthly dosing interval, a majority of them. In these patients, it included AMD as well as PCV. A few examples that I would show now. My first patient, 5th October 2020. So brolucizumab was launched probably on 3rd October in India. And this patient was 90 years old, just out of the unlock phase after the lockdown due to COVID, had CNVM at 20/80 vision, and after one injection, improved to 20/80 drying. We followed only a PRN protocol in this patient. The fluid came back again in a month, vision dropped, then again after an injection 21/25, and he came for a few months after that but did not come for follow-up after that. But what has been seen in PCV patients, while Hawk and Harrier have shown some light on PCV, but they did not do ICG angiography to see regression of polyp after brolucizumab injection. We published this report wherein we showed that after brolucizumab injection the polyp does regress, but it takes time. This patient took more than 9 months for the complete regression of polyp. Another long duration patient, this patient first presented to us in 2007, more than 15 years ago. He had vision of 20/60 in the right eye, and he had a very small CNVM. There was a doubt of a RAP lesion. He underwent PDT, photodynamic therapy, and you can see time domain OCT status. Some of the senior people here would recognize this. PDT plus Avastin. He had repeat PDT plus Avastin again after 6 months when the fluid recurred. He was quite stable for about 4 years. And then in 2013, this patient started developing more aggressive lesion, intraretinal fluid, subretinal fluid, and we switched to Lucentis at this point of time, which was the standard of care at that time. He was still having some amount of fluid, but he received 5 Avastin, 10 Zaltrap after that because of cost reasons. And in 2022, even during COVID, he used to come occasionally for some injections. But this was the time when we gave him brolucizumab the first time, and he never was fluid free in these last 6-7 years. After brolucizumab, I was expecting a lot of improvement. I was surprised that there was not much improvement. He gave eccentrics, ranibizumab plus Ozurdex, which I have used in such cases with very high intraretinal fluid and PED. That also did not have much of an effect. And this is when we gave 5 brolucizumab injections to this patient starting March last year, and that's when it dried up. Patient still had very poor vision, had cataract. We did cataract surgery, and this was last month. The first time ever he has crossed 2250 or 6/60 vision. He has received approximately overall 40 injections, but now he has been injection free for the last 4 months or more. And I have one last case that I am showing here, a PED with intraretinal fluid, serous PED in the pachychoroid disease, which was discussed earlier, a chronic CSR patient, and 1 injection PED and fluid is flattened. It is so unbelievable in these patients that we really have to think whenever we present these cases, is this the same patient are you presenting, and what's the question which is asked in conferences. Regarding inflammation, one of my first patients, the mother of a retina specialist, developed severe vitritis with hypopyon on the night of the injection. So this is not the second or third injection, which is typical for brolucizumab. This is not 40 days, which is the average after the injection. This is 1 day first injection. Patient developed severe hypopyon, vitritis, no lid edema, not severe congestion, no pain or discharge. But she had received 30 anti-VEGFs prior to this, and this was one option we had to consider. And 5 days we did put her on intensive topical steroids and had to do vitrectomy. We cannot rule out endophthalmitis in such a patient. But in 5 days the fundus cleared like anything, never had any inflammation kind of feeling. And in 5 days you see the OCT. The OCT above is before the injection. The OCT below is 5 days after the injection. Fluid is gone. But this patient had recurrence of fluid, came back again. We didn't want to give brolucizumab. We re-injected Eylea at least 4 times combined with Ozurdex, but she had to come back to Paginax or brolucizumab. She is on brolucizumab now again with no inflammation. So in summary, brolucizumab is non-inferior to aflibercept, but it also has significantly better outcomes in AMD and pachychoroid disease with durable efficacy. But safety should be considered and discussed with patients. Thank you very much for your kind attention.
Raja, what do you tell to a patient who is about to receive brolucizumab?
Earlier I used to have a special consent form as well, but now it's not a special consent form. It's the same consent form. I tell them there is a small risk of inflammation. In Indian eyes, we haven't faced that many as compared to the West, but we have used in more than 1500 eyes in our institute, and we have had 2 cases of vitritis. So this is the information I give them. Typically they don't have any problem at this stage. When someone is starting to use brolucizumab, they have to discuss more, but documenting and talking to the patient is very important.
Raja, one hypothesis, what you said, it has a smaller molecule. so it can penetrate through the retina into the choroid. Now, if we have a vascular disease like diabetic macular edema or a branch vein or a vascular occlusion, then already the pericytes are weak in these kind of diseases. So this smaller molecule can penetrate through the vessel into the lumen of the vessel, and we know that if it penetrates intraluminally, then it can create an thrombosis like reaction. We know all anti-VEGF can cause thrombosis. So might not be this is the reason why we see more of vascular occlusive vasculitis in patients with brolucizumab, and we should resist ourselves giving this medication where we find lot of leakage in fluorescein angiography or in central retinal vein occlusions. What's your take on this?
Yeah, that's a very nice question. I'm not sure about it because the Hawk and Harrier and other studies have looked at AMD patients and reported the intraocular inflammation. I think Dr. Garwag has published, who is online today with us, has published a meta-analysis on intraocular inflammation after brolucizumab last year. He would probably have a much better insight into it, but that's a good hypothesis.
I think AG, you are theoretically right. Theoretically, you have a right hypothesis that in such patients maybe it may not be the preferred kind of drug.
So I had a question.
But although Mishra, he says he has started using in RVOs. Yes, sir.
Yeah. So I had a question. So basically, through the talks, I've realized that we all are following different protocols. Like some are following treat and extend, and some are following PRN. So two very specific questions. One is that if a person on brolucizumab is, let's say, on a treat and extend for 3 monthly treat and extend, and you see there is some sort of a worsening after a few injections of the disease process, how do you go back? Do you go back to only 2 monthly, or you switch the drug? That is one, because the minimum treatment criteria for brolucizumab is roughly 3 months. So let's say you're given 2-3 on treat and extend, and a person has a rebound with AMD, has a tiny bleed coming back or a CME coming back. Then do you go back to 2 monthly, or you switch the drug? That is one. The second thing is that with the vast experience everybody has, that if somebody has been giving bilateral Pagenex, then what is the time interval that you put between the two eyes, considering the fact that there is some risk of inflammation? So
regarding treat and extend, I'm not sure if there is any evidence so far for treat and extend with brolucizumab. I'm not sure if you are talking about monitor and extend, which is what most of the practitioners in India do. It's not treat and extend which most of us follow. I do follow treat and extend, but most of the practitioners do not give an injection when there is no fluid, which is not treat and extend. But if you have a patient on treat and extend, and if the fluid comes back, you certainly can come back in aflibercept. If you are at 3 months and the fluid comes back, you can come back by 2 weeks and then re-inject the patient. I don't know if with brolucizumab you may come down to 2 months instead of 3 months if you are following a monitor and extend protocol. The maximum that I have given a patient is of brolucizumab is 14 injections so far, and he has been receiving once in 3 months. In terms of bilateral brolucizumab, I don't think I'll have to search really hard. I don't think I have a patient right now who is on bilateral brolucizumab.
Raja, I have one patient I am injecting at 5 weeks interval, and I have given somewhere around 24 brolucizumab to that patient, and he only comes and demands that I want another injection. He is the only eye patient, although it's very fiery sometimes whether I should give at 5 weeks, but patients was already given aflibercept, rebound occurred at 3 weeks, then with brolucizumab it's occurring at 5 weeks, and now I have extended till 8 weeks. He is doing fine. I'll ask Dr. Justus Garwag from Switzerland. He is also here online, and we'll continue the discussion after his talk. He will be speaking on brolucizumab, a game changer in treatment of NAMD and diabetic macular edema. Dr. Justin, please.
Welcome, Dr. Garwag. you know, we are late by some time, but nevertheless, everybody in the hall is waiting to hear your views about this game changer in the treatment of NAMD and DME.
I thank you for the invitations. I'm very proud to be allowed to present my personal experience, which draws to already 8 years with brolucizumab. Maybe to your discussion, I think the most important issue in Harrier and Hawk compared to Kite and Kestrel is that there was a 4-week loading in Harrier and Hawk, but only 6-week loading in Kite and Kestrel. And the number of severe intraocular inflammation was tended to be clearly lower in Kite and Kestrel. And this is why Novartis decided that a 4-week loading is not necessary anymore. And also you should not go below 6 weeks of injection intervals, whatever your patient needs. You could combine with other anti-VEGFs or with corticosteroids, but you do not extend to go out to closer than 6 weeks. Just to mention, in Switzerland, all treatment is covered by insurance companies. That's one to your country. Another difference to your country is that brolucizumab has been approved quite several years ago, but only as a second-line treatment because of the side effects. So this is why I namely will present difficult-to-treat cases, but these are definitely the more challenging personal experience. And I have to come back to the earlier discussion with the wow effect. The wow effect in AMD is an anatomical one. The wow effect in DME, in my hand, is that if you treat a patient systematically, then in the long term, you may stop treatment for many years. 3 or 4 patients that I have treated with DME systematically, they were able to stop treatment for 3.5 or more years meanwhile, which means they had 2 years of treatment and nothing thereafter for many years. And this is the lucky side of that. My disclosure and the disclaimer, just to mention, generally speaking, and this adds to the discussion before, 60 to 80% of eyes primarily do respond very well and achieve complete dryness within the first 6 to 12 months, independent of the anti-VEGF drugs in use. If you have a patient or an eye that is not completely dry after 6 to 12 weeks, that would be an argument to switch treatment if the patient follows treatment. The difference between the approved drugs that have already been discussed is the time to dryness, where brolucizumab seems to be very potent. The portion of eyes achieving complete dryness, as Harrier and Hawk showed, that was stronger in brolucizumab compared to aflibercept, and the number of injections over time and the adherence to treatment. This is very important. Our patients on brolucizumab are very happy because they have a minimal treatment burden and they have a very reliable treatment. The portion of eyes insufficiently responding to treatment with persistent intraretinal fluid differs remarkably between drugs. It may be up to 50% in Avastin treated eyes that do not completely dry off. It may be 40% in ranibizumab. It's something like 25 to 30% on aflibercept, and it goes down to 15% for brolucizumab in my personal experience. With that, I want to share such a difficult to treat case. A lady of 75 years, beyond her hypertension, pretty active and healthy. She reported a vision loss to 0.3, which was very significant for her within 5 weeks. She had a huge pathological subretinal complex, which was not well delineated because it was blocked by the hemorrhagic PED. That may well have been a PCV lesion. We do not do routinely ICG angiographies. She wished explicitly to be treated with brolucizumab because she is a very active lady and had not much time for her eye disease. She received 1 injection, came back after 5 years, had a significant vision improvement of 12 letters, which is is 2 lines after only 1 single injection. She received a second injection, was extended to 6 weeks, a third injection extended to 10 weeks, and she had a total of 9 injections over 2.5 years. And one remarkable about the duration of effect of brolucizumab is that she's not the only patient that is kept absolutely stable on 24-week intervals. And this is what is interesting for the patient. They do not need to come in between if they have brolucizumab in 24-week intervals. So that's a case with 2 annual injection, and he had a vision gain of 18 letters or 4 lines in total. Here you see the anatomy. You see the left eye with a confluent drusen, the right eye with its hemorrhagic pigment epithelial detachment, which does not look very fancy. And if you see the OCT, you would not expect her to respond so well. And the bottom line, you see the drusenoid changes on the left side. Here the angiographic frame, early and late frame, you see a diffuse dye leakage and a very extensive lesion covering almost the total posterior pole. Here you see the response before on the right side after 1, the second and the third injection. So this is amazing anatomic response, which you already expect after the multiple experience that you have from today's speakers. So this is a very good response, and she had 18 letters of visual gain. In the long term, she gained to 0.8 visual acuity, and that was remained within 24-week intervals, as you can see at the bottom now, over meanwhile 3.5 years. A second case to show that this is not a unique case. A second case is a pre-treated case with a chronically active type 2 macular lesion or mixed macular lesion that was not well responsive to other anti-VEGF drugs. He had aflibercept given in 5 weekly intervals and was already 5 years into treatment, or 4.5 years into treatment. The treatment was switched from ranibizumab to aflibercept, and from aflibercept then to ranibizumab. If you see the baseline situation, that looks rather harmless. The OCT is on the upper line. It shows the baseline situation in 2016, and the bottom situation is 4 weeks after the last aflibercept injection. This is not a happy situation. 4 weeks after aflibercept, in that situation we decided for brolucizumab, and this is what you can see. The response only after 1 week is an almost complete drying off of the retinal fluid. More importantly is that we were able to extend it from 4 weeks under aflibercept to 8 weeks, and had, despite that, a significant improvement in the anatomic responses. She's currently under 10-week intervals, and she had a total of 9 injections. She insists on staying on brolucizumab. Maybe to add a comment to brolucizumab, the risky period for brolucizumab intraocular inflammation is within the very first 6 months. If a patient has come beyond the 6 months juncture, you must not expect severe IOI, which means if you have a patient that needs bilateral injection, you could do that well if the patient is more than 6 months into treatment. 80% of the patients from Harrier and Hawk had their intraocular inflammation presented in the first 6 months into treatment. So we have to decide which is the higher value for the patient. Is it efficacy, because we have an early, intensive, but also long-lasting efficacy, and we have the safety thing. We have to discuss safety, but if you want to screw down safety, the very first is you do not start with 4 weekly, but with 6 weekly loading injections. Here another case, a newly diagnosed type 1 macular lesion, again a hemorrhagic lesion, a huge lesion, and you would not expect a good response. You would rather expect a high number of injections needed to control disease activity. In this case, this is the baseline situation, the angiography on the left side, the OCT on the right side, and a significant retinal thickness after a single injection. Visual acuity improved significant by 2 lines, and CRT was reduced by more than 50%, and namely the pigment epithelial detachment was massively down already 1 single week after the first injection. Despite what you can see here, she had epiretinal membrane and some sort of vitreomacular traction. So this is an excellent response, and she was extended to 12 weeks. the right panel shows the anatomic situation in the OCT 3 months after the 5th injection. At that point, this lady decided to stop treatment, and she had treatment cessation then, which is almost 2 years ago, and she remained stable since then. So she had only 5 to 6 injections and never needed any injection thereafter. That these are not single cases shows this graph. As you can see, if you look at the treatment naive cases, we reach an average of 16-week intervals if we continuously treat under a treat and extend protocol. And in the switcher cases, this negative selection, where we had an average of 5-week injection density, they were able to extend to 8 weeks under brolucizumab. To summarize, we have 35 patients, the majority of them difficult to treat cases, and 5 cases with a negative baseline situation. All but namely the treatment naive cases showed an early and sustained response in 76%, which means 3/4 of the cases, despite the expanded treatment interval, a complete fluid resolution was achieved. 4 cases had intraocular inflammation, and we had to learn to handle with that. In the first 2 or 3 years of brolucizumab, in the context of the Harry and Hawk study, we had no experience with the intraocular inflammation, and these eyes had severe vision loss. But once we learned how to handle these cases and introduced early and aggressive corticosteroid treatment, and for sure informed consent to make sure the patients come early back, we do not have we have not seen any severe vision loss. And this is, as already mentioned, been summarized in a meta-analysis that has very recently been published. A meta-analysis of all the case reports that have been published on brolucizumab. You can see the early cases regularly lost, and nowadays where the patients are informed and we know how to handle the cases, we have no vision loss. In contrast, we do have a visual gain despite severe intraocular inflammation if we handle the patients and the inflammation correctly. This explains why the patient satisfaction, namely in switches, is very high. With that, I switch not the treatment in DME, but from AMD to DME. I will show you a case that has already been 5 years into treatment with brolucizumab. The case was of the first cases in the KITE study. He was 67 years old, had a well-controlled diabetes with a HbA1c of 10, a very sportly, active man, did not smoke, had a well-controlled blood pressure. This patient came with a moderate diabetic retinopathy in both eyes and a vision loss in his left eye. He was randomized to brolucizumab, a loading injection phase, as I mentioned already, with 5 loading injections, not in 4 but in 6 weeks intervals, which is meanwhile also recommended for AMD, not 5 but 3 loading injections if you want to have full disease control. He was randomized to Q12 treatment. And if you see the angiographic frames, you see significant changes in the angiography, multiple aneurysms. On the right side, you see there's a capillary dropout and a macroaneurysm close to the foveal center. The OCT does not look too dramatic, but the large fluid spaces indicate the edema is probably quite long-standing. He responded very well. As you can see, only 6 weeks after the very first injection, the fluid had completely dried off. Per protocol, he was followed up with treatment through the loading phase, and then 12 weekly thereafter over 2 years with excellent anatomical and functional outcome. They had a full visual recovery and was very happy. What happened at the end of the study? We had no access to brolucizumab, so the patient was completely dry after 12 weeks after the injection. As you can see in the upper left OCT, we said, okay, let's see how the situation looks 4 weeks later, and then we had significant fluid in the retina. At this point, we had no access to brolucizumab, so the patient was treated with aflibercept and never had a good response needed aflibercept in 4 weekly intervals and decided to switch to faricimab, as you can see at the bottom line, and also faricimab did not completely dry off the lesion and did not stabilize visual acuity. And meanwhile, we have come back to brolucizumab, which has been approved in Switzerland, and he's currently under 8 to 10 week intervals. Again, this is not an only case, as this example shows, a case with significant retinal fluid, as the thickness map shown left side. Here the visual of 5 injections. Thereafter Q12 treatment completely dried off and had a visual recovery to 80 letters and a normal retinal thickness. With a total of 10 injections over 2 years. So 13 letters and a complete resolution of fluid is not the single case, but the average case. The question is, does every case make it directly after the loading phase to 12 weeks? And this must not be the case. As you can see here, a case with a significant amount of intraretinal fluid coming from extra foveal approaching the foveal center, a significant vision loss to 37 letters, which is something like 0.16 visual acuity. He was treated per protocol and completely dried off. He had an amazing visual gain of 55 letters over 2 years with only 10 injections. And in this case, remarkable, this case was treated per protocol in year 2, and he made still a 10 letter gain in the second year under continuous treatment, though the fluid was away, which means if you continue your treatment, you may even achieve additional visual gains in the second year. A side effect of treatment is also that the diabetic retinopathy severity improves, as you can see in this 7th case. The fluorescein angiography in the upper side shows a pretty much severe ischemic maculopathy, and the OCT, which you can see on the left side, is not very fancy. It shows a huge amount of retinal fluid, but also a serious retinal detachment. The retina is almost 1 millimeter thick. For that, visual acuity of 0.4 is rather surprising. Again, this patient responded extremely well to the protocol, had a gain of 24 letters and a normalization of retinal thickness. But in this case, to mention, is also a 3-step improvement of the diabetic retinopathy severity over 2 years, as you can see in the angiographic frames on the right side. Moreover, the thickness map shows that after 2 years there is extra foveal fluid present. So if you would stop this case after 2 years with treatment, you would be sure there would rapidly be an increase in the fluid, which again would approach the foveal center. So if you look at your cases, do not only look at the foveal OCT frames, but look at the thickness map. If you have a thickness map, as you can see in this case, you may likely expect that the fluid is rapidly improving compared to the cases I have shown before. So this case had an amazing visual gain of 5 lines, which is very important, and more importantly, the stabilization of the diabetic retinopathy to grant long-term outcomes. But the price is brolucizumab-associated intraocular inflammation, and the time gap of intraocular inflammation is typically between 7 and 56 days, as reported from Harry and Hawk trials. You do not need therefore regular post-injection controls because you don't know when such event would occur. You have to inform your patient, and this is very important, the education of your patient, that if they have any symptoms, they immediately come back. Re-injection intervals should be minimally 6 weeks in the short, but also in the long term, which is also has already found entrance in into the posology of brolucizumab. I show you a case with severe intraocular inflammation. In this case, 84 years old patient with a significant health burden with myocardial infarction, stroke, coronary artery disease, aortic valve replacement, renal insufficiency, and hemodialysis. He came with vision loss on his left eye to age 20. In the right eye, he had a macular scar with no relevant visual function remaining. So it's an only eye. He had progressive intraretinal fluid despite 4 weekly injections of aflibercept. These are the typical cases that are very, very happy if you switch to brolucizumab. You see the significant amount of retinal fluid on the OCT at the bottom. How did it evolve? 4 weeks after the first injection, he had an amazing anatomic response, and he was very, very happy because he said, "Listen, I couldn't read for years without reading, without magnifying glasses, and now I can read again with my reading glasses. I'm very happy." And he received a second injection because he had already 10 letters of vision gain, and we hope to gain further. But unluckily, as you see at the bottom line, he developed intraocular inflammation, and the OCT that you see at the bottom line is very, very typical for brolucizumab-associated intraocular inflammation. The hyperreflective spots within the retina, but also on the retinal surface, are almost pathognomonic of brolucizumab-associated intraocular inflammation, and endophthalmitis does definitely look different. And on the left side bottom, you see the shadowing of the red free by the patient. Nevertheless, the anatomic response was fantastic. Despite the severe intraocular inflammation, the residual fluid had completely gone, and this is why the patient didn't even notice so much the vision loss that he had encountered. If you see the angiographic frame, then you see there are vascular occlusions, namely the temporal inferior arcade. There are significant vascular occlusions showing this is a severely affected eye. He immediately received intravenous corticosteroids along with aspirin and fully recovered. He even improved visual acuity to 0.8 or 16/20 1 month after initiating corticosteroids, which was tapered over 4 weeks. So yes, there are safety concerns, and this has been 4.6% in total in the Harrier and Hawk trials, with the majority of them being mild to moderate and being handled with topical corticosteroids, but 0.8% having severe intraocular inflammation with retinal vasculitis and vascular occlusion requiring systemic corticosteroid treatment. These cases are the critical cases, but we have learned to handle them. And if your patients are reliably coming back, then you can make sure that they do not have a significant vision loss. As mentioned, a careful consideration of brolucizumab is deemed prudent if both eyes require treatment. If the second eye requires treatment with after 6 months of treatment, then the likelihood of developing intraocular inflammation is rather low. So you could even inject those patients in parallel if you would want to. On the bottom you see the two papers that we have published in the pitfalls in the interpretation of intraocular inflammation in response to brolucizumab and the outcomes of brolucizumab in intraocular inflammation posterior segment. So my personal experience is that we have similarly favorable functional and anatomic outcomes encountered in mild diabetic retinopathy with uncomplicated DME as in advanced NPDR with long-standing and ischemic maculopathy, including central serous detachment, as our cases have shown. 3 out of 4 own patients were able to extend their treatment interval to 16 weeks, and after 2 years were completely stopped with treatment and haven't been retreated in the last 3 to 4 years, which means they have been followed for more than 5 years, had a total of 9 to 10 injections, had remained their improvement in DRS scores, and no further need of injections. These are the happy patients, but not all of them, as the fourth case that I also have presented shows. We have not seen any significant safety signals in the DME cases. They do not have more safety issues than the AMD cases. It may well be less because of the 6-week loading phase. Besides, nobody in real life probably does 5 or 6 weekly loading injections. We do 1 injection. We see the patient after 6 weeks. If the patient has a good response, we re-inject, but we extend the treatment to 8 weeks and to until 24 weeks, as I have shown. And in DME cases, in contrast to AMD, we regularly stop treatment if not if the fluid has completely resolved in the thickness map. To conclude, the efficacy profile of brolucizumab in neovascular AMD and DME in real life is as favorable as in clinical trials regarding the reduction of intraretinal fluid and the control of lesion activity. The durability of effect is amazing, and that namely in non-responded to other anti-VEGF drugs including faricimab, as one example has shown. Post-marketing safety signals have advised that 6 weekly injections should be the minimal interval even in the early phase, and patients with DME do not harbor an excessive risk of intraocular inflammation. The chance of complete treatment cessation for many years is a very interesting thing, which has not been reported for other drugs. That's something that we also have published, as you can see at the bottom line. Just to mention the posology of Paganax in India. With that, I thank you for your attention and Wanda for your questions.
Thank you, Dr. Garvik. That was a very, very informative talk. So we are running a little short of time. So I would like to invite our next speaker, Brigadier S.K. Mishra, who needs no further introduction. Sir, please.
Thank you. Dr. Justice, please hang on for some time because we may have questions after this talk.
First of all, my sincere gratitude to Sao and Dr. Lalit Barma for inviting me to share my experience. Thank you, sir, for having those benevolent words. But I always say I'm going to finish in time, so I'll just take 2 more minutes within my stipulated time to thank my team. It's actually, I'm as good as my team. So all these advancement, newer projects were not possible but for my team. My team has been very, very sincere. I was just leading the team, and the team behind the doors was working overnight to get these things. The one thing which was very close to my heart was the new center, which has now got a government approval in a record 5 weeks' time. This was a dream which was conceived by my seniors, very revered seniors like General Vats, who is just retired as a member of parliament from the Rajya Sabha, General Pariyar, General Patyal. They were all, I was just fortunate enough to just make it happen in this time. My sincere gratitude to Colonel Pradeep and Major Sanskrita, who they have worked very, very hard for this work, and they've, day and night, they did their work, and they used to sit in the department and work with all those drawings. And now I come to know that a lot of work is required to create a center. So my kudos and my sincere appreciation to them. Now I'll start my presentation as I say that I'm going to share my experience of Army Hospital RNR in diabetic macular edema. The agenda is basically, it's a presentation of HR. It's an RCT which was done on brolucizumab in DME, and further observation of DME post RCT and other novel applications of brolucizumab. So the logic behind this RCT was that we know that FDA had given approval for 2 different dosages of ranibizumab, that is 0.3 in DME and 0.5 in CNVM, and even the Kestel study studied 2 different doses of brolucizumab, 3 milligram and 6 milligram, with showed that it had almost similar efficacies. Basically, the hypothesis that intravitreal administration of biological molecules provides easy access to a pre-retinal space, which is a major target for the diabetic retinopathy. So the design we designed, it was a randomized design. We put the patient in 2 categories, one in receiving 3.6 milligram and other receiving 6 milligram of brolucizumab. We had all the approvals were taken in due time, and the major inclusion criteria was that the BCVA was less than 0.1 logMAR unit, and the CMT and SDOCT was more than 300 microns, and the exclusion criteria was all these patients were treatment-naive patients. It was a PRN study. 4 weekly intervals was used from week 0 to week 28. BCVA was measured using logMAR units, and the macular thickness was measured. This was measured at all visits. Safety parameters were of utmost importance, and each patient was monitored on day 1, day 7 and day 21 of administration of intravitreal brolucizumab. Retreatment criteria was considered any presence of intraretinal fluid on OCT, presence of subretinal fluid, reduction of BCVA of 0.1 on logMAR unit from the last injection, and the central macular thickness increasing to more than 350 micron in absence of SRF and IRF. Ocular adverse effects were graded as per the standard protocol. Of the more important was the grade 4 reaction. This was the result. If you see that both the groups were matched equally, whether it was age and the ocular parameters were matched equally. This box and whisker plot shows the vision change in group receiving 6 milligram of brolucizumab. There's a definitely increase from week 0 to week 28, and this on 3.6 milligram of brolucizumab, again showing similar result of improvement of vision from week 0 to week 28. This is in the tabular form of comparison of BCVA in both the groups. It's almost similar matching. And the changes of BCVA who received 6 milligram on a graphic form, if you see that there's an improvement. This is the 3.6 milligram receiving groups. And again, the changes in BCVA is almost similar to the group receiving 6 milligram. The CMT, again, like BCVA, again, both the groups fared well and almost matched equally. So the number of injection in two groups, that is group which required 6 milligram were given 119 and 3.6 were given slightly less of 112 injections. The ocular effects, side effects was important that in 6 milligram group, grade 3 reactions were noted in 4 cases and grade 4 in 1. This grade 4 was managed with a PST of 40 milligram. The BCVA worsened from pre-injection from 0.3 to 0.9 at week 1, but gradually improved to 0.4 at week 6, and he again received one more injection of brolucizumab with no further injections, and the final BCVA was 0.26. In the 3.6 milligram group, grade 3 reaction was seen in 3 patients and grade 4 in 1. Again, this patient was managed on the same lines. The vision worsened from pre-injection of 1 to 0.66 at week 1, improved to 0.18 at week 8, has again received 3 more injections of brolucizumab, and the final visual acuity is 0.1. So the take-home message is that brolucizumab is a very effective form of center involving DME, can be used at a lower dose. This is very important because, you know, financially also it can, it will definitely help the patients at lower group of lower dosage of 3.6. PRN basis can be employed right from the beginning. Patients usually require 3 injections in 28 weeks on an average. The adverse effects which were seen were did not pose any contraindication of reuse of brolucizumab and were managed well. This was our study. I spoke about our study which was in AMD cases, and this is how it was published in the International Journal of Retina and Vitreous. And the frequency of patient in this group, we studied the frequency of patient achieving different inter-injection interval after receiving third loading dose at 8 weeks in 2 groups. So currently, the current status as of now, we have used more than 2,000 injections, 2014 to be precise. Various indications what we have used is AMD, DME, RVOs, and myopic CNVMs, and other novel uses which I am going to tell. In myopic CNVM, normally it's a type 2 kind of a CNVM. Normally the approach is to use a conventional anti-VEGF given in 3 loading doses, and after that a PRN therapy is formed. But here we differed. This is the case 1, a 32 years old lady, high myop, a vision of 6/9 with metamorphopsia, and received 6 milligram of brolucizumab. And at 8 weeks, the macula was dry. The patient was asymptomatic. At 12 weeks, received the second dose. The metamorphosis responded, and at 28 weeks, patient remained asymptomatic with a best corrected vision of 6/9. Other novel application we use in a von Hippel-Lindau disease. So the large angiomas required and usually require anti-VEGF prior to excision. Normally, other anti-VEGFs are used. Where here we used brolucizumab, and we performed the surgery in this case. So basically the angioma was excised. After cauterizing the angioma, it was excised, and via surgery with a silicone oil was implanted after doing a 360-degree Panret. The patient fared very well. Again, another novel injection that we have, this is a case of a one-eyed patient having a PCV and earlier bleed, had a fresh bleed, and the vision dropped to 3/60. We gave TPA and brolucizumab subretinally after performing the surgery, and the patient responded very well, and the post-surgery the vision was 3/60, 3/36. Thank you so much.
Thank you, sir, for that excellent talk. Can we now have Dr. Arnab presenting his views?
Arnab, the one below, yeah.
Slide.
Yeah.
Slides.
Yeah, good evening everybody, and thank you Dr. Lalit Verma sir for inviting me here. So this is my topic, and so this has already been discussed and we know of this, and just to emphasize that PCV is a subtype of type 1 CNV, and OCTA in neovascular AMD is especially helpful in type 1 CNV, where the BVN can be picked up and monitored. My talk and cases discussed shall be confined to this subtype. So we all know how an active BVN on OCTA generally looks, and we know that it's a dense network, and one variety has been variously described as coral bush, lacy pattern or glomerular pattern, and an active BVN has a closed loop appearance, as you can see there. There is another pattern called the trunk pattern, we know of this too. And we also know that when the BVM becomes inactive, it will be less dense and is often described as a dead tree appearance. And the inactive BVM has an open loop appearance. Newer anti-VEGFs more regularly help achieve anatomical improvements once considered near impossible, allowing some, maybe many retinologists to even contemplate not using the conventional tree loading doses with these newer, more powerful and longer acting agents, even in neovascular AMD or PCV. So this case, as you can see, is a 75-year-old lady presumptively having PCV with fluid in all three compartments, along with subretinal hemorrhage and exudation. The patient's left eye too showed PCV with fluid in all compartments. Exudation and hemorrhage was lesser in this eye than the right, but the visual acuity was same at 624, and the safety was increased in both eyes. OCT of the right eye 1 month post brolucizumab showed total resolution of fluid in all three compartments, so the wow effect as we know of, and the left eye too 4 weeks after one shot of brolucizumab there was total resolution of fluid. CFT dramatically improved in both eyes. Expectedly, FAF also significantly improved in both the eyes, and in the right eye the visual acuity improved from 624 to 612 parts at 1 month, and in left eye it improved from 624 to 66 parts. 2 months after one shot of intravitreal brolucizumab, visual acuity was even better at 69 parts in the right eye now, and the OCTA too showed no BVN. And similarly for the left eye, no disease activity and visual acuity at 66 parts. Thus no further injections planned at that point for either eye, as no fluid or hemorrhage clinically around SD OCT and no BVN on the octa, even 2 months post injection, and the patient was given amsulagrid and asked to follow up SOS or 6 weekly. This case, a 72-year-old female with drusense in both eye with large PED in the right eye and drusenoid PED in the left eye. She was being followed up elsewhere and referred to us as the right eye PED had suddenly increased in size with associated drop in vision. At the first presentation to us, on SD OCT, a large PED greater than 2 disc diameters in size with subretinal fluid was noted. Old OCTs done elsewhere did confirm the PED to be smaller before and without any subretinal fluid. Thus, SRF, sudden enlargement of the PED, and BVN on the octa justified the need for anti-VEGF injection, and the right eye patient underwent intravitreal brolucizumab, and 13 days after one dose of intravitreal brolucizumab, PED height was grossly lesser and SRF volume also lesser, and the visual acuity had already improved by 1.5 lines. Another cardinal axis confirms the same, and even 90 days after one shot of brolucizumab, PED nearly flattened and the macula has remained dry. So it seems that newer anti-VEGF, especially brolucizumab, is a powerful drying agent even for the more difficult fluids like sub-RPE fluid and intraretinal fluid. This case, a 63-year-old man complained of decreased vision in left eye for last 10 days, and left eye showed RPE alterations with subfoveal hemorrhage, and visual acuity was at 612 parts. And on the OCT, you had a sharp subfoveal fibroscler PED with subfoveal fluid, and another axis showed irregular fibroscler PEDs with double layered sign filled with hyperreflective material with peaking in one region. Octa showed BVN in the outer retina and choriocapillary zone. A more zoomed Octa showed BVN even more clearly. Diagnosis was PCV and underwent intravitreal brolucizumab. SDOCT 5 weeks post-injection showed remarkable structural improvement with complete resolution of the subfoveal fluid, hemorrhage and PED, and visual acuity had improved to 6.9 from the baseline of 612 parts. Octa 50 days post-injection showed BVN had nearly disappeared but not totally, so another dose of brolucizumab was given. For recollection, this was how the BVN was prior to the first injection. Follow-up 6 weeks after the second dose shows no BVN on OR, no fluid or hemorrhage, so third dose not planned and patient only asked to follow up regularly. This case, a 69-year-old physician, past history of CSR both eye with increased diminution of vision in the right eye for the last 1 month, with FAF showing significant RP alterations right greater than left, and visual acuity was poor in the right eye at 660. The right eye Octa showed BVN in the outer retina and slight scarring in the CC zone, and SDOCT showed fluid in all compartments, as you can see there. Underwent brolucizumab injection. And 1 month post the first injection, the BVN is somewhat regressed. The SDOCT shows IRCs and shallow irregular PEDs nearly totally resolved, some macular fluid much lesser, and visual acuity was now at 624 parts vis-a-vis 660 with improvement in CFT as well. But large OCT angio through the outer retina showed BVN still significantly present, thus brolucizumab second dose was given. 1 month post second injection, BVN is more regressed and smaller, with SDOCT showing further improvement with no submacular fluid now, and fibrovascular PED is also a shade smaller, and visual acuity was even better now at 618 and CFT even lesser. Large angio of the outer retina shows BVN now significantly smaller and less dense after the second injection, and third dose of brolucizumab was given although no fluid was there on the SDOCT. 6 weeks after the third dose, BVN now grossly lesser, and the SDOCT nearly restored to normalcy. Visual acuity was even better now at 612 with further reduction in the CFT. And this is how the Octa and the OCT looked at baseline for your recollection. As this was the state 6 weeks after the third dose, with BVN now grossly regressed and also no activity clinically and on SDOCT, plan was to review the patient 6 weekly, but also he was to report SOS and repeat treatment if reactivity picked up clinically on SDOCT and or the BVN reactivating on the Octa. This case, a 65-year-old male non-smoker with history of scotoma right eye for the last 2 months. We had a presumptive diagnosis of hemorrhagic PNV or PCV. In the right eye, BVN was noted, as you can see there, closed loop appearance. Structural OCT shows IRCS, shrimp and SRF, and visual acuity was at 612 parts. Enlarged scan shows the closed loop active BVN even more clearly. 1 month post one shot of Brolu, Octa showed BVN nearly disappeared except for a few remnants. SDOCT showed dry macula. Visual acuity had improved to 6.9 parts from 612 parts. Another injection of brolucizumab was given 7 weeks after the first shot in spite of no fluid on SDOCT. 14 days after the second dose of brolucizumab, patient had come for other eyes post phaco plus IOL follow-up. BVN had disappeared in the outer retina. A zoomed angio confirms avascular outer retina, and avascular outer retina 2 weeks post the second dose and visual acuity having improved by another half line to 6.9. No further injection was immediately planned and patient asked to review after 6 weeks or SOS. This case, the last case, a case of neovascular AMD in left eye with prominent BVN in outer retina with some perifoveal scarring in the CC zone. SDOCT showed fibrovascular PEDs with SRF with slight subretinal hemorrhage as well, and visual acuity was at 618. 4 weeks after one injection, BVN in outer retina significantly regressed, structural OCT is much better, and visual acuity has improved to 6.6 parts now. But as the BVN is still somewhat there, though less vascularized, next injection of brolucizumab was planned 2 months post the first injection. But 2 months post the second injection now, there's been no change in the Octa, as you can see, and the SDOCT remains the same, that is stable and dry, and the visual acuity is static and good at 6.6 parts. Large angio-OCT and NFAS confirmed stability and no improvement or worsening. Thus, no further injections planned, and patient asked to monitor left eye using Amsler grid and follow up SOS or after 6 to 8 weeks. So, when treating with brolucizumab for neovascular AMD, in the initial phase, I do not insist, as many of us, many of you in the hall too, don't insist on the 3 loading dose, especially when I have an octa to guide me, but stop short of 3 loading doses only if BVN has totally regressed, which is infrequent, or the BVN does not regress any further. Of course, in addition, the disease should have appeared, should also appear inactive clinically and on the structural OCT. Else, repeat injections with increased spacing of 6 to 8 weeks. If one does not have access to octa, better to go for more than 1 injection of brolucizumab, of course with an increased gapping, even if the macula is dry on the OCT after the first dose, as one cannot be sure about how much the actual pathology has regressed without an octa. My experience is that only small, less florid, fresh BVNs with thinner vessels may vanish with 1 or 2 shots of brolucizumab, and only the early varieties of glomeruli pattern BVN without major trunk may totally regress. The trunk pattern does not regress completely, as the trunk remains even if radiating branches regress significantly. After the initial loading dose phase, what is classically recommended for neovascular AMD is treat and extend, but now with the advent and the ever increasing availability of octa, the need to treat, that is to inject at every visit in the TNE phase, even when the macula is dry, might be needed to be re-evaluated. Maybe if the OCT is dry and the visual acuity is stable and the octa reveals no or stable inactive BVN, then injection in the treat and extend phase might be avoided. You may follow up the patient classically as is done in treat and extend, but treat only as necessary, and this is known as observe and extend. However, a large RCT needs to look into this, and if octa is not available, best may be to follow the classical treat and extend regime. This is the last, and you will get what I was trying to talk of. This patient had received 3 doses of brolucizumab at 6 to 8 weeks interval in the initial phase, with last being 5.5 months ago. Was being followed up on the observe and extend regimen rather than the treat and extend, with visual acuity being stable at 6/9 and the SD-OCT being dry and residual trunk pattern BVN which was keeping stable noted. Thus, patient had not received any repeat injections post the initial doses. An enlarged scan also of the same day confirmed stability with relatively dead-free appearance with larger, more mature vessels suggestive of inactive chronic neovascularization. Structural OCT reconfirms dry macula with shallow irregular PEDs continuing to stay very shallow. However, at a last slide. However, at a further observe and extend follow-up, 8.5 months after the last injection of brolucizumab given in the initial phase, showed that though the vision was still stable at 6/9, structural OCT showed an increase in the height of the fibrovascular PED with an associated increase in CFT, and octa showed an increase in the vascularity and enlargement of the BVN. And you can see there were also traces of SRF if you zoomed up the thing. So there was certain evidence of disease reactivity. So of course, now I had to retreat this patient, and since the patient had done well with brolucizumab, I retreated with brolucizumab. Thank you.
Thank you, Dr. Arnab. Yeah. Can we now have Dr. Arindam for his talk on antioxidants in AMD?
Arnab, till the time Arindam comes, if octa is not available, you still inject one more. That line I could not understand. Why do you want to inject more? If structural OCT is okay.
There were some cases where the SD-OCT was absolutely dry. There was no hemorrhage of fluid. So basically, it was appearing stable clinically and on the SD-OCT, but I, having injected another shot, found a further regression of the branch vascular network. So maybe we can improve the causative pathology more if we give another shot.
Good evening, everyone. Thanks, Lalit sir, for inviting me here to speak on antioxidants in ARMD. We all prescribe antioxidants, so we should know what we are actually prescribing. So over the years, numerous treatment options and strategies are there for wet ARMD, which have been successful. However, management of dry ARMD has not received the desired attention, and treatment options are extremely limited. The researchers with the age-related eye disease study reported in 2001 that a nutritional supplement called Aegis formulation can reduce the risk of developing advanced age-related macular degeneration. The original Aegis formulation contained vitamin C, vitamin E, beta-carotene, zinc and copper. The age-related eye disease study, Aegis, it demonstrated that the daily oral supplementation with antioxidant vitamins and minerals reduced the risk of developing advanced AMD by 25% at 5 years. Now in 2006, this same research group began a second study called Aegis 2 to determine if they could improve the Aegis formulation. What they did, they tried to add omega-3 fatty acids as well as the antioxidants lutein and zeaxanthin, which are in the same family of nutrients as beta-carotene. They also tried to substitute lutein and zeaxanthin for beta-carotene, as prior studies had associated beta-carotene with an increased risk of lung cancer in smokers. So what was it? It was basically a multi-center randomized trial of lutein, zeaxanthin and omega-3 long-chain polyunsaturated fatty acids, DHA and EPA in ARMD. So this is the scientific basis of using these compounds, because all of them have a major structural component in the visual area of the retina. So the purpose was to evaluate the effect of the two dietary xanthophylls, lutein and zeaxanthin, that accumulate in the macula, and two omega-3 long-chain polyunsaturated fatty acids on progression to advanced ARMD and or moderate vision loss in people at moderate to high risk of progression. So it was not for everyone, it was for people with moderate to high risk for progression. We'll come to that later. The purpose was to evaluate the effects of eliminating beta-carotene from the original Aegis formulation on the development and progression of AMD, to evaluate the effects of reducing the dose of zinc in the original Aegis formulation on the development and progression of AMD, and of course to contribute data for validation. So this study enrolled 4,203 participants in 82 sites between the age of 50 to 85 years. It included patients with either bilateral large drusen or large drusen in one eye with advanced AMD in the fellow eye. So this inclusion criteria is important. Exclusion criteria were of course other ocular diseases like high myopia, glaucoma and clinically significant diabetic retinopathy, besides eyes that had already undergone cataract surgery, but eyes which had undergone cataract surgery at least 3 months prior to enrollment were eligible, but within that 3-month period, those eyes were not included. So it was a randomized double-masked placebo-controlled trial evaluating the risks and benefits of adding lutein 10 mg, zeaxanthin 2 mg, DHA 350 mg, EPA 650 mg, or both to the Aegis formulation. So the doses of the original Aegis formulation was 500 mg of vitamin C, 400 international units of vitamin E, 15 mg of beta-carotene, 80 mg of zinc as zinc oxide, and 2 mg of copper as cupric oxide. So this is the primary randomization where this 5178 patients were assessed for eligibility, and this first group was randomized to receive the placebo. But here, mind you, placebo doesn't mean the placebo in the real sense, because they were all supposed to receive the original Aegis formulation. So it's not a true placebo. The second group, it was randomized to receive lutein and zeaxanthin. The third group was randomized to receive DHA plus EPA. And the fourth group was randomized to receive both lutein, zeaxanthin as well as DHA plus EPA in addition to the original formulation. So this was the primary randomization. But what they did a second tier randomization had to be done. Why it was done? It was to evaluate the effect of eliminating beta-carotene and lowering the zinc doses in the original Aegis formulation. But here there was an issue, because there were people who did not consent to this secondary randomization, but who agreed to take the original Aegis supplements, provided they were not current or former smokers within the past year. They were allowed to participate in the study, and smokers were not randomized to groups receiving beta-carotene. So this secondary randomization, all 4 of which received the intervention. So the first one was randomized to receive only the original Aegis formulation. The second was the original Aegis formulation without beta carotene, and the third group was randomized to receive Aegis supplement with low dose zinc, and the fourth group was randomized to receive Aegis supplement with no beta carotene and low dose zinc. So it was a little complicated study design with a secondary randomization, and then the follow-up study visits were scheduled annually. At each study visit, participants received a comprehensive eye examination, including best corrected visual acuity using a standardized protocol and stereoscopic fundus photographs of the macula and optic nerve. The primary outcome of this study was the development of advanced AMD. What is advanced AMD? It was defined as central geographical atrophy of retinal features of CNVM, which were detected on the stereoscopic fundus photographs, or a history of treatment for advanced AMD after study enrollment. Secondary outcomes including progression to moderate vision loss from baseline or treatment for choroidal neovascularization. Treatment was included in the outcome because treatment might maintain the visual acuity in an eye with advanced AMD. Out of a total of 4,203 participants who were enrolled was mean age of 73.1. Total of 3036 participants agreed to the secondary randomization, evaluating the modification to the Aegis supplements. 141, 3% were lost to follow-up, and 368, 9% died during the course of the study. So what was found in the results was that the Aegis 2 participants had significantly high serum levels of lutein and zeaxanthin and DHA and EPA compared to the general population as expected. At year 5, the serum levels of lutein in those randomized to receive lutein plus zeaxanthin and Aegis formulation with beta carotene were actually lower than in those randomized to receive lutein plus zeaxanthin and Aegis formulation without beta carotene. Now, the median follow-up of 5 years and a Kaplan-Meier probabilities of progression to advanced AMD by 5 years were almost similar in all 4 groups. You can see from the percentages. 31% for placebo, 29% for lutein plus zeaxanthin, 31% for DHA. It's almost similar, so there was not much of a difference. So comparison with placebo in the primary analysis demonstrated no statistically significant reduction in progression to advanced AMD, and there was no apparent effect of beta carotene elimination or lower dose zinc on the progression of advanced AMD. So in other words, it was almost a similar result we were getting. So what was different? Different was number one, lutein and zeaxanthin was found to have a higher odds of reducing the progression alone than with omega-3 fatty acids alone. So the role of omega-3 fatty acids was kind of, it was found not to be effective. Then none of the nutrients affected development of moderate or worse vision loss, defined as a reduction of 15 or more letters from baseline or treatment for neovascular AMD. And there was no apparent effect on vision was observed on eliminating beta carotene and reducing zinc dose. So in other words, there was very little change from the original Aegis formulation with the new Aegis 2. Now, what were the changes? Now, we will come to that in the next slide. And safety outcomes, no clinically or statistically significant differences in reported serious adverse events, including rates of developments of neoplasms, were noted across the treatment groups in the primary randomization. However, the secondary randomization, excluding participants who were smokers, showed more lung cancers in the beta carotene group than in the no beta carotene group. So this is important. So beta carotene was a culprit. The addition of lutein plus zeaxanthin, DHA plus EPA or both to the Aegis formulation in primary analysis did not further reduce risk of progression to advanced AMD. So the addition of these nutrients were not very much helpful in changing the results, but because of potential increased incidence of lung cancer in former smokers, lutein and zeaxanthin could be an appropriate carotenoid substitute in the Aegis formulation. So this is the basis by which most of the pharmaceutical companies have removed beta carotene from their formulations and supplemented it with lutein and zeaxanthin. The primary analysis demonstrated no beneficial or harmful effect of lutein zeaxanthin for the treatment of advanced AMD. But when exploratory subgroup analysis of the treatment effects were limited to those participants in the quintile with the lowest dietary intake of lutein plus zeaxanthin, lutein and zeaxanthin demonstrated a protective effect for progression to advanced AMD. I will go to the second point here. The simultaneous administration of high doses of beta carotene and lutein zeaxanthin may suppress serum and tissue levels of lutein zeaxanthin because of competitive absorption of carotenoids. So we have to be very careful with the formulations of what they contain. We should not contain lutein zeaxanthin as well as beta carotene, because not only does it increase the risk of lung cancer, but it also reduces the serum levels of lutein zeaxanthin.
Dr. Arindam, can we?
Yeah, I'm finishing. Summarize addition of lutein zeaxanthin or lutein zeaxanthin and DHA EPA to the AREDS formulation in primary analysis did not reduce risk of progression to AMD, to advanced AMD. Comparison of low dose zinc plus high dose zinc showed no evidence of any statistically significant effect. In view of the risks associated with beta carotene, lutein zeaxanthin requires further investigation to include, which has already been included. But now this slide is very important. I am sorry I am out of time, but please take a good look at it, because this is the recent data. The recent data, the AREDS and AREDS2 studies established that dietary supplements slow progression of ARMD. Now in a new report, this is just published in 2022, the scientists analyzing 10-year AREDS2 data showed that the AREDS2 formula, which substituted lutein and zeaxanthin for beta carotene, not only reduced the risk of lung cancer, but is also more effective at reducing risk of AMD progression by an additional 20% compared to the original formula, which indicates if you give a proper AREDS regime to a patient, you reduce the risk of developing advanced ARMD by almost 45%, which is a substantial number. This finding suggests that the AREDS2 supplement with lutein zeaxanthin instead of beta carotene was safe with no association with developing lung cancer, and so there is no need to any longer take a history of smoking when describing AREDS2 regime. So this is the practical point. But where to prescribe is again important. Multiple large drusen, bilateral, large confluent drusen, single large drusen in one eye with advanced AMD in the other eye, non-central geographical atrophy, which could be unilateral or bilateral. Now, the most important point in India, most of the companies, they do not have formulations which satisfy AREDS2. Despite multiple requests, multiple discussions, they are not willing to make AREDS2 formulations as per the regime given. Except for maybe two compounds which I have come across. One is IGM6 of Ophtho Life Sciences. The other is Oxysite of Neomedics. These are products whose components satisfy the AREDS2 recommendations. And the advantage with IGM6 is it has a once daily dosing schedule, so which gives it an additional advantage. And it also has the green mark. So anyone, even a vegetarian, can take this capsules. So whenever we prescribe, it is for the clinician to follow the science behind the management of dry RMD. Thank you.
Thank you, Dr. Arindam.
So thank you for chairing this session, Dr. Mishra, the entire team, AG and Ogli, as well as Kunal. So we'll come to the last session now. Last but not the least, I think there has been an overdose, but believe me, this session should be the punching session, primarily because of the advancements which have taken place. Okay. So this session is primarily, again, because we started with anti-VEGF conventional agents, then we had newer agents, then we have the newest agent now, which is faricimab, which has recently become available this year only. And we are very fortunate to have Dr. Anirudh Agarwal from UAE, who will be joining us and giving his experiences. And there has been a new paradigm shift all over the world. It's not in India. This is Dr. Anirudh Agarwal, who was with us for a long time. but now he's in Cleveland clinic in US, and he's already online. And with me will be Dr. Nikhil Pal as well as Dr. Vikram and Dr. Neeraj. Can I request you to please, Neeraj, can you please come on the dais, and Dr. Ruchir as well as Dr. Saurabh. So these three retina experts will be helping in conducting this session along with me. So the sequence is this. I will not waste time in introducing all the speakers because all of them are very well-known people, starting from the younger Ruchir to more experienced Anirudh and Saurabh. But I would like to begin this with I'd like to. Can everybody sit down, please, instead of talking? हेलो सर, बैठ जाएं क्योंकि सेशन अभी ख़त्म नहीं हुआ. वी कैन स्टिल हियर अदर्स ऑल्सो. So I would like normally divide anti-VEGFs into first generation, which all of us have been hearing since morning, and to the newer generation. You see, faricimab got approval in 2022, but in India it became available in January of this year only. So I would like to skip these slides primarily because previously goal was maintaining vision, now expectancy by everybody is to improve vision. And because a lot of data is now available with for last so many decades, you see NAMD as well as diabetic retinopathy has been very, very effectively managed with the anti-VEGF therapy, and there is a 50% reduction in the incidence of blindness in NAMD and 75% in DME. People are talking of 1-line improvement here and 2-line improvement in DR. But remember that both these diseases are increasing as the longevity is increasing, both NAMD and the projection is to reach this. So all of us have to be prepared to tackle this blindness. But believe me, despite so many discussions on conventional anti-VEGFs and other anti-VEGFs, the burden of treatment is very high because no longer patient wants to come every month and get an OCT done, and the burden is not only primarily for the repeated visit, but increased drying effect also, as well as other factors which play a part in compliance issues. So frequent interval, that is the main thing, frequent visits to the hospital, and people are looking for larger duration actions and more drying action. And this was stressed in the morning also, that a huge proportion of patients, nearly 30 to 40%, do not adequately respond to the conventional anti-VEGF agents. So there is a new thinking for sustained as well as effective management, and here comes this wonder drug by the name of Vabysmo. And Ang2 and Ang1 has already been spoken in the morning. We will not deliberate, but suffice to say that this new molecule has 3 arms primarily. One is anti-VEGF, one is Ang2, and the modified FC is primarily to reduce the systemic exposure and inflammatory potential. But why this new molecule? Why? Primarily, as I said, safety is always of paramount importance, and this is one molecule which you can inject with confidence, reasonable amount of confidence. Efficacy has been proven beyond doubt by multi-centric trials, primarily stressing on 3 Ds, that is dual mechanism of action, durability and drying. And people with longer distance travel time, because this was one point which a lot of my patients in fact prefer this molecule because of frequent travel. Suffice to say, why so much hype has been created is because of its positivity spread in various countries. More than nearly 100 countries it has become has been approved and standard of care in a lot of these countries. And globally 4 million vials have been injected, and in India we have had nearly, I think this figure is slightly old, 2,000 patients already injected. And this would not carry on till the time until unless this drug is effective. And this is what I recently got attention to today itself, that this is the extension of primarily the Yosemite and Rhine study. Is this the largest DME extension study to date with retention of nearly more than 80%? You see, very few studies will have retention of 80%. And what was concluded in this was that BCV and CST improvements were achieved. What were achieved in the landmark Yosemite and Rhine studies
were maintained in 80% on Q12 dosing. This is what all of us are looking for, that majority of the patient, here it is nearly 80% on Q12, that is what this ROAN X study also has demonstrated. I'll just share with you very briefly what CFS experience has been till date. We have given around 46 injections, but here we'll share data of around 20 because we have follow-up of 4 to 6 weeks. Because remember, it is only 6 months old only. And these were a couple of diseases which all of us in CFS injected, NAMD, DME being the major one. This was my first patient. He himself is a doctor, his wife is a nurse, and he travels from Kashmir. And he actually was receiving aflibercept as well as razumab for long time. He himself said, Dr. Sahab, naya injection aaya, to why don't you try this? So with his recommendation, this was my first injection. This was given in the month of January itself. And first day itself, he said it's very good, and he volunteered for the other eye injection also. And this was the other. This was left eye. The previous was the right eye. So here also this patient, had some effect, and this patient already received another injection also. So, but when he came for the 12th week visit, he himself did not come, because actually my experience also was not so much in dealing with this. So he himself came at 12 weeks only. Once he came at 12 weeks, he was doing pretty well in the right eye, but in the left eye there was some recurrence of edema. Although vision was still 6/9, but there was some edema here, and he received the second injection also. This was my first treatment naive patient here, which is lady with, you can see PED with Shrem hair and CNVM. And this was the first time patient had visited any ophthalmologist. Presenting vision was 636. In the January month itself, gave her the first injection, and after week 4 there was a dramatic reduction of both PED as well as this SRF had completely vanished away, and this Shrem material had virtually disappeared also. And you can see 854 to 415, nearly 50% reduction with one injection. And then subsequently she received second injection also, then third injection, and then fourth injection also, and then fifth injection. And this vision has now reached 6/9, and she is pretty stable on this. She started with 636, 6/9. The point to be conveyed here is that once we are treating treatment-naive patient, it requires multiple injections. It is not that one injection will give the final result. So this was the timeline of this lady, first, second, third, fourth, and this. This is after 4 monthly injections which she has received. This was a couple of other patients, not belonging to me, but some of my colleagues who had given this 92-year-old lady previous history of multiple anti-VEGF injection, and you see this is 4 weeks after the first injection given in February, then in March, and dramatic reduction of IRF here. This was another patient, again one of our colleagues' patient. You see this was this was again dramatic reduction of the fluid. Another patient of CNVM. This was after 4 weeks of injection. Another patient, one of my colleague gave of faricimab. This was again, you see the last picture. This is in April. If you compare the first and the last, there is a dramatic achievement here. This can go on and on, but suffice to say, this was our cumulative experience of central oversight in CNVM, another patient who had. So, logMAR visual acuity was not a dramatic change, because most of our patients were not treatment naive patients. They were resistant to conventional anti-VEGF for long time. However, point to be noted was the change in the CST, PED and SRF. And all these 3 compartments showed good reduction of fluid. So this was about CNVM, a brief experience. About DME, this was again a lady who her son is in San Francisco, heard about this, and he virtually forced me, Dr. Sahab, we want the best kind of injection. He told that US has shifted, why don't you? So this was multiple Eylea injections had been given in the past, and we injected faricimab to this lady, and patient maintained vision, and you can see obvious collapse of this cavity here. This was left eye, and this was the right eye of this same patient. although the effect, if you see, to my thinking, the effect was not as dramatic as in CNVM, although a patient felt happier, but I was not so happy, primarily because she received only one injection in each eye, and I could not cajole her to receive another injection. This was another patient, resident of Far East from India, and first injection did not make much difference in DME, and this was another injection given, though effect was there, but not as dramatic as in ARMD. This was the other eye of the patient. So to my thinking, in DME, our observation was the effect is not as dramatic as in AMD. AMD, which we saw reduction of fluid in all the compartments. In DME, the reduction was not as much. Primarily, I think these patients did not receive multiple injections. This was one doctor, orthopedician, who had vasculitis and had significant IRF. So we gave first injection, and within 3 weeks this became absolutely normal. This patient absolutely became normal. He was receiving Eylea in both the eyes for a long time, and we switched to faricimab for this. In the other eye also, he had, this was an inflammatory kind of swelling, but patient did respond dramatically to faricimab. So this was the timeline for this patient. So, but once he came back, then he, after 8 weeks, there was some rebound in the left eye. Right eye still continued to behave reasonably well. So this is a learning experience for us also, because I also do not have much of experience for treating faricimab, but nevertheless in AMD, this patient. So we were just talking about economics in the morning. If you see the previous anti-VEGF generation 1 and anti-VEGF generation 2, considering that it has various schemes available, 1+1 and 1+2, this because it may not be ultimately required to be injected every month after the loading dose, this does make economic sense in the long run. So maybe like in other countries, faricimab is occupying a lot of space in the armamentarium of all anti-VEGF agents. Maybe ultimately it becomes cost effective with advantage of longer duration of action and reduction in the number of visits. So this is the comparative costing which we had worked out. So thus to conclude, this new molecule with dual mechanism of action acting on both VEGF as well as Ang2 pathways promises long duration of action, and considering the scheme offered by the company is cost effective. And as I said, we will hear Anirudh also, it is efficacious, but primarily AMD, the response is much better. But what we have learned after speaking to a lot of international faculty also in various forums, that do not expect benefit after a single injection. For this, injections have to be given in a loading dose, especially in treatment-naive patient. Do not expect that one injection you will have a wow effect. So you have to persist with the patient for 3-4 injections, and here is the role of counseling and sitting with the patient for a long time, that please persist with number of injections, then you will have the advantage of long duration as well as as reduced number of visits. So this is the punchline, that you have to adhere to this loading dose and multiple injections have to be given. Saurav, this is your patient. Would you like to comment? This is Saurav's patient, and you can comment from there only.
So yeah, I mean, as sir said, I think this particular molecule has been, yes, it may become a very cost effective, and no doubt that it is a drug which probably needs some time to act. It is not something which we have a wow effect immediately. So this was a patient who was on Eylea, had been on Eylea for almost 4 injections. There was a hard exudation clump which had been persisting over there. I have been giving Eyleas regularly over a period of 8 to 12 weeks, but again there was a recurrence again and again. So I have just given one Vabysmo, but this is a picture which has a gap of 2 months, and there was a very significant reduction in the hard exudation itself. So yes, here 2 things come: whether the glycemic control was well earlier, and is there any difference now? No. So the lady is she's pretty intelligent. She understood her disease very well earlier, and she had been keeping her glycemic control very nice. Her lipid profiles are very well managed. So I would say, I would definitely congratulate this molecule that it has given me a good effect.
This is the OCT also.
Yeah, so the OCT here is there, and we can see that there is a pretty spongy thickening with hybridated foci, and then later on this is the recent OCT which has given me a good reduction. Earlier it used to reduce, I would not say initially 2-3 injection it gave very nice reduction, but then it used to recur. So this, but right now I have given her a period of a 1 month, 2 months gap now again, and she's going to come back to me in 2.5 months now.
So are you contemplating faricimab again, or?
Sir, yes. I mean, to looking at this OCT, I just told her that maybe her vision never improved beyond 612 part. Now she's 6'9", 6'6" part. She was reading almost the third line, like the last line also, but then she was little this thing can we wait now, because.
So how many Eylea injections this lady has received before?
So we almost gave 3, I think, 4. 4 injections in a matter of almost 8 months.
Did you try Ozurdex?
No, sir. I didn't try. I used to get a good effect, sir. Only that I shifted only because last one injection in that I didn't get a very good wow response, and then later on even this molecule has come. I just gave an offer to her. So this is a new molecule which is just launched, and she was very willing for it. Plus she comes from very far, so she was all the more interested that if we can increase the intervals. I could not plan a loading dose for her because she's already received 4 Eylea, so that was a difficult task to get a loading dose, planning a loading dose for her. But yes, I mean, giving 1 injection, definitely it improved a lot, and she was very happy.
Yeah, because I was amazed by this photograph in the lipid reduction, because conventional anti-VEGF agent take longer time to have this kind of effect.
So even for me, looking at this, and she was very excited looking at this more than anybody else, I would say. So that was something which I look forward now, because I think, I mean, even with exudative clumps, what we have usually, we plan to inject more frequently. I mean, and this is only 1 injection. So I would definitely plan a couple of more so that I can give them a better response.
So thank you, Saurabh, for sharing this slide.
Thank you. Thank you.
Yeah.
In about 20 cases, and I found in about 2 or 3 patients, the anatomy did not change. These were all non-responders, but vision improved in at least 3 of them, to the extent that they wanted to continue only with faricimab. So those who were for years DME, the vision was stuck at 612, suddenly came to 6.6. The anatomy remained the same. Similarly, some patients with AMD as well. So there was something going on, but I'm not sure.
Yeah, so even this patient, ma'am, if you see, there is still the sponginess there, but the contour is kind of coming back to its normal, little structure is maintaining. So for me also, it was a little difficult to say don't give it, but yes, I mean, looking at her vision, going improvement to almost 6.6 part now, she was not almost not willing now, because that last line which you could, but for them the target is that last line. So the target is
retina mein last line nahi dekhte. Don't. But you see, in Mallika, what Mallika is saying, anatomy didn't improve.
Yes,
in your case, anatomy has
anatomy did recovered. Yeah, anatomy recovered, vision recovered.
Yeah, Vivek Dave says that he has patients where anatomy has improved, but not so much the vision. So anatomy probably does improve, but not in my patients.
No, we will hear from Anirudh also. Anirudh, are you online? So we now welcome Dr. Anirudh.
Yes, sir.
Yeah. I hope you heard our conversation here, and we'd like to hear your talk and also your comments about Dr. Saurabh's case as well as Dr. Mallika's comment.
Good evening, sir. Thank you so much for inviting me for the talk. I'll just share my slides. I hope my slides are visible.
Yeah, everything's good.
I saw the excellent cases presented by sir and a few comments. I'll just come to each one of them. I'll just go through my presentation, initially showing you some data very briefly, and then a few cases just to add on to the discussion. So as sir has already described, faricimab is I think one of the first intraocular molecule which has 2 mechanisms of action, both the anti-ANG2 and anti-VEGF-A. And I think sir showed a couple of cases of vasculitis, and I think this is very important, and probably faricimab might see more of this in the future, because the anti-ANG2 stabilizes the blood vessels and reduces inflammation and vascular leakage. as well as it has the anti-VEGF-A actions. There have been a lot of studies pertaining to the DME and AMD. We have the Tenaya and Lucerne and Yosemite and Rhine for DME with faricimab. So there is a robust data which is already available. Very briefly on the neovascular AMD, the faricimab did overcome the primary outcome at week 48 compared to aflibercept at Q8 weekly. So the Q16 weekly were non-inferior to aflibercept Q8 weekly. And I think this is very important when you talk to these new patients who come to you. Like you mentioned, you have patients who read about the new injections and they come to you and ask you, doctor, can we try this injection? And this is something that you can tell them, look, with the new injection, we expect you to receive more than one for sure. You will require multiple injections, and it is likely that you will require less injections. So with the PTI phase, you see here that in the second year especially, in this study it showed 6 injections of Eylea versus only 3 of faricimab. So on one hand, where you require 15 injections of aflibercept, the patients require 10 injections of faricimab for comparable results. So this is some sort of a statistic that can be given to these patients. And again, you see greater anatomic improvement. There was a comment that anatomy doesn't improve. The studies have shown that anatomy does improve with faricimab in terms of the intraretinal and subretinal fluid. And that's what I also have seen clinically, that the anatomical response is actually very good with the newer agents. Especially faricimab gives a very good response in terms of reduction of pigment epithelial detachment height as well as scarring. The studies showed that almost 100% patients at week 48 were fluid free in AMD. So you persist with the injection, and by the time you reach week 48, you will have complete drying compared to 90% with Eylea. And again, consistent results. You see that even with PCV data which is included in this, the post hoc analysis shows you that the durability exists even for PCV eyes, and the numbers are astounding. More than 84% patients receiving Q16 weeks, every 16 weeks with faricimab, and even the number of polypoidal lesions in the PCV group were much less with faricimab. I think this is a magic slide. So if you have a patient, you can tell the patient that, look, you have almost a 78% chance that you will receive another injection maybe after 3 or 4 months with faricimab once we have completed the loading dose. And I think this is something that I want to stress, that I try to stick as much as to the protocol as possible and try to load the patients. That's when you really will obtain the benefit of the new molecule. This is up till week 48, and the results were continued up to week 112, where you have nearly 78% patients, and you see the number of patients who are at Q16 weeks has gone really high. So you'll have more and more patients who will be dry for a longer period. Faricimab was well tolerated. There is no safety signal in terms of any intraocular inflammation or vasculitis compared to other competitor molecules. Quickly in DME, in the Yosemite and Rhine again, faricimab was able to maintain the results non-inferior with aflibercept, maintained through year 2. And you see here the median number of injections with aflibercept were 14, and if you look at the PTI, you have only 11 injections with DME. Again, faster and fewer injections, so you have a very good response, near 100% drying effect by the time the patients reach week 100. With faricimab PTI also you find a very good response comparable to aflibercept, in fact faster resolution of DME. This is again a similar slide showing you faster and fewer injections than aflibercept. Again, the magic slide here showing you that by week 52 you'll have 72% patients who will be Q12 weekly or Q16 weekly. So you have a significant proportion of patients receiving injections at 3 or 4 months, and these effects are continued. In fact, they improve by week 96. You see that 78% patients, and a large majority are those who are receiving injections at 4 months with faricimab. Again, with DME, there were no safety signals which came up with faricimab, and there was no concern with retinal vasculitis or intraocular inflammation. So you have 3 Ds, which is dual pathway inhibition, drying, and durability. So I'll just show you some real world experience that I have. There are lots of real world studies which have been going on. Some of them have been completed, including Far Wide, Far Retina, Voyager, etc. This is my experience in Cleveland Clinic with Vabysmo. We have had Vabysmo since 2022 now, and we've treated a lot of patients, about 131 total treatment naive with both neovascular AMD and DME, and 122 previously treated or switched. So we have a good database of treatment naive patients with faricimab. Total of 503 injections have been given, and we have not observed any adverse event or inflammation with this agent. So this gives us a lot of confidence really with faricimab. So these are my tools, or my mantras in treating with Vabysmo. So I do use it as a first line in both treatment naive DME and AMD. Even in monocular patients, I do not, have any hesitation in using Vabysmo. I also use it as first line in eyes with previous inflammation due to other anti-VEGF. So I have patients, I have at least 2 patients who've had inflammation because of another agent, and I'm using Vabysmo in those eyes. I also use it for durability as a first line. It is my first or second line in recalcitrant cases. And Lalit Verma sir showed some cases of DME, and I think even in difficult patients with difficult anatomy, I do use it as first line, and the key is to persist. It is the agent of choice in a couple of more indications for me, like subretinal fibrosis or large pigment epithelial detachments, difficult anatomy. I tend to use faricimab, and it's also the agent of choice in a lot of outer retinal or RPE changes. If there are profound changes, you would like to use faricimab. So in treatment naive patients, I often start with faricimab, and like we've seen so many cases, we do expect a very good response, and I usually like to load these patients. So you see, sometimes one injection is not going to achieve complete drying, and these patients may have fluctuation of fluid even after the second dose or third dose. And you see here, after the third dose, the patient has achieved complete drying, and the visual acuity has improved, and I persist. I give the 4th injection, and you see here the patient, I have directly called the patient after 6 weeks. I do not call the patient now after 4 or 5 weeks. I directly call them after 6 weeks, and if even if there is fluid, I'm confident that this fluid will go away with the next injection, and in my mind I'm already extending the treatment interval, and this is after 6 doses. 6 weeks after the 6th dose, he's completely dry, and the visual acuity is 20/80. Now I've already extended to 8 weeks and the patient is dry, but I still give the 7th faricimab. I was looking at the previous talks. I usually don't follow patients with OCT angiography. I just follow them on OCT. And looking at this patient here, I was comfortable in injecting the number 7 injection 8 weeks after, because of this. The fact that 15 weeks now after the 7th dose, I'm able to withhold the injection. The patient is 20/60, and at this point, I'm very comfortable looking at the anatomy of the pigment epithelial detachment. It's much better than the first visit, and I will try to extend as much as possible. This is another case resistant to Eylea, and you look at the difficult anatomy here at baseline. So this patient received Eylea, nothing happened. Second injection 6 weeks after, nothing happens. 3 injections, and the patient has such a difficult anatomy and lots of fluid. 4 injections of Eylea, and I think we've had enough. And so what we did was we did faricimab, and this OCT is 4 weeks after the first injection. There is some mild improvement, but you see here at 6 weeks, you see the improvement. That's significant, and the patient goes on to receive the second injection of faricimab. Excuse me. The third injection, and you see here at 8 weeks. So 3 injections, and you see the anatomy has completely changed, and the injection is now withheld. So you have to persist with these agents. You will not get a wow effect after 1 injection. You do have to give multiple injections to achieve that anatomical outcome. This is another patient here with AMD. Here you see this patient received Eylea 4 weeks. It didn't respond. This is the OCT actually after 4 weeks of Eylea, and immediately I switched to faricimab, and you see the response of complete drying, and this is 8 weeks after the first dose. And at this point, I can only say, if you look at the PED, faricimab is having an anti-ANG2 action, and ANG2 has been noted to have a good effect on scarring and fibrosis elsewhere in the body. So in fact, anti-ANG2 has been used for interstitial nephritis, for interstitial lung disease because of its effect on fibrosis and scarring. So intuitively, faricimab may have a good effect on PED or fibrosis and scarring. This is a patient of PCV. This was a treatment naive patient, you see, with a lot of fluid at baseline, and the patient received faricimab, and you see here at 4 weeks there is tremendous reduction in the amount of fluid. This patient did have choroidal thickening. I just treated with faricimab monotherapy, and this is what I do in my PCV patients now. I am very comfortable in faricimab. So this is 5 weeks after the second injection. I give the third injection, and now at 10 weeks later I withhold the injection. So you see a very good anatomical response. The amount of fluid decreases. Like I said, I do not follow patients with OCT angiography anymore. I just use OCT angiography in doubtful cases or for research purposes only. I do follow them only on the basis of OCT. So the same patient at 3 months comes back with some fluid, and this is after 4th injection. I'd give the 5th injection, and now 16 weeks later, you see there's a big interval between injections, and the anatomical response is so good. The response with the pigment epithelial detachment is so good. So 6 months, I think, since faricimab has been launched in India, and I think with time you will experience what we are experiencing here in Abu Dhabi, that you have to give the molecule time, and once you reach the 3 to 5 month window, you will realize that this molecule has a very good anatomical as well as visual outcome at the end of these weeks. So the previous case that was shown with hard exudates in diabetic macular edema, I want to share this experience also. You look at this macula with such an unfavorable profile, even the disc is edematous here. Look at the OCT, it's so unfavorable, and if you look at the infrared, there's so many hard exudates there. So after the first dose itself, you have a very good anatomical response. Now I've already extended here to 6 weeks since the patient cannot come. So sometimes I try to call the patient between 4 to 6 weeks, and I did do the second injection, and you look at the infrared, it's so much better than at the presentation. This patient was lost to follow-up. 18 weeks after the second dose comes back with significant drop in vision and macular edema. But you see the response is consistent. 5 weeks after the third dose, he comes back to normal. So, near normal, I would say, the very good response. And the catch point here is the infrared. It's so good. This is after the 4th dose. Very good response in terms of the infrared. But again, it comes back. It will come back. These are diabetic patients, but the response is very consistent. So this is 15 weeks after the 5th dose. So you see here the comparative picture. The hard exudates have almost completely vanished, and even the disc is appearing quite normal. So this is another patient of switch recalcitrant DME. This patient was started on Eylea, and after Eylea, really not much benefit after 1 or 2nd Eylea, 3rd Eylea, and at this point I did give faricimab. This is 8 weeks after the 3rd Eylea. I've given faricimab number 1. Some response was achieved. I did give faricimab number 2 and number 3, but I've already reached 6 to 7 weeks interval. The injections are continued, but you see the anatomical profile is becoming favorable. So it does take time. You have to be persistent. I am increasing the interval, at the same time I am persisting with the drug. So you continue the injections and you will sort of achieve a good outcome. So in patients where you want durability, I also try to use faricimab. If patients are coming from far, I think I've started using more faricimab than DEXA implant because of the good anatomical results. This is 6 weeks after the injection. This is now 6 weeks after the 3rd injection. And further, I've already increased it to 9 weeks after the 5th injection. So again, coming to the point, this is usually after 4th or 5th injection, you will see that you have a very good extension of the treatment interval. So give it time. By the time you reach your 4th or 5th injection, you will get a very good anatomical response and you will be able to extend these patients. And they will maintain a very good anatomical profile. Now this is 10 weeks after the 7th faricimab, and these patients are doing quite well. Because of this agent now I've started to reduce my dependence on even focal laser and other things that I think all of us must have reduced. So I think, am I worried after injecting Vabysmo? I do not call the patient next day after the injection. I'm very comfortable calling the patients directly 4 to 6 weeks after. I do not use any antibiotics, or we don't use antibiotics for that matter for any anti-VEGF. We don't use any steroids. And per protocol, I try to call them between 4 to 6 weeks. There were only a couple of incidents, there were publications which were reported with faricimab in terms of inflammation, and I would disregard them both because Neil Bressler in his JAMA Ophthalmology article, he actually attributed to a storage or handling problem. And in the ocular immunology inflammation, this was a patient who had bilateral hypertensive uveitis and granulomatous KPs. So I think this kind of a response is not with a biological agent like faricimab, where you have granulomatous KPs. So this is possibly an unrelated response. So like I said, I'm very, very comfortable in using Vabysmo even in monocular patients and even in patients who have had inflammation with other agents. So very sketchy evidence that inflammation was linked to faricimab. So far, I think faricimab has excellent safety signals. You have inflammation reported with everyone else, with all other agents, with faricimab, aflibercept, ranibizumab, and of course brolucizumab. With all intravitreal agents, you have inflammation which has been reported. So I'm just going to skip this, and I think more than 90 countries have approved faricimab. I think it's now almost 3 years touching. More than 3, I think probably more than 4 million doses, and like sir said, more than thousands of patients in India treated with faricimab. I don't think we have any patient from India with any adverse event. So with this, I'd like to end, and I'm happy to take any questions. Thank you so much.
So, would you like questions now or after hearing Nikhil and Vikram? So Anuradh, I thought let's hear these two brief talks and then I think we can have, I hope you'll stay for some time.
Yes, absolutely.
Yeah, so.
The next speaker. So Dr. Nikhil, please come and deliver your talk.
Yeah, so they say, life comes full circle. So I remember 2005, Avastin became available as off-label from Roche company, subsidiary being Genentech. Though its use subsequently decreased because of medical legal issues. Then came a cocktail of other anti-VEGF injections, but each had its own pros and cons. And we were lucky in January this year, Roche again launched a new drug for us, which was available in US for 2 years, faricimab. And I'm here to present a few of my limited experience, and thank you for listening to me. So this case 1 is a 60-year-old female with recurrent MNV. She had received ranibizumab earlier, then she stopped responding to it. I switched to aflibercept, again responded to the initial few, then stopped responding, then switched to brolucizumab, again responded to the first 2, didn't respond to the third. So this was the OCT when she responded very well to the brolucizumab, but then she presented recurrence, and after 8 weeks of the third brolucizumab, the OCT picture didn't change. And that's when I offered her faricimab. This was my first faricimab injection. You can see the date, it's January. And within a week, the patient came back with a big smile on her face, improved visual acuity, and OCT speaks for itself. Most of the fluid had gone down, and the counter had become almost flat. And at 2 weeks, you can see that there was no evidence of any previous pathology visible, apparently. And at 4 weeks, it became even better. So I usually don't follow a typical loading pattern. I follow a modified extended loading where I inject at generally 8 to 10 weeks. And this is a 1 week post the second dose faricimab where the OCT picture was maintained. And third dose I injected again at 8 weeks. And this is a 1 week follow-up. which is now patient just came few days back to me at 10 weeks, and even after the third dose, the OCT picture is maintained. Case 2 was a 55-year-old lady with a recurrent MNV. Her BCVA used to be good, fluctuating between 6.9 partial to 6.12. Similar story of receiving aflibercept earlier, switching to brolucizumab, not responding to the second brolucizumab. This is the OCT picture after 6 weeks of the second brolucizumab. I offered faricimab to her. You can see the picture at 2 weeks became flat, and the picture speaks for itself, nothing to say more. And I retrospectively went back to analyze the OCT angios, and like Anirudh said, I usually don't repeat OCT angios, but this was my biology teacher from school. So she was slightly a VIP for me because she was the one who had introduced me to this field, and I wanted to do a thorough checkup. And the initial pictures of OCT angio were stable. There was no branch vascular network visible. But when the disease started to recur, you can see, sorry, I don't have a pointer. Okay. So the BVN is started to visible in the outer chorial capillaries. This is a magnified view. That's when I injected faricimab. And you can see after a few weeks, when I received, repeated the OCT angio, the branch vascular network pattern started to regress. And at 8 weeks, you can see that regress pattern was still maintained. And at 16 weeks, though the collateral has started to increase, but the OCT picture was still stable, and the patient was reluctant in receiving another faricimab injection, though I wanted to inject at that time, but she wanted to wait more. And so I followed her very closely. Every week I used to call her, and it was at 20 weeks you can see that the fluid has appeared on the OCT, and the branch vascular network has also increased. That's when she got convinced for another dose of faricimab, and I just injected her last week. There's a case 3, a 50-year-old male with sudden diminution of vision, both eyes. I'd seen him in 2016 with bilateral fibrovascular PED picture, and at that time the convention was to give a combined PDT and anti-VEGF, which I did with good results in both the eyes. Then the patient was lost to follow-up, and he called me one fine day during COVID times that, "Doc, I'm having a recurrence in both the eyes and I'm not able to come to Delhi." So I asked one of my juniors from AIMS to inject him with ranibizumab, but the patient did not respond at all. Then luckily the lockdown, there was a loosening of the lockdown, the patient was able to come to Delhi, and I injected brolucizumab at that time to this patient, and the fluid had decreased. But he again presented with a severe recurrence after injecting brolucizumab second dose, which didn't respond to the brolucizumab. And you can see the pictures, the below picture is the pre and above is the post brolucizumab. The fluid continued to increase, and that's when I injected faricimab first in one eye to see the response. And immediately at 2 weeks, you can see the below picture is the pre and the above is the post. The thickening started to go down. The patient's visual acuity subjectively started to improve. And at 4 weeks, it started to subside on one side, and a gradual response was coming overall. And so the patient got convinced for injecting in the right eye also. And you can see the pre and post pictures, even that eye started to respond. Though the response is slow, but I'm sure, like Anirudh said, that we have to be patient with this molecule, have to keep injecting, and I'm sure the patient is going to respond. And this is at 8 weeks follow-up with the left eye, and I have injected the second dose at the 10th week. Case 4 is a 55-year-old lady. She had a left eye's MNV. BCVA was 6/18. And this was my first treatment naive faricimab. So nothing interesting, but I wanted to include here because this was my confidence became so much that I've now started giving in treatment naive patients also. Case 5 is a 50-year-old patient with macular telangiectasia with CNVM recurrent. Again, he had been a long-term follow-up with me. He used to receive ranibizumab initially, then switched to aflibercept. Somehow he was a CEO of a big company and was not willing to take even a 1% risk of intraocular inflammation. So I convinced him for brolucizumab, but he was not willing for it and wanted something else. So he used to present with a very small minimal hemorrhage and minimal fluid, and that's when I used to inject earlier. So this time when he presented with a fresh hemorrhage, I injected faricimab and he responded well. That hemorrhage disappeared. The OCTs are similar, but clinically the hemorrhage had gone away. I have few cases of center involving diabetic macular edema. These were cases of chronic DME. You can see that the OCT tells itself the above picture and the below picture. All the hyperreflective foci have disappeared. Especially earlier molecules, the HRF used to respond only in the outer segments. But here in the inner segments also, the HRFs have decreased, besides all the cystoid pockets and other OCT biomarkers going down. And these are the cases where they are more at risk of epiretinal membrane formation chronically. So I feel if we are more aggressive using faricimab in these kind of cases, the long-term implication of ERM formations will also go down. And this is another case of chronic DME. The hyperreflective foci have gone down. The spongiform thickening has disappeared. And this is a treatment-naive DME patient. He just came a month back to me, and this where I injected faricimab. And after first dose, after 4 weeks, there was not much of response, as Dr. Lalit said. So I injected faricimab at 6 weeks. And you can see after 2 weeks of the second dose is when the response has started to show on the OCT. And subjectively also the patient's vision has started to improve. I have included 2 more cases, though faricimab is approved for retinal venous occlusions in US, but I think in India it's still not approved. But it's in this kind of cases where you can see the wow effect of this molecule, and the pre and the post picture within 2 weeks you can see. You can see the date also, it's a magic response. And another case similar where the patient responded magically to faricimab of BRVO. So just to conclude, I like to say that this is an excellent molecule because of its 3D effect, where D stands for the dual pathway inhibition, faster drying and extended durability. At the same time, we are achieving these at having the safety profile being similar or better to other molecules. And the Roche company has come up with an excellent patient support program, the Blue Tree program, where the patient pays for 2, gets 5 injections. So in the long term, the socioeconomically also, the cost is at par with whatever other anti-VEGF molecules available with us. So I think this is the way forward, and we are quite lucky to have it with us and to give the best available option to the patient. Thank you.
Thank you, Dr. Nikhil. I think we'll not waste more time. I'll call Dr. Vikram for eyes on Vabysmo, interesting cases in NAMD and DME. And I think maybe we can take the questions later.
Yeah, good evening everyone again. So I'm just going to have just 2 cases, and why I feel they are interesting because they are a little deviating from the norm that we have right now with the drug. So Vabysmo, we all know that it's a dual pathway mechanism drug. So my first case is a chronic DME patient. So she's a 52-year-old female, known diabetic and hypertensive since 15 years, lasered PDR, post-VR surgery in right eye, and had received multiple injections in left eye as well. And she completed with diminution of vision in the left eye since 4 months. So this is her OCT. We can see the chronic nature of the disease. We can see those skytic spaces, very difficult to go. We can see hard exudates even below the, just under the fovea. So it's a very difficult case. My first line would have been an Ozurdex in this case, but the patient was very apprehensive with steroid injections, and so we went ahead with we discussed that there is a new drug called faricimab, and we went ahead with faricimab on 28th of Jan. This is when just earlier cases. So just after the first injection, we have this wow effect. So normally in DME, as we have seen that not many people are getting good responses, but just after first injection, we can see that's a great response. So to compare, it's really a wow effect. And I continue to follow up the patient. Again, I called her after a month. So again, the effect is good, and we can see the retinal architecture. It's completely normal. There is no cystic spaces. Hard exudates have resolved considerably. I called her again after 3 weeks because not sure when to inject, how to follow up the patient since it's a new drug. So she again came back after 3 weeks, but we still have a very beautiful OCT, near normal architecture. The interesting point here is to see at the IR image. So we can see the hard exudates. I think now we can have the consensus that it really works magical with hard exudates. So we can see just after 1 month, there is marked reduction in all the hemorrhages and all the hard exudates. What is again interesting here to see is If you look at these dilated segmental dilatation of these vessels, just after the first injection, we can see there is a drastic change in their appearance. So there is near normal appearance of those vessels. So, and this is, I think this is the Feb OCT, this is the Feb scan, and this is April. We can see the hard exudates are continually regressing. I have not injected her. I have just injected her on 28th of Jan. So now she comes back after in June. Her vision is still good. She's still 6'9", but now again the cystic spaces have come back. We again inject her on 12th of June. So again, second time also we get a great response. So it was not a one-time fluke. Again, the drug had a very good response. And if we compare the image, this is a January image and this is just 2 days ago. So we can see it's almost a near normal appearance of the retina, as if she never had diabetic retinopathy. So what interesting when I felt that it appears to improve vessel wall stability, possibly anti-Ang2 effect, which is really helping the vessels there. Near normal retinal architecture after just 1 month, which I did not expect at all. Marked resolution of hemorrhages and hard exudates that we have in this conference itself. We saw almost a lot of cases where it is really working well with hard exudates. And in this patient, I got a prolonged effect, nearly 20-week treatment-free interval. So case 2 is an exudative AMD patient. So she's a 68-year-old female, known case of AMD since 15 years. She has received multiple intravitreal injections, and she is someone who has received from Macugen to bevacizumab to Eylea. See, she has received everything. And they were very open also to the new drug. They were always very open. I discussed with them they've been with me since 1 year, and I had given them almost every 8 weekly she needs injection. I was giving aflibercept. And so we discussed that there is a new drug which is coming. So they were open to the idea that, okay, we'll go ahead with the new drug. So I injected her on 8th of Feb. So this is the OCT. We can see the large PVN. She had a PDT in the right eye, so she doesn't want any laser or any PDT procedure in the left eye. So left eye is still 612. So we gave the injection on 12th of Feb. So interesting point here is that after a month, she's not very happy. So normally she's very happy after aflibercept. She says my vision recurs back, and we can still see the SRF, but the PED height has markedly decreased. And she was always on 8 weekly interval. I could not ask her to, okay, let's have it again. But also with my experience with brolucizumab, I've seen with the stronger medicines, I have never injected brolucizumab before 8 weeks, because even after 4 weeks, if there is fluid, they keep on improving. So I expected the same will happen here. And so this is the comparison scan from after the first injection. This is 8th Feb and 15th March. So now this is 10th of May. I did not re-inject. There is almost again near normal architecture. We can see the PED height is completely almost, this is her main culprit PED and large BVN. So we can see that 15th of March and then 10th of May. So it's been almost, and we gave injections on 12th of Feb. So post 3 months also, the response was little slow, but it was persistent. We had a great response. So I again happened to see her just 3 days back again. And we can still see there is no SRF, but her PED height has again started to increase. So I have advised her injections, and we're going to plan it in the second week of August. So that will be roughly 6 months after her first injection. So interesting point is maybe the response is slightly delayed, but it is persistent. And although the norm right now is that we need loading dose, but I think this is a rare abnormality here. And I could achieve treatment-free interval for more than 20 weeks and beyond, which she had never had, and increase the treatment-free interval by nearly 12 weeks from previous anti-VEGF. So I was giving her at 8 weeks, and now I could extend it to almost 5 months. Thank you.
Thank you, Dr. Vikram. So, I mean, I think loading dose is something which we should discuss something here. It's a bigger molecule definitely, and we realize this, that it has been, it needs some time. It's not something which although we have a lot of cases, what Lalit sir also showed, and I think you also had some cases, even 4 weeks we had a very good resolution. But still it's a very big molecule, it's bigger than the other molecules, and it needs more time to come up, and I think loading dose will make a big difference.
Can we have Anirudh on the screen so that Vikram, maybe you can say.
Yes, yes.
So yeah, Anirudh, any observations from these presentations, because you were talking about loading doses, and the last presenter, Vikram said that first injection he had effect, and that continued effect after a couple of months also. And first injection in the first patient, he gave first injection in January, then in June. So these are two opposite views we are hearing.
So I think my take is that as far as possible, we try to load the patients. But there are special circumstances. I think the case that Dr. Vikram showed was a special case in the sense a very long follow-up of over 15 years, had been pre-treated with a lot of anti-VEGF agents already. And in such a patient where the primary aim is to extend, you may not go ahead with loading dose. But in most clinical situations where we encounter, I think we should try to load the patient, or at least call the patient and have an OCT done. Having said that, I would say that the bottom line is that you will get a response if you are persistent, and if you sort of maintain, try to stick or adhere to the protocol as much as possible. You will get a response in terms of vision as well as the anatomical improvement. The anatomical improvement, I think, with these newer agents, the second generation agents, like Sir said, I think this is the bottom line, and we are seeing many more. In fact, I think for a patient with even with a subretinal hemorrhage, which is limited to the macula because of PCV or because of AMD, I think monotherapy with anti-VEGF is now, I think, the standard of care. Not many of us would even go ahead with vitrectomy because we get such good results with anti-VEGF alone, especially the newer agents.
Anirudh, is your treatment protocol different in treatment naive patients and recalcitrant or resistant patient? Because a lot of patients we get is we shift, like a lot of people are saying, initially start with ranibizumab, then aflibercept, then brolucizumab, then finally faricimab. So whenever a patient comes to us, suppose there is a treatment naive, vis-a-vis a patient who has already received multiple injections, is the treatment protocol same or different with faricimab?
So what I try to do, sir, is for naive patient, I think things are more under my control. I try to stick to protocol, call the patient every 6 weeks for the first 3, and then I extend maybe to 8 weeks or beyond. I extend to 8 or 10 weeks depending on the response. This is in my treatment naive patients. So like I said, 6 weeks for the first 3 follow-ups, and then 8 or 10 week follow-up, and then I extend it even more. For a treatment resistant patient or the patient who has been previously treated, I may be wrong, but my personal, I don't try more than 2 injections of one agent, or maximum 3 injections. If it doesn't work, I shift, and I am beginning to shift more patients to faricimab directly. And when I shift, I try to at least give 1 injection, follow up very closely at 4 weeks. If there is fluid, I will inject and try to load the patient, but little closer follow up, because I want to identify patients if they have a response which is short-lived. Some patients, they have a short-lived response and they may require injection at 4 weeks. So I think it's very important to get the patient back early at 4 weeks. Maybe you do the second or third injection at 4 weeks, and that's when you will start to get the response. And the 4th or the 5th injection will be at a longer interval. So you have to pay a little more attention to this.
Anirudh, you showed one of your patients actually worsened from the baseline to a worse stage at injection 3 or
Yes.
4. So after 4 loading dose, you see a worsening from the baseline. So how do you convince yourself that the injection is working, or it's not the right time to switch? Like if I see worsening from the baseline, I'll think I need to switch to another molecule. So what made you to persist on the same molecule over a period of time, going for 4th and 5th injections?
Sir, usually if you get worsening after the first injection, then it is probably not going to work. But if you get a good response after 1 injection, and let's say after 3rd injection there is an increase in fluid, it still gives me confidence that he has responded in the past and he will respond. It is probably an outlier, and the OCT that you have today is not reflecting the course of the disease. So in such a situation, I think I'm still confident I will go ahead because I had the response the first and the second times.
And if you don't get any kind of response, even after 3 injections, you would like to switch?
No, I usually shift, sir. After 2 or 3 injections, if no response, if worsening, I shift immediately. If no response after 2 or 3 injections, I shift. I don't wait for, some people wait for 4 or 6 injections. I don't do that.
Anirudh, do you give 4 weekly loading doses or 6 weekly? Because and is there any like scheduling is different for DME patient versus AMD patient?
I think, sir, there are differences between DME and AMD. I have to go back to the protocol to look at it. But I generally call the patient at 6 weeks. 6 weeks is my cutoff. I think, and I try to sort of cheat. I try to ask the patient when it is convenient for them. So it may be 5 weeks, it may be 6 weeks or 7 weeks. So for example, if they are coming to the hospital for another, let's say, endo visit or a orthopedic visit, I try to bring them closer to that visit. So this ensures compliance, and I try to stay in that window of 6 weeks, around 6 weeks plus or minus 2 weeks.
Have you seen any patient not responding to faricimab and shifting to any other anti-VEGF drug?
Yes, absolutely. We have patients who have not responded to faricimab. Some of them have gone back to Eylea, and if there is a no response to faricimab, we had patients who were shifted to faricimab to experience durability. Some of them did not experience, and they have been shifted back on Eylea, and they respond better to Eylea. So that will be across the board. You will have agents which will not work. We have Eylea 8 milligram also now, but not all patients will respond. So you will have patients who will respond to some other molecules.
One thing I just wanted to know, in case we want to use faricimab in siliconal field eye, whether we need to use half dose or I've used actually. One patient of vitreous hemorrhage is seen. Full dose, sir?
And Neeraj, to answer your question regarding the trials, the Yosemite and Ryan used a more number of loading doses for DME patients vis-a-vis the Tenaya and Lucent, which was for the AMD. So 6 and 5, yeah, vis-a-vis 3 and 4 there. Yeah, and my thought is that I think faricimab can be a game changer in DME patients. My reasons for thinking this is that it comes from 3 aspects. One, obviously, amongst the anti-VEGFs, this has the best anti-inflammatory potential. That's the first thing. Secondly, it's been shown that amongst the anti-VEGFs, this faricimab has the maximum effectivity in terms of regression of microaneurysms. And there are studies to show that residual DME as well as recurrence of DME is because of the persistence of microaneurysms. So if we have an agent which can tackle the microaneurysms better, then probably we'll have a better response to follow.
Yeah, the same thing. The lipid deposit resolution is related to vessel stability plus I think this stoppage of microaneurysm.
Yeah. And the last thing is about parasites. So even that applies. We know faricimab protects parasites and allows the parasites to come back. In that aspect also is more relevant to DME than an PCV or an AMD. So these 3 reasons.
Carrying on from this question, as well as Anirudh, you showed one slide, excellent resolution of hard exudates, and Saurav also showed one slide. So I was just wondering whether like we normally shift from anti-VEGF to Ozurdex, or patients who have more of hard exudate, think of inflammatory component. So what Arnav was saying, is faricimab going to replace Ozurdex or maybe give a tough time to Ozurdex patients who have a lot of hard exudates?
Personally, I think with faricimab coming in, I think dexamethasone implant has suffered a setback because I tend to use, I mean, not me alone, but I think most of us, we tend to use newer anti-VEGF. Shifting from one anti-VEGF to another anti-VEGF has become very common. Before, we used to immediately shift to steroid. Now, I think we have so many options.
Especially in phakic patients. Especially in phakic patients.
Phakic. Also, I think dependence on focal laser. I said that also before. I think I've really reduced doing focal laser. In fact, even doing fluorescein angiography, the indication has really reduced. Very hardly we have patients where we need to do fluorescein.
So I have
any other question?
I have a question.
Actually, we all know about the effect in PDR in DME and neovascular AMD. My thing would be, has anyone tried it in PDR cases? For example, like we had protocol S, and the problem was the high number of injections.
Not with us. We'll ask Anirudh.
Yeah, Anirudh,
because
if he has any experience.
Our confidence is just started
PDR.
to build up. Anirudh, any experience?
Yeah, I mean, for DME it works very well. Faricimab will work just
PDR.
like in
Vitreous hemorrhage in PDR, Anirudh.
Proliferative.
vitreous hemorrhage. I mean, if you are operating the patient, like pre-operative, you mean?
No, he's asking PDR, not vitreous hemorrhage, only PDR. PDR.
See, protocol S is nonsense according to me. So I think we have to do PRP. There is no doubt about it. Anti-VEGF monotherapy doesn't really work. But for PDR, for DME response, faricimab will have similar response like NPDR. The DME will respond. But the PDR has to be tackled by laser. There is no doubt about it.
I am actually very happy to hear this word that protocol S is nonsense, which I didn't have the courage to speak like that. But Anirudh, I have one of my slide. I'll put these words from you in that slide. Yeah, PDR.
No, but sometimes after PRP and you see that it's not regressing.
So, I mean, we are just talking about only injectables for PDR. I mean, that's what. I mean, nobody is going to follow that, I think.
So I think we have had some very nice discussion in this last session again. So new drug, new observations, and a lot of new game changers. People have used this term. But believe me, the key line take home for everybody is that persist and give time. And like Saurav was saying, it's a bigger molecule. Whatever, load these patients, what Anirudh said, load these patients and you will get good response. Because initially our patients, we got worried actually, because first injection we were not getting civilian DME, and a lot of people are doing like this, that no response coming, and I used to call Arun and everybody. So then Arun said, no sir, you have to persist. The problem is with the patient. Believe me, patient wants a response. And if he is spending, even if it is 1+1 free, then also he is asking, sir, wo 78,000 bhi laga, response abhi tak nahi aaya. So that is the concern practically. But with the kind of slides I think all of you have shown, and Anirudh also has shown, so you have to spend a lot of time in counseling these patients. Counseling is very, very important. So that patient adheres to the regime, follows this loading dose, and then we get a good response. No, Anirudh?
Absolutely. I think talking is the most difficult part, talking to the patients and explaining all what we are discussing.
So I think we thank Anirudh, and all of us have become wiser after listening to your talk, and very nice pictures of OCT and photograph, and especially the IR images was another good take home, that once you see IR comparative images, they, you were also showing those images, very nice take home. So thanks Anirudh. And hopefully we'll see you more often and physically also. Thank you so much.
Yes,
so with this, I think we conclude the day-long marathon session we had, and I appreciate all of you who had time to stick till the end, and also want to thank all the sponsors for helping me conduct this session, and all the chairpersons for waiting till the last moment. So thanks Saurav, Neeraj and Ruchir, and for this excellent session. Thank you so much. So all of you are invited for dinner outside only, along with fellowships. Please stay and have dinner. And thanks to the audiovisual team also for flawless conduction, and they were very, very good and receptive, and in fact the internet connection also was very, very good. And also thanks to Mr. Naresh and other people who cooperated, and the team of IHC who did a fantastic job. And my own team deserves a lot of applause, because they have been here since morning. So 3 cheers for my team led by Kirpal, Rana and Sajid. Must appreciate this.